Proceed?
Yes.
Okay. So good afternoon, everyone. I welcome you all in this part of the session. So today we have some quick bites for you. We'll be dealing with 3 topics. To chair the session, I have Dr. Rahul Taparia from Siliguri with us and Dr. Shubhajyoti Ghosh from Dibrugarh. To start with, initially we have Dr. Arjun Vaidya from Calcutta, who will be dealing about the role of sitagliptin in type 2 diabetes patients. So we have been using sitagliptin or in fact other DPP-4 inhibitors for quite some time now. And probably it was the first time when this was launched, the first DPP-4 which was launched. And till date, it stands well, strongly, and we all are prescribing it left and right. We know that sitagliptin is a molecule which is backed by largest number of trials around the world. And we have plenty of evidence regarding its efficacy, regarding its various other pleiotropic benefits. So of late, there have been many studies which shows that there are a large number of pleiotropic benefits like anti-apoptotic properties, like anti-inflammatory properties. So all these properties, now we can use it quite well for our type 2 diabetes patients. And there are several studies also now to have a fixed drug combination right at the beginning of the disease so as to bring the sugars under control as early as possible. So I request Dr. Arjun Vaidya to deliver his lecture and let us see how we can justify. Dr. Arjun Vaidya, please.
So good afternoon, everyone. I welcome everyone to this DICARE conference. And today's program is on the theme with assessing improving diabetes care. So with this, we know that sitagliptin have got off patent, and we got one of the best speaker to speak on the sitagliptin. It will be none other than our own Dr. Arjun Vaidya, sir. He is MD DM, and he's also associate professor, Department of Endocrinology. Then he's also fellow of American College of Endocrinology, and he has got a lot of presentations and have 41 publications. And he also a principal and a co-investigator of various research clinical trials. He's also the faculty of National Diabetes Education Program with 25 years of clinical experience and 14 years of teaching experience. So, sir, please enlighten us with the role of sitagliptin in our type 2 diabetic patient. Over to you, sir.
Thank you, Dr. Shobhasachi and Dr. Chakraborty, for your kind introduction and nice context setting. So let me share my slide. Slide is visible?
Yeah, it's please go ahead.
So over next 15 or 20 minutes, I'll be discussing the role of sitagliptin in patients of type 2 diabetes mellitus. This is the best approach. So I will discuss an hypothetical case, though it is a hypothetical case, but I would believe that like me, you do also face these sort of cases in your day-to-day clinical practice. So this is a newly detected type 2 diabetes mellitus patient, 42-year-old male, detected during an annual health checkup. He is a software engineer and he is following sedentary lifestyle, but normotensive and non-smoker and non-alcoholic. So with regards to his clinical finding, he had nothing abnormality in his clinical finding, but biochemically, obviously, he has hyperglycemia, fasting plasma glucose, postprandial, as well as HbA1c was high. HbA1c was 9.1%. So what should be the management protocol for this patient. So definitely there are many options for managing type 2 diabetes mellitus in a newly detected type 2 diabetes mellitus. So unless and until it is contraindicated, we should always start with metformin. But if in some situations, like if there is established atherosclerotic cardiovascular disease or diabetic kidney disease or heart failure, we need to choose between GLP-1 receptor agonist and SGLT2 inhibitor. But in otherwise, we have many other oral options. As I have mentioned, metformin. After that, we have sulfonylureas, we have DPP4 inhibitor, and obviously SGLT2 inhibitor, and also glitazone, AGI. So, what to choose? Should we start with metformin? Should we start with fixed dose combinations of metformin or with SGLT2 inhibitor or DPP4 inhibitor? Or should we start with DPP4 inhibitor alone, or should we start with SGLT2 inhibitor alone for this patient? So we need to individualize. So our management goal should be long-term durability of glycemic control in a newly detected type 2 diabetes mellitus patient who is otherwise healthy, not having other comorbidities like hypertension, dyslipidemia, or obesity. So our primary goal is to have durable glycemic control, but it is not easy to achieve target glycemic goal always, particularly in Indian scenarios. And we know that glycemic control is very poor in Indian diabetic subjects with a mean HbA1c of approximately 8.9%. And in a study by Dr. Mohan and et al., which was published in 2014, it was seen only 19.7% of Indian diabetic patients, they achieved their target HbA1c goal of less than 7%. And in another global study, it was seen that 47% of patients do not achieve the glycemic target even after dual or triple drug therapy. So it is not very easy to achieve the target glycemic goal or otherwise. And that is our experience also says the same thing. The clinical practice, we have seen many cases that they are not under control. So monotherapy very often fails to achieve the target glycemic control. This is also experienced in these studies. It was seen that after a period of 5 years, the rosiglitazone failed in 15% of patients and metformin failed in 21% of patients, and glyburate, which is a very potent sulfonylurea insulin secretagogue, which failed in 34% of cases. This is because of its insulin dependent or insulin secretory mechanism of action, because we know type 2 diabetes is a progressive disease and there is always progression of beta cell loss because of apoptosis of beta cell. So that's why the sulfonylurea failed and faster. So monotherapy is not always adequate to achieve the glycemic control that is reflected in these studies. So in another studies, which was a retrospective analysis from UK Clinical Practice Research Data Link database, which includes more than 93,000 patients, it was seen that depending on the time when the treatment was intensified, it was classified that into 3 categories: early intensification, intermediate intensification, and late intensification. Where early intensification, the patients are intensified in a period of less than 1 year, and in case of intermediate intensification, treatment was intensified between 12 to 24 months, and in case of late intensification, treatment intensified between 24 to 36 months. So it was seen in that studies, likelihood of attaining glycemic control was 22% and 28% lower for patients in the intermediate and late intensification group respectively, compared to intensifying early, and it was significant. So durability of glycemic control is very easy to talk, but it is very difficult to achieve. So that is because the type 2 diabetes mellitus is a progressive disease, and there is always decline in beta cell function, and clinical inertia are also another important roadblocks in achieving this target glycemic goal. But we need to at least try to achieve the durable glycemic control for initial few years, so that we can maintain and achieve the near normal glycemic goal and can prevent long-term microvascular and macrovascular complications. So guideline also suggests the same thing, that if the initial blood glucose level or HbA1c level is very high, Say, for example, according to the ADA, if the HbA1c is more than 9%, and according to the AAC and AAC guideline, if the entry HbA1c is more or equal to 7.5%, we should always start with dual therapy or combinations therapy in a drug-naive patients. So now let us have a look on the efficacy and safety of sitagliptin in comparison to other therapies. So in a study of 24 weeks period, it was seen that in a patient's population, so the baseline HbA1c was more than 7.2%. Sitagliptin reduced HbA1c of 0.43 percentage point, and metformin reduced 0.57 percentage point. And in another subgroup where the baseline HbA1c was more or equal to 8%, sitagliptin reduced HbA1c by 1.13%, and metformin reduced HbA1c by 1.24%. And HbA1c goal of less than 7% and 6.5% was achieved in 69% and 34% patients with sitagliptin respectively, and 76% and 39% patients with metformin only. And there was also body weight reduction in both the arms. So, and in the same study, it was seen that the incidence of hypoglycemia was very less, 1.7% with sitagliptin and 3.3% with metformin. And incidence of gastrointestinal related adverse events was also very less with sitagliptin compared to metformin. And this is primarily because of significantly decreased incidence of diarrhea and nausea with sitagliptin. So sitagliptin was found to be non-inferior to metformin in improving HbA1c in treatment-naive type 2 diabetes mellitus patients, which was generally well tolerated with a lower incidence of GI-related adverse effects. Now coming to the comparison between sitagliptin and metformin in a patient who is type 2 diabetes mellitus uncontrolled with metformin. So in a study at the end of 30 weeks, it was seen that 52% and 60% of patients were with an HbA1c level less than 7%, which was the target in the sitagliptin and glimepiride group respectively. And mean change in HbA1c was 0.47% with sitagliptin and 0.54% with glimepiride. And as we know that glimepiride is a very potent insulin signal, that's why there was better HbA1c reduction, but the difference was not significant. And with regards to fasting plasma glucose change, fasting plasma glucose was reduced by 0.8 millimole with sitagliptin and 1 millimole per liter with glimepiride. And sitagliptin was also associated with a mean weight loss, whereas glimepiride was associated with a mean weight gain of 1.2 kg. So in the same study, it was also seen the hypoglycemia was reported in 7% patients with sitagliptin and 22% of patients with glimepiride. So addition of sitagliptin to ongoing metformin monotherapy provided similar HbA1c lowering efficacy after 30 weeks of treatment compared with the addition of glimepiride with a substantially lower rate of hypoglycemic events. Now coming to sitagliptin with metformin efficacy in patients with type 2 diabetes mellitus uncontrolled with metformin. At the end of 24 weeks, it was seen that the HbA1c reduction with sitagliptin was 0.67 percentage point, and in the placebo arm, it was 0.02 percentage point. And with regards to fasting plasma glucose change over a period of 24 weeks, fasting plasma glucose was reduced with the sitagliptin by 0.9 millimole per liter. So there was no increased risk of hypoglycemia and gastrointestinal adverse events also with sitagliptin compared to placebo in this study, and body weight decreased similarly with sitagliptin and placebo. And sitagliptin 100 mg once daily added to the ongoing metformin therapy in this study was effective and safe in patients with type 2 diabetes mellitus who have been inadequately controlled with metformin. Now coming to the efficacy of sitagliptin metformin fixed dose combinations versus metformin in treatment-naive type 2 diabetes mellitus patients after a period of 18 weeks. You can see that there was significant reduction of HbA1c over the period of 18 weeks with the sitagliptin metformin fixed dose combinations versus metformin, and between group difference was 0.6 percentage point. And in the sitagliptin metformin fixed dose combination, there is a reduction of 2.4% of HbA1c. And as we know that higher the baseline HbA1c, more is the HbA1c reduction efficacy with any molecule. So that was similarly seen in that study in the subgroup of patients where the median HbA1c was more than 9.7 percentage point, there was a maximum reduction of HbA1c of 3.2 percentage point. And in the same study, body weight change from baseline was 1.6 kg in both the arm, and both treatment was generally well tolerated with a low and similar incidence of hypoglycemia, but abdominal pain and diarrhea occurred significantly less with sitagliptin and metformin fixed dose combination. So compared with metformin monotherapy alone, initial treatment with sitagliptin metformin fixed dose combinations provided superior glycemic improvement with a similar degree of weight loss and lower incidence of abdominal pain and diarrhea. Now coming to the subgroup analysis from the same study, you can see that in the subgroup of patients where the baseline HbA1c was more than 7.5% to less than 9%, in that subgroup, 69.4% of patients, they achieved the target HbA1c level of less than 7%. And also, as I have mentioned that higher the baseline HbA1c, higher, more is the HbA1c lowering efficacy. That was also justified in that study that in patient subgroup where the baseline HbA1c is more than 19%, there was highest HbA1c reduction by 3.6 percentage point. So the greatest mean HbA1c reduction, 3.6%, occur in the sitagliptin metformin fixed dose combination treatment group of patients in the baseline HbA1c of subgroup of more or equal to 11%. So in type 2 diabetic mellitus patients with a baseline HbA1c of more than 7.5%, but less than 9%, substantially more number of patients achieved the HbA1c goal of less or equal to 6.5% with initial dual therapy than with initial monotherapy, that is metformin. Now coming to the durability of glycemic reduction, benefit of sitagliptin in this respect. So this is a study where you can see in PRESS and O2 study, that is persistent sitagliptin treatment and outcome study, long-term results after 5 years. So there was sustained reduction of HbA1c over a period of 72 months, and the maximum reduction was initial maximum reduction was after 4 to 6 months, and that persisted till 5 years with the sitagliptin compared to no sitagliptin. So coming back to the case, this patient was started on dual therapy of metformin 1000 milligram and sitagliptin 100 milligram. So as guided by the guideline, the patient was advised for follow-up visit after 3 months. So the patient's blood glucose came down to fasting 118 pp 158, HbA1c 7.2 percentage point, and blood pressure was normal. So patient was advised to continue the same medications, that is metformin 1000 milligram and sitagliptin 100 milligram. So the patient was also advised to follow up every 3 months. So after 6 months, now blood glucose is normal, fasting 92, postprandial 110, and HbA1c 6.3% patient, which is the desired target for this patient, because this is a newly detected young type 2 diabetes mellitus having no other comorbidities. So the our target is stringent for these patients, which is less than 6.5%. So the patient was advised to continue same medications, that is sitagliptin metformin fixed dose combinations, and patient was advised to follow up every 3 months. So my conclusion, extensive clinical trial and real world data, which was also mentioned by the chairperson sir, that has firmly established the glycemic efficacy of sitagliptin as monotherapy, as initial combination therapy, and also as an add-on therapy with other OHA in adult patients with type 2 diabetes mellitus patients. And sitagliptin is generally well tolerated, with most adverse events being of mild to moderate intensity, particularly about the upper GI side effect like nausea, abdominal pain, and which is seen relatively few patients who discontinue treatment because of these events. And according to the guideline, if there is no established atherosclerotic cardiovascular disease or heart failure or CKD, and there is a compelling need to maintain the body weight, there is a compelling need to avoid hypoglycemia, then we can choose this class of drug, that is DB4 inhibitor, among the other classes like SGLT2 inhibitor and also GLP-1 receptor agonist. So definitely there is a scope for this molecule in management of type 2 diabetes mellitus, particularly in a patient who is newly detected and having no other complications So even if there is any complications like established atherosclerotic cardiovascular disease or diabetic kidney disease or heart failure, but GLP-1 receptor agonist or SGLT receptor inhibitor is contraindicated or intolerated by the patients, then there is a scope for using this molecule, that is DB4 inhibitor. So with these, I would like to stop here.
Thank you very much, Dr. Arjun Vaidya, for excellent deliberation regarding the sitagliptin and its use. What we learned that there is a grossly inadequate control which is going on everywhere in India and abroad everywhere, and monotherapy is not adequate. One of the slides you mentioned that the dual therapy needs to be done after 9 HbA1c, which is just showing in contrast with the AAC showing 7.5. Would you like to comment on that? Because 9% dual therapy is too high.
We can have the discussion at the end of the program, sir, or else time won't permit us.
Okay, fine. All right. Okay. So we proceed for the next lecture. I request Dr. Subhajyoti Ghosh to introduce the speaker, Dr. Ashish Dengra.
It was a wonderful talk from our Dr. Arun Vaidya, sir. So may I request Dr. Rahul Taparia to introduce our colleague, Dr. Ashish Dengra.
Thank you. Good afternoon, everyone. So it's a privileged part to attend this session, and I'd like to invite Dr. Ashish Dengra, sir. He doesn't need any kind of introduction, but still I'll give a brief introduction. He's a director of Mahi Diabetes Thyroid Care and Research Center of Jabalpur. He has received a various certification course in the field of diabetes and thyroid and diabetic food management. He has been an organizing secretary of Jabalpur Diabetes Update, Jabalpur Thyroid Update, and he has been a president in API, president in Jabalpur Endocrine Society. He has been vice president in RSSDI MP chapter. He has received various awards as RSSDI Fellowship Award in the year 2020. He has received Best Diabetes Awareness Initiative Award in 2014, Best State of Award Art Diabetes Food Clinic, and he has presented various papers in various national and international journals. So he'll be talking on how to manage diabetes in juvenile and young diabetes patient, a case-based approach. Over to you, sir.
Thank you, Rahul. And at the outset, I would like to thank Spansi Bhai to invite me here to deliver an important talk on the management of diabetes in juvenile and young diabetic patients, which is very close to my heart. And to begin with, I will go through the management of diabetes through the case-based approach. And in this journey, we will be going through the various cases, and you will learn that how to diagnose in your clinic without any investigations if you are not having the high-end laboratories or patient is not affording. So through the 5 cases, I will take you through the journey of managing the juvenile and young diabetics coming to your clinics. So case 1, 10-year-old girl, typical presentation of polyuria, polydipsia, abdominal pain, tiredness, weight loss, burning micturition, HbA1c is very high, 10%. No family history of diabetes. On examination, she was having BMI of 12.5, no markers of insulin resistance, but dehydration was gross. So what investigations you will do next, my dear friend? Definitely we will go for fasting, PP, ketones. This is a typical case. So ketones were positive, and she was undergone the C-peptide level, which were very low, 0.2 picomole, and normal values more than 0.9, and depends upon the laboratory. So the patient was having absent beta cell function, and then GAD antibody was done, it was positive. So this is a typical case of type 1 diabetes with ketosis or ketoacidosis, whichever report shows. So to begin with, we
Ashish, your slides are not moving.
Ashish, sir, your slides are
not moving.
Oh,
so please make it full screen, sir.
I will reshare. See now?
Yeah, now it's fine.
Yes, sir.
It's moving.
So we have discussed the 10-year-old girl coming with typical complaints of dehydration and no family history. BMI was very low and ketone was positive. So she was having GAD antibody positive and C-peptide was very low, and she was diagnosed with type 1 diabetes and with ketosis. So this is a typical case which we follow in our clinics. But what mistake we are doing, we are labeling every young patient with type 1 diabetes and insulin is being started. So she was managed on proper hydration, insulin infusion, and gradually the ketones were taken away, and then the patient was shifted to subcutaneous multiple injections, and her A1C came down to 7.4 in next visit. And we know that insulin antibodies are very sensitive, whether they are GAD, IA2, or insulin antibodies. Why we require this dictum that we are having a positivity or not? That in the environmentally patient who are prone for type 1 diabetes, autoimmune reaction leads to immune dysfunction, and ultimately they develop the beta cell dysfunction. Even the type 1 diabetes goes through the phase of pre-diabetes, that is immunological abnormalities are prevailing at that time. Ultimately, the patient goes into the clinical diabetes, but a few weeks or months of good news is there that they don't require insulin, that is the honeymoon period, and then the chronic phase goes down. So this was a typical case which we follow. Now the case to 13-year-old girl, again the young girl coming to your clinic with 8 months history of diabetes, BMI is 29. She was started directly on multiple doses of insulin injections, but still she is not controlled. And still she is not controlled, but sugars are high, HbA1c is 9.2%. On taking the family history and ketone was absent, and she was having a strong family history in her parents. So again, the young girl, but here the BMI is high. So what you will suspect? As we see, she was also started on insulin because of her age. So we did a pedigree chart. This is a patient, mother, father is diabetic, and in their maternal paternal part also some of the parents were diabetic. So the BMI is high and all the other parameters are normal, but the acanthosis is positive on her neck. So the signs of insulin resistance were positive. Beta cell function was done by C-peptide. It was 1.3. She was showing preserved beta cell function. The antibody was negative. So what is your diagnosis in this patient? So my dear friend, it is early onset type 2 diabetes. Due to the obesity, we are seeing these cases in our clinic every weekly. Because of the COVID, they have not done any activities and the obesity has gone up in the young age and they are developing type 2 diabetes. So patient was managed on diet, exercise, insulin was withdrawn, added on metformin, glimepiride, but she was going into hypos. So glimepiride was withdrawn and ultimately she was well controlled on metformin alone. So suspect a type 2 diabetic patient in any young patient also who is having strong family history of diabetes, obesity, acanthosis nigricans, signs of insulin resistance, and a fair to good beta cell function should be proven to start the metformin therapy. So moving on to the third case, that's again a young girl. Since the age of 13 years, she was having diabetes. She was again put on basal bolus therapy and presented with recurrent UTI and vaginitis. She had a strong family history of diabetes on the maternal side. Mother, Nani, Mossy, and elder sister all are having diabetes. So what is the clue here? Again, the 16-year-old girl coming to your clinic, young girl, started on basal bolus therapy. Please take the proper history. What should be your next diagnosis? History is very important. Pedigree charting. Here, this is the patient. Patient's sister is diabetic. Mother is diabetic. Mother's mother and sisters are diabetic. So the maternal side, pedigree chart showing the strong family history of diabetes. The BMI of this patient is 20. Other investigations are normal. What next you will advise to her? So my dear friend, the C-peptide was seen. It was normal. Fairly good beta cell function was seen in this patient and no pancreatic calcification was seen in the abdominal X-ray. So this is a case of monogenic diabetes with history of 3 generations of positive family history in the maternal side. How you will diagnose whether it is a moody or early type 2 diabetes or type 1 diabetes. So moody patients are usually non-obese, acanthosis is not seen, 3 generation positivity will be seen, and only secretory defect is there, no insulin resistance, and better response to sulfonylurea. In contrast, the type 2 diabetic patients are obese, they are having signs of acanthosis nigricans, they are having signs of both insulin secretion and resistance, and there is high prevalence in India and response better to metformin. So this is a case which we are discussing. On the third case is moody. maturity onset diabetes of young. It is a monogenic form of diabetes. Genetic testing is required. And the most common form is the HNF1 alpha gene MODY3 was seen in this patient. Genetic screening is needed, which is very rarely available. And she was previously on basal bolus therapy, but shifted to glimepiride metformin. From HbA1c 11.9, it came down to 7 in 2 to 3 years. And she was continued on glimepiride or glibenclamide only. So the features are typical. This you have to take care in your mind when you are dealing with a young diabetic. Please take the proper history, proper pedigree charting should be made. The Terrestrial-Fajans clinical features for Moody is mutation in a single gene, non-obese, less than 25 years. Generations, 3 generations are seen, autosomal dominantly inherited, no ketosis. The treatment is usually not required in the mild fasting hyperglycemia Moody 2, and they do not need insulin initially, but later they may require. So there are Moody 5 is a syndromic part with renal cysteinogenesis syndrome, Arquette syndrome. So these are the various Moody types, which we can see 1, 5, 4, 6, 3, 2, and 11. So these are the basic Moody, and HNF1 alpha Moody 3 is the most common. This is a GCK, glucokinase mutation. It does not have any microvascular complications, so they don't require any treatment. So my dear friend, the third case was a Moody. You have to be vigilant for the pedigree charting. The case 4, again a 20-year-old boy detected to have diabetes since 6 months. He is having severe weight loss since 1 year of 10 kg, abdominal pain, oily stools. He comes to your clinic with sugars of 345 postprandial, A1C of 12.8. You are worried. You think that it is a type 1 diabetic and or type 2 diabetic you have to diagnose, but it is a 20-year-old. But in the village, he was taking the OHS triple drug combination, but still he was on 12.8 A1C. What should we do or what should we think? So my dear friend, in this patient, ketone was absent, C-peptide was borderline low, poor beta cell function was there, and BMI was very less. So what is the next step to diagnose this patient? We have done abdominal X-ray. It showed large multiple pancreatic calculi at the T12L1 level, and he was diagnosed with FCPD, fibrocalcific pancreatic diabetes. He was started on basal bolus therapy. Pancreatic enzymes were given. A1C came down to 7.8 in 3 months. His weight gained gradually. This is a typical patient who is seen in the pancreatic diabetes in the central part, certain parts of India. And this is the picture which we are seeing. And the patients are having from the tropical country. Evidence of chronic pancreatitis should be present, like calculi, recurrent abdominal pain since childhood, steatorrhea, abnormal pancreatic function test. But the other causes of chronic pancreatitis should be ruled out, that is alcoholism and hepatobiliary diseases. So why it is important to diagnose, my dear friend? Because we can give him a second life. He will be feeling happy, and his quality of life will improve with basal bolus or any other insulin therapy. The plain X-ray shows multiple pancreatic calculi, you can see here, and it is mostly found in Kerala and Tamil Nadu states. Etiology is still unknown. Why we should be vigilant? Because it can cause pancreatic carcinoma. So this was a 4th case of FCPD, again young guy, now 32-year-old male presenting with 3 Ps, A1C is high, acanthosis is present, GAD antibody is present, islet cell antibody is present. My dear friends, now we are confused. Type 1 and type 2, both pictures are coming in the same patient. So what you will think? So this is a case of LADA mixture of type 1 and type 2. That's why it is known as latent autoimmune diabetes of adult, or 1.5 positive for at least one of the autoantibodies associated with type 1 diabetes. Age of onset, but you have to think it is mostly above 30 years. They are usually free from insulin for the first 6 months, 2 years, but they gradually require insulin because they have the poor beta cell function. So this is a phenotypic type 2, but genetically or immunologically, it is type 1. So phenotypically type 2 and immunologically type 1 is known as LADA or 1.5 or hybrid diabetes or double diabetes. Many names are there. So it is a hybrid of type 1 genetically and type 2 phenotypically. You can see the acanthosis in this patient. Initially, patient of LADA are controlled on metformin or sulfonylurea may be added, but gradually they require insulin as the beta cell reserve is low. So this is a simple chart which you should keep in your clinic, and the patient young coming to your clinic, and for family, you have to take the family history, and if it is positive or if the ketone is negative, you have to follow the two things. First, you take the history of diabetes. If they are positive in the 3 generations, the ketonuria, if it is positive in the 3 generation, ketone will be absent, no acanthosis will be seen. So this is moody. If the 3 generation history is negative and the patient is obese or having the signs of insulin resistance, C-peptide is good. It is early onset type 2 diabetes due to obesity. Moving on the right side, if the ketone is negative or positive, if the ketone is positive, you have to think of type 1 diabetes. The C-peptide should be done. It will show absent C-peptide or less. And autoantibody negative is known as idiopathic type 1. Autoantibody positive type 1 is known as autoimmune type 1 diabetes. So ketone positive, definitely our mind goes towards type 1 diabetes. If it is negative and you do the C-peptide, it is poor reserve, go for abdominal X-ray, take the patient's history of recurrent stools, oily stools, abdominal pain. You think of the X-ray and it is showing the pancreatic calculi, it is FCPD. So this simple chart you should keep in your clinic and diagnose your patients easily in your clinic, whether it is type 1, type 2, moody, LADA. So my dear friend, we have discussed this is a 9-year-old, 12-year-old, 15, 20, 32-year-old, and all were having the high A1C. So this was a type 1, this is a type 2, this is a moody, FCPD, and LADA. So in the nutshell, what we have learned today from the typical type 1 diabetic to the LADA patient, that don't fix your gauge to the type 1 diabetic only. In young population, you can have moody patients or LADA patients, or nowadays we are facing with the obese youngsters at 12 to 13 years, I am having type 2 diabetic patients in my clinic. So think of out of the box of type 1 diabetes, follow the protocol, take the proper history of family, make the pedigree chart, and go for the basic test first. You can diagnose these young and juvenile diabetics with proper and in the right direction to give them the right treatment. Thank you. Thanks a lot for patient hearing.
Yeah, thank you very much, Dr. Ashish. I think the question answer will be later on. So we proceed for the third lecture.
Thank you very much.
Yeah, I request Dr. Rahul to introduce Dr. Anjali Bhatt.
So moving on the third session of this. I'd like to invite Dr. Anjali ma'am, and she is a founder and chief consultant of the Endo Clinic Pune. She has done her MD in medicine from Mahatma Gandhi Institute of Medical Sciences, Wardha. She has contributed for many publications in journals as well as books and invited for many talks in the conferences. She has been visiting consultant at Symbiosis Medical College for Women and Symbiosis University Hospital. So for the today's topic, she'll be discussing on genetic in health and disease, how modifiable are non-modifiable factors. Over to you, ma'am.
Thank you so much, Chairperson, for the kind introduction. And thank you so much, Bansi sir, for having me here to talk on this topic, which I am getting interested in a lot in the recent times. And this is what I thought I should share with all of you as to what is happening with the approach towards management of chronic diseases like diabetes. So we have, I'm sure we have been talking about diabetes as well as the chronic illnesses that come along with diabetes, that is coronary artery disease, which finally affect the quality as well as the longevity. And apart from monitoring and treating hyperglycemia, we are in process of understanding these disorders more. We know that there is a very strong genetic background to diabetes. We know there are monogenic diabetes, like Dr. Ashish mentioned just before this talk. So these are purely genetic transmissions. But apart from that, what we're talking about is type 2 diabetes. And we know that the genetic background of type 2 diabetes is very complicated. We cannot pinpoint to one particular gene, so we cannot pinpoint our treatment to a particular pathway or a genetic modification as a treatment for type 2 diabetes. Again, the disease is at such an endemic proportion that we will not be able to manage it by looking at the gene or modification of the gene. So our main treatment comes to treatment of hyperglycemia. And again, I think if you have listened to the previous two lectures, we are seeing that more than 50% of our patients with diabetes do not reach to their target level. So there is something grossly missing in the way that we are managing this disease. And I think we need to look into detailed aspects of the pathophysiology and causation of the disease apart from just treating the hyperglycemia. So I would like to share my thoughts on how our thinking about genetics in health and disease is changing and how the factors that were considered non-modifiable earlier are coming into the modifiable factors list. And unless we try to learn them, I think we'll get back behind in the way the future is changing in treatment of these disorders. So I would like to talk about how understanding about genetics is changing, how we are understanding these transmissions in a newer way. What are the windows of opportunity to peep in and intervene so that we change the course of the disease in one as well as more than one generations and more than one individuals? And then how does it matter in our clinical practice? Is it just a theoretical topic or topic for research? And when it comes to the clinical treatment, sitting in front of a patient in the clinic, does all this information matter to us or not? So coming to the first point, understanding genetics in a better way. There was a society called Fetal Origin of Health and Disorders. We know it as a very famous Barker's hypothesis. Dr. Yagnik sir from Pune has contributed a lot to this topic, where they thought that the exposure of the fetus in the mother's womb of various environmental factors will decide how the individual's health and propensity to disease in future long-term health will be affected. Now it was changed to developmental origin of health and disorders. So it is not only those 9 months in the mother's womb, but also certain important stages throughout the patient's or individual's life that can get modified by environmental exposures. And we are here not only trying to see the influence on an individual and not for a shorter period of time. Throughout the life, the developmental origins of health and disorders can be affected, can be modified favorably as well as non-favorably. And it is not only the individual, but a generation to come can change because of such exposures. So earlier this was thought to be non-modifiable, but now many of the factors are coming in the list of modifiable factors. Now, looking at the role of genes in chronic health and disorders, if you're talking about a disease which is such at an endemic proportion, I think we need to talk it at the basic level. So the gene, as we know, as a DNA strand, the similarity of genes between a man and a chimpanzee is 98%, and one human to another human is 99.9%. So there is definitely very little to understand by studying the genes, because we know that we are nothing like chimpanzee, and one human being doesn't behave in terms of health and diseases, for that matter, even type 2 diabetes. One individual is nothing like the other individual when it comes to the disease and health. So if it is not genes, then what is it that is giving an influence through the genetic transfer? So the genetic transfer has three components. One is genome, that we have seen the pool of genes, DNA sequences. Second is an epigenome, which are the proteins that cover the genetic strands, which are modifiable, which decide how a genetic profile will get expressed. And these are modifiable. And what can modify epigenomic expressions are called exposomes. Now, these exposomes can have anything which is specific to an individual, specific to an external environment, specific to an internal environment, or a general external environment. It can be medicine, it can be pollution, it can be nuclear radiation, it can be anything that can affect an epigenomic profile and change how a gene will be expressed in a given human being. So unlike genetic changes, epigenetic changes are reversible, and do not change your DNA sequence, but they can change how your body reads a DNA sequence. In other words, if you are provided with a face which can be simulated with a genetic profile, the expression of the face can be compared to the epigenetic influences. So with the same face, you can have different expressions. And similarly, with the same genetic makeup, a human being can have different expressions depending on the modification that happens at the epigenetic level. And this is a very interesting article, if any one of you is interested in topic, by Dr. Sanjay Kalra sir, of metabolic karma, how it can change our destiny. And when we don't understand this link, we call it destiny, or when we don't understand the link, we call it as non-modifiable. Even though now that we are understanding it better, we are trying to pull it from a non-modifiable factor towards the modifiable factor. So like I said, there would be multiple windows of opportunity to peep in and intervene to modify or influence the epigenetic expressions. So we know the life cycle, which starts from in utero, infancy, early childhood, puberty, youth, reproductive years, which includes pregnancy in women. And then here we have andro or menopause and aging. And believe me, each of this stage is a window of opportunity to modify how epigenetic changes will decide the genetic expression, either favorably or non-favorably. And unless we understand this, we will be not in position to modify the unfavorable factors towards the favorable factors. So we need to keep looking for the windows for opportunity, for intervention, and changing the path the way the genes get expressed in future. So coming at what can modify this, what exactly we need to do that can modify epigenome. So it's a vast list of things that can modify epigenome, and these are called exposomes. I'm thankful to Yagnik sir for introducing me to this term. It can be a specific external environment like drug, chemical, pollution, general external environment like climate, change in the environment, change in the season. It can be internal environment, the patient's genetic profile, transcriptomics, proteomics, and metabolomics. And then health risk and impact assessment can also be part of modifiable exposomes. So for example, which we can relate to our day-to-day practice, hyperglycemia during pregnancy. If we modify the level of glycemia during pregnancy, we know that we are modifying the health and disease risk of the child that is born. Maternal nutrition, as we know, has a very strong impact on the baby's birth weight, and the birth weight has a very strong impact on the future health of the child. Anti-aging, living long is another way of looking at, is another subject matter where people are looking at changing epigenomic expressions and improving the longevity as well as the quality of life. And then coming to the clinic level pharmacoepigenetics of type 2 diabetes. Now, as I described, we would see what are the evidences. We know that hyperglycemia model is a very known model. The children who are exposed to hyperglycemia during mother's womb have a very high risk of developing diabetes in future. So this is something that can modify the epigenomic expressions. Birth weight, we know, is a very strong predictor of the health and disease of the child born. As the birth weight changes from towards higher or lower of normalcy, the chances of developing chronic heart diseases in these patients are changing. Another example is prior to pregnancy. Why wait till pregnancy? The effect of maternal, surgical, or medical weight loss in mothers has an improved outcome of the intergenerational transmission of obesity, a favorable outcome. Significant maternal weight loss modifies the obesity-related risk in children. Why only mother? Even the paternal exercise improves glucose metabolism in the adulthood. Lactation has been shown to reduce the risk of developing diseases in the child as well as the future mother's life. So these are multiple windows of opportunity where we can actually change the future risk of the disease as well as decide how healthy the individual is going to be. So there is an intergenerational programming. It's never too late or never too early to start changing the epigenomic expressions. It will take much longer to normalize the fetal growth or capacity, but we start early and we keep continuing the improvement. There are strong and sustained improvements in the health and disease parameters. Now, epigenetic influences, they have a potential to influence a large number of people together in family, as a herd or as a society, and they can influence more than one subject at a time. Eating habits of a family are likely to have an effect on a larger number of people rather than just treating one person. Now we have windows of opportunity at every level of development in men and women. At adolescents, their puberty has to be normal. Then in youth, if we control obesity, in pregnancy, if we control hyperglycemia, we change the fetal programming by changing the hyperglycemia status of the mother. And during menopause, if we treat these chronic disorders, we are reducing the chronic complications that arise. So it's a continuous process. Never say it's too late to modify your genes and epigenetics. What does it mean to us in the clinical practice when I'm sitting in front of the patient? So now there are studies happening at the clinical level where epigenetic modifications are looked at as another way of modifying the disease outcome. Especially, we are going to talk about type 2 diabetes. So Dr. Ling has good amount of data, and if you want to go back, you can go to her lectures. They're there on the YouTube, as well as a lot of publications in the international journals. So epigenetic modification in type 2 diabetes, they are looking at 3 to 4 main aspects: DNA methylation, histone modification, and non-coding mRNA. I know at clinical level, these things may not mean anything, but there is a genome-wide epigenetic analysis in human, which is now used to predict, to prevent, and to treat type 2 diabetes. How we are going to look at? These are some parameters that can be used as epigenetic markers and their modification in patients with type 2 diabetes. So for an example, we'll go ahead with just one study done on newly diagnosed drug-naive type 2 diabetes patients. They were treated with metformin, and 2 studies were done. One, to see if there are any epigenetic markers that can tell us a glycemic response of a person to metformin therapy, and second, the tolerance to metformin therapy. So the study compared people who responded to metformin versus who did not respond to metformin, and secondly, those who were tolerant and intolerant to metformin. And they found that they could very strongly identify through epigenetic parameters patients who will respond to metformin and patients who will have intolerance to metformin. By this, we are saving a lot of people who will be non-responders to metformin and intolerant to metformin by giving them metformin and causing complications. Now, coming to the slightly detailed aspect of pharmacoepigenetics in type 2 diabetes, what all an epigenetic study can do in a clinic. So one is blood-based markers. Like we have seen, there are a list of epigenetic markers that can predict a response or a tolerance to the therapy. For example, we had metformin. It could be SGLT2 inhibitors. It could be GLP-1 analogs. GLP-1 analogs are so costly. If initially I know if the patient will respond to it or not, if the patient will have side effects or not, it will become very easy for me to choose a right patient for giving GLP-1 therapy. Then individual differences in response to therapy due to epigenetic mechanism. This is something like culture and sensitivity that we do, that this is the person who will respond to this particular therapy. Therapy-induced epigenetic alteration. Am I giving the drug and changing only the level of hyperglycemia, or the drug is also changing some epigenetic factors that can either favorably or unfavorably influence the outcome of a disease? And then finally, we might dream of epigenetic therapies, including epigenetic inhibitors of epigenetic enzymes, which can be curable or make reversible changes in the pathophysiology of the disease. So we must know this because the future isn't very far. We can predict response and have new therapeutic targets. If anyone is interested, there are further readings where we can have fetal programming theories, how stress and mismatch can cause problems. There is a very interesting but relatively less well understood theory that is psychologically focused fetal programming. So there are epigenetic changes that can be modified or influenced by changing the psychological profile of the mother, or for that matter, of the father. So with that, we come to the summary of the talk. We have seen that genetics understanding has changed. We understand genes and its modification through epigenetic factors. There are multiple windows to peep in, identify modifiable exosomes at many levels, and you can not only change the individual's life, but of the generations to come. And it will not be very far when we use epigenetic and genetic markers in our clinic to predict response and the right therapy for the right patient. With that, I would like to thank the organizers and chairpersons. And if there are any questions, I'll be happy to take.
Thank you. It was a wonderful presentation.
Thank you. I'll stop sharing.
Hi, Anjali.
Hello, sir.
How are you?
I'm fine, sir. How are you?
Fine, fine. So new thing you have taught us that जिसको जो दवाई चाहिए वो we have to first diagnose and then we should start. So over to the chairpersons.
It was a wonderful talk from Dr. Anjali. So at this point of time, do we have epigenetic markers for various metabolic diseases?
At the clinic level, we don't have much, sir. It is at the research level. But if we remove the part of pharmacoepigenetics, just the change of lifestyle modification is going to change our epigenetics. And rather than just treating the hyperglycemia, if we look at these factors, these are new targets for us to talk to the patient and to modify. Many a times what happens is patient come to a stage where they say that, okay, everybody in my family has diabetes, so I also have a diabetes. So there's nothing that I can do about it. But this is not true, actually. There are epigenetic markers that can change, and not only that generation, but the next generation also can have prevention of diabetes or prevention of complications. Secondly, there are some epigenetic markers coming up which can predict which patients with diabetes will develop which complication. So, specifically for development or incidence of nephropathy, there are markers which can predict that this person will progress to developing microvascular complications in terms of renal complications. Because different patients have different complications. We don't have a direct relationship of hyperglycemia to a particular complication.
So let us combine both the lectures, Dr. Dhengraj as well as Dr. Anjali's. And now let us see, do we have epigenetic markers as well as some kind of treatment for those who are young diabetic and they will probably not transmit the disease to the next generation?
Dr. Ashish, would you like to say?
Sir, can you repeat your question?
So let us combine both of your talks now and see that you talked about the young diabetics, multiple genetic aspects you already taught it. Now, what best can we do to prevent these diseases from transmitting to the next generation through all those epigenetic markers and epigenetic way of treatment?
Yeah, definitely we can prevent the future generation population by doing the markings, because we are having, I have already done the buccal mucosa swab, and I was diagnosed as a pre-diabetes 10 years back. So we are having many tests available for the future progression, that whether you will have diabetes or not. So with the availability of these markers in the easy way, but we are far away still after 10 years also, that I have done 10 years back. So still we are not having these tests readily available, but if we are having it, we can modify their lifestyle and then can prevent the future transmissions.
Yes,
are these markers somehow related with that, like some of the Asians who respond to medicine, some of the medicine like DPP-4 inhibitors well compared to the other? Is it something like this?
Anjali, you can take this.
Yes, sir. Sir, there is definitely very strong likelihood of what you are saying of different people responding to different pharmacological therapies. And there must be a very strong epigenetic reason behind it. Though we right now do not have an identifiable marker, which we can test as a blood test and see whether this person will respond to a drug or not. But continuing the answer to your question, how we change the epigenomic expressions and prevent transfer of an illness from one generation to another generation. Like I also hurried up in my slides, there was a slide and clear evidence suggesting that if a mother or if a reproductive stage woman loses weight, obese woman loses weight before she conceives, we are reducing the epigenomic exposure of obesogenic factors to the next generation. So we are in kind of preventing type 2 diabetes in the coming generation. A lady with type 1 diabetes or type 2 diabetes before pregnancy, if she controls her hyperglycemia and then plans pregnancy, we are preventing the exposure of hyperglycemia to the child, which will halve the chances of the child's developing diabetes in the future. So these are epigenetic changes that are happening and preventing the transgenerational transmission of the disease.
So what
Any
we are saying
questions
is
from the-
about basically the primary prevention. Basically, we want to mainly focus on primary
This is
prevention to change the
primordial
epigenetic.
prevention, sir.
Primordial
Even
prevention.
before primary prevention, this is a primordial prevention.
Can I comment on the previous topic, previous question?
Yes, sir, please.
Oh, sure. So you have rightly said that currently there is no effective, I think, drug to prevent the epigenetic changes. Only effective therapy or effective mode of prevention is the lifestyle modifications. That is the I think the effective method of prevention of epigenetic changes. Currently, there is no drug or medicine which can prevent the epigenetic changes. This is number one. And with regards to the difference between the effect of therapy to the same therapy for the different patients, I think pharmacogenetic are more important. So this is genetic because of the genetic difference between the persons or between the subjects. So pharmacogenetics determines the efficacy of the therapy. This is not because of the epigenetic things, I think, the epigenetic changes.
Is there anyone in the audience who wish to ask some questions?
Myra, are there any questions?
No, sir.
Thank you very much.
Can I reply to my questions?
Yeah, please go ahead.
Yes, sir, please.
Please go ahead, sir.
Okay, fine. So there are many differences between the two guidelines, that is ADA guideline and ACE guideline. So first of all, who is making the guideline? So in AS and ASC combination joint position statement, mainly the endocrinologists, they are making the guideline. And ADA guideline is mainly by the diabetologist, and there might be some endocrinologist as well. So and secondly, what are the trials or the studies they considered for making the guidelines? That can also make the differences. So when the guidelines are made, mainly the randomized control trial, meta-analysis and systematic reviews are considered with regards to the efficacy and the benefits and all these things. So that makes the difference. And the slide I mentioned that in ADA guideline, they recommend that when the baseline HbA1c is more or equal to 9%, we should start with dual therapy. So that was actually a guideline some years back. So if you look into the recent guideline, they have already changed the guideline. They said that we should start always with metformin unless and until there is any contraindications. But if there is atherosclerotic cardiovascular disease, established atherosclerotic cardiovascular disease or high risk for atherosclerotic cardiovascular disease, irrespective of the baseline therapy or irrespective of the baseline HbA1c level or irrespective of the target HbA1c level, we should either choose GLP-1 receptor agonist or SGLT2 inhibitor. So now they have shifted from the glucocentric management to the patient-centric management. So considering the comorbidities and complications. So now they are following the guideline of individualization. On the other hand, ACE guideline, they are still mainly focusing on the glucocentric manner. So they recommend that if the baseline HbA1c is less or equal to 7.5%, we can start with monotherapy. If it is more than 7.5%, we should start with dual therapy. So I am giving one example. So in verified trial, it was seen that in the arm where the combination therapy was started from the very beginning, in that arm, the treatment failure, the primary treatment failure as well as the secondary treatment failure was very less and it was delayed. And the mean duration of diabetes in that trial was less than 1 year. The mean duration was 3.3 months only, and the maximum duration of diabetes was less than 1 year. And the mean HbA1c level was approximately, I think it was also less than 7%, and the range of HbA1c was 6.5 to 7%. So you can understand that even in drug-naive patients and in newly detected patients, if we start with fixed dose combinations, not always, in some situations, we can prevent long-term loss of durability of therapy, and thereby we can delay the complications of the diabetes as well. So this is just an example. There are many other trials which has also showed similar benefits, starting with fixed dose combinations or combinations therapy from the very beginning, in terms of prevention of loss of durability and also loss of glycemic control and complications in the long run. And that was also seen in real world studies. So I think these are the points. That's why there is a difference between the ACE guideline and ADA guideline. So after all, we need to individualize. We need to apply our clinical acumen and judgment and also experience. And the guidelines are only just to guide us, not always to followed by us. So this is just a guideline, not a fixed mandate. So we need to individualize.
A very good message by you, sir. Individualization is the key, that we have to don't follow the guidelines by right and left, but see the patient first, see his profile, and then you start your treatment.
So do we have time to further, or we should stop?
Myra?
So you have 10 minutes because we'll be starting by 2:30.
So
Okay.
do we have any
5-7
more questions?
minutes you can take.
If you don't have any more questions, we can conclude the session and we can hand over to the next session.
Yes, you can conclude if you want, because we already have the speaker for the next session.
Right.
It
Thank
was
you
like
very
a
much.
wonderful.
Thanks to you all.
I will get 10 minutes more.
Yes, sir.
So that will be excellent.
Hi, Vitul, sir.
Hello, how are you?
Fine, sir. Fine. How are you?
Hello, sir.
So, Sabajyoti, you can conclude this session.
So after a wonderful presentation of this quick sessions by three eminent speakers, and which was very informative by everyone, and there was a good discussion at the end. So we would like to conclude this session and hand over to Dr. Mahira to continue with the next session. Thank you all the speakers and all the chairpersons.
Thank you, chairpersons.
Thank you. Thank you.
Thank you.
To invite us. Hi, Ariana.
Nice to meet you.
Yeah, same again.
Good afternoon, everyone. And with this, I welcome you all to the Diabetes Education Symposium. I'm Mahira from Diacare, and I welcome the chairperson of this session, Dr. Manjula Mittal from Jaipur, and Dr. Shruti Shet from Ahmedabad. And Manjula ma'am is MD in medicine, working in Jaipur as a consultant, specifically in diabetes. And Dr. Shruti Shet is a diabetologist based in Ahmedabad. And I welcome you both here. And I welcome all the three speakers of this program, Dr. Mitul Gupta, Dr. Ariana, and Dr. Cheki. So over to you, chairpersons.
Hello. Am I audible?
Yes, Shruti, you're audible. Please go ahead.
Okay. Hello, fellow chairperson. Good afternoon. We're in a very post-prandial state, I would suppose. But it's a very important topic that we are addressing today right now, that is diabetes education. And for that, our first speaker is Professor Dr. Vitul K. Gupta. He is an MD medicine with FICP, FCSI, FACP, FICM, and he's a health and human rights activist. He is an honorary teaching faculty in AIMS Bathinda and also a consultant in Kishori Ram Hospital and Diabetes Care Center in Bathinda, Punjab. Over to you, sir, and let's start the topic with sir. Over to you, sir.
Thank you very much. So may I have the slides, please? So thank you very much, Dr. Bansi, for having me here to speak on rather important subject of challenges in medical education in India. I think this has gained the prime importance, and especially when nobody is talking about it, and Dr. Bansi has given me time to talk about challenges. And luckily, I have 10 minutes more. I think the previous session finished before time. So I will have, I think, 30 minutes to discuss important challenges in medical education. Next. Next slide, please. Next. So I always start my lecture by paying tributes to my late father, Comrade Prakash Gupta, my friend, Dr. Gurpreet Wander, who was instrumental in my academic pursuits and inculcating academics from the very first year of our MBBS. Next. And nothing is possible without family support. Next. So coming on to the topic disclosures, because of paucity of documentation in medical literature, this lecture is largely based on personal observations, experiences, and interactions with various stakeholders and media reports. Some listeners might not agree with the pathetic state of our medical education, but I think their disagreement is certainly justified because they might not have been exposed to the actualities and realities of the prevailing deplorable state of medical education, and that could be much worse in some of the medical institutes, what I am going to describe or what I am going to discuss today. So there are no conflicts of interest. Next. India has one of the oldest and largest medical healthcare system as well as medical education system in the world, but it is still struggling with to fulfill the basic and needs of the society. Moreover, COVID-19 pandemic and Ukraine-Russia war has brought increased focus on challenges in medical education, opening a long dormant Pandora's box. And Dr. Bansi, you have given me opportunity to discuss this chapter, which is not being discussed openly. Medical education is expected to play an important role in achieving sustainable development goals and producing competent, ethical healthcare professionals capable of providing universal, equitable, and effective healthcare services. Next. So this is my observation that medical education in India is maybe on the verge of collapse, or it has already collapsed. Next. Post-COVID-19 and post-Ukraine war, everyone, including the professional organizations and media, is becoming more and more sensitive about the role of medical education, except the government and National Medical Commission. You will find several media reports taking up the deficiencies in medical education or how we can improve medical education, but there is no step from the government or the National Medical Commission. Next. So there are several reports on medical education post-Ukraine war, like Doctors Out of Borders, regulate fee to stop students' exodus or dying to learn about medicine. Next. These are the media reports which are highlighting the importance of medical education. Next. So we are going to discuss challenges, and medical education in India is facing numerous challenges, each requiring days of discussion. But we are going to briefly discuss a few rather important challenges today. Next. First and foremost, I think it is commercialization and privatization of medical education. Since 1990s, with opening up of medical colleges, more so, private has led to the concept of buying medical seats rather than merit, leading to skyrocketing capitation fee and corruption in medical admissions. So till 1990s, it was only non-profit trusts which were allowed to open their medical colleges, but progressively the conditions they decreased and more private medical education colleges came up. Next. private medical education, even after establishment of NMC in 2020, remains very expensive and has become a market investment for the students. Major reform for NMC to regulate fee in about 50% of the private medical colleges, in fact, failed. Next. So media reports were there highlighting the increase in course fee to MBBS to about 50 to 70 lakhs, and for post-graduation, it is up from 1 crores to about 5 crores. So that has led the fee increase because of commercialization of medical education. Next. So we were not behind as health and human rights experts. We take up this issue of increase in medical education fee, and we are working or fighting at all the fronts to impress upon the government to regulate the medical education fee. But till now, our efforts have been proved futile. Next. Next. So these are the media reports. Only on this July, NMC issued a letter regarding guidelines for determining the fee and other charges in respect of 50% of seats in medical institutions and deemed universities. But several media reports and editorials have reasoned why a more affordable MBBS education could be a pipe dream, and you will be distressed to know that only 3 days back, Supreme Court has issued notice to NMC that why the fee should be regulated in private medical colleges. So I think there is inherent defect in NMC Act that they can or cannot regulate the 50% of fee in private medical colleges equivalent to government medical colleges. Next. So again, several reports are there. Activists feel that NMC fee plan for private medical colleges could face challenges. If you go through the act, they found certain defects by which NMC will not be able to regulate fee. Next. So commercialization of education has affected the mentality of students, making them more materialistic, self-centered, without value of sacrifice or service to the country, and affected the chances of poor, brilliant students to become a doctor. This has led to complete eradication of societal and humanitarian aspects of medical education, converted into a very lucrative business. So when you pay a fee of 1 crore, how anyone can expect you to do service and not earn to take back the investment what you have done for medical education? Next. On the other hand, there is miserable neglect of public healthcare institutions confronting with low budget, inferior infrastructure, unable to keep up with pace of new development in medical services. Our public healthcare is in pathetic state. Numerous aims have been opened mindlessly, and almost all are facing one or other type of problems. More importantly, there is no separate budget for medical education. It is part of health budget, and there is suspicion among experts that government's medical education funding may be further curtailed under private-public partnership model, affecting public medical education in future. Next. So these are again various media reports and editorials highlighting the importance of medical education that invest in healthcare, not just in aims alone. To booster healthcare, government must allocate more budgets. Next. So next important challenge which medical education face today is corruption. Corruption has different faces on private and public medical education system, but the worst kind of gross corruption and unethical practices was encountered and also being encountered during MCI and NMC inspections, when bus loads of patients are mobilized to fill empty wards, car loads of doctors are paraded before the inspectors, the ghost faculty, birth and death registers are manipulated, instruments are hired or shifted between colleges, and still private medical colleges manage to get MCI and NMC permissions under the influence of cash, kind, or political patronage. And this is an open secret. Next. Now, same things are happening under even NMC. Reports suggest that in spite of need, many private colleges charge under the table in addition to high fee for admissions. Worst type of corruption is passing the undeserving students, especially with grossly deficient attendance in lieu of cash and kind. So this is, experience and reports where faculty interact with you, that whenever the candidates have deficient attendance, private medical colleges take extra money to fulfill their attendance requirement or pass the undeserving students. So this is the worst kind of corruption occurring in medical system today. Next. So again, these are the media reports where ghost faculty, PMC chief takes on the minister, but at the ground, nothing much is happening. Next. So these are the dummy files from a ward. Next. Registers with dummy faculty. Next. So it is very important to mention that NMC and PMC has failed to act on especially my written complaints against the local private medical college at Bathinda, for in spite of undertaking in Honorable Punjab and Haryana High Court, so much so that now last week I have filed the contempt petition and High Court has accepted the contempt petition against the Punjab Medical Council. Several other aspects of corrupt practices can't be discussed here because of paucity of time. So I will skip some of the aspects. Next. So this is the media reports. The High Court looked into the issue of ghost teachers in medical institute. These are all media reports on my complaints. Next. So safe medical education for ghost faculty, media is highlighting, but on actually NMC has failed to do this to curb the ghost faculty culture. Next. So role of regulators like NMC and state medical councils gains importance and their role is larger than life. Activists like me have questioned the role of MCI and the NMC ever since the inception of MCI in 1934 and replacement of MCI by NMC in 2019. In 2010, MCI was dissolved following the arrest of MCI president by CBI in a corruption case and submission by the Parliamentary Standing Committee. Next. So no doubt, converting 15 district hospitals into medical colleges is a welcome step. But who is going to, how on earth the government is going to provide much needed teaching faculty? So already there is more than 50% deficiency of teaching faculty in various government colleges, and the private medical colleges fill that vacancies by ghost faculties or doctors on rent. Next. So, but now reports suggest that private medical colleges continue to indulge in open and gross illegal and unethical practices, as this recent report only last month, where temporary doctors and during patients, the NMC gave go ahead to 5 new colleges in Gujarat. So these are the recent reports even that NMC is failing or NMC is conniving with private medical colleges for recognition. Next. So again, a media report. That is why health activists like me are forced to think whether NMC replacing MCI was a good idea, or could MCI would have been reformed to make it efficient and corruption free. This only time will tell. Next. NMC has miserably failed to act when a local private medical college demanded enhanced PG fee from PG students in spite of ongoing fee determination case in Honorable High Court. And when inhuman attendance guidelines were implemented for PGs, NMC then also failed to act on my written complaints, and NMC bill was supposed to be a revolutionary step, but NMC seems to have failed in almost all the objectives for which MCI was dissolved. Next. So this is the representation by the students, and media reports about the dispute over tuition fee being charged from 21 students, and more importantly, the State Medical Council as well as NMC failed to act to protect the students' interests. Next. So that is what the powerful private medical education mafia is like. So MD-MS exams are delayed, and this was the message I got from NMC, that it is the discretion of university. NMC has no power to intervene, and NMC can issue only guidelines. So this is the pathetic state for NMC regulations. Next. State medical councils are mainly involved in registration of doctors, awarding CME credit hours, but have failed to keep up with present post-COVID situation and frame guidelines for hybrid CMEs. And I have approached the Punjab State Medical Council, but they say that whenever NMC is going to frame the guidelines, only then we are going to frame the guidelines. In fact, they are independent bodies, they can frame the guidelines, but I don't know why they are shirking from escaping their responsibility for framing hybrid CME guidelines. Next. So this is the letters what I have received from Punjab Medical Council for hybrid CME guidelines. Next. So today also, the India Today exposed private medical college faculty faith that flouting MCI rules, those similar things are happening under NMC also. Next. Next, please. Next. Against NMC. Next. So highlighting the medical education fee. Next. So I think in a desperate effort for increasing medical seats, NMC is compromising on quality of medical education, skewed distribution of medical colleges, seriously compromising teaching and learning activities, and monitoring standards of admission, evaluation, facilities for teachers, adequacy, and infrastructure is severely compromised. Next. So next challenge is disproportionate growth of regional imbalances of medical colleges and states. So almost 50% of the medical colleges are in 5 states. Next. So those 5 states are Karnataka, Maharashtra, UP, Tamil Nadu, and health experts explain that such regional imbalances are because of increasing political patronage and as commercial enterprises rather than service to the nation. Next. Next. So again, regional imbalances are because of the private, commercial interest, because PG medical seats are on sale for 2 crores. So these are all media reports. Next. So role of universities and colleges are very, very important, where now professional ethics based on Hippocratic oaths have been replaced by business ethics based on commercialization, affecting the mentality of young doctors. Next. So there is rapid proliferation of institutions with deemed university status and grossly deficient infrastructure and manpower, and merely serve as commercial venues for giving degrees. Next. So this is a deemed university where the medical college was found to charge money, and that was illegal and unethical practices in implementation of our Ayushman Bharat scheme. After even High Court's notice, nothing has happened. Next. So again, corruption in medical colleges related to all these schemes. Next. 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 So curriculum again is a very, very important challenge. Curriculum revision to competency-based UG curriculum stressing on medical ethics, doctor-patient relationship, and outcome-based learning is a welcome step. But I think serious doubts that curriculum change will be able to train professionals able to fulfill community needs, because the students will be learning under the hypnotizing influence of privatization and commercialization. Young doctors are increasingly adopting market private corporate initiatives under the pursuit to earn more money. Next. So these are the papers where you can see the curriculum change has not affected much splenomegaly of the liver. Next. So angina pectoris severe burns. Next. Arteries and veins are atrial fibrillation. Next. So this is how a young doctor is checking blood pressure during examination, final examination. Next. So poor internship supervision is again very, very important subject. And proportionally now, basically what is happening, the interns are joining coaching institutes to prepare for PG and super specialty entrance tests, severely compromising their internship training. So they are unable or they are unprepared to practice as primary care physicians. Next. Next. Shortage of clinical material is again an important challenge, which is filled by the rented patients during inspections. Next. So these are the empty wards. Next. Rented patients, like they have come to the wards like on a picnic. Next. Poor research activities. Most of the medical colleges add medical science and research to their name due to the administrative reasons, but research activities are practically nil. And majority of the research is in the major institute like AIIMS Delhi, PGH Chandigarh, or CMC Vellore. Next. 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 So even when the NMC requirement of publication exists for the promotion of faculty, a unique way out was publishing in the paid journals. And next. But I think absence of any credit for research and selection of PG or DM courses discourage doctors to go for research rather than they spend time attending coaching classes. Next. So selection of medical students, one revolutionary measure of NEET, UG and PG would have gone a long way to rationalize medical college admissions, but progressive decrease in UG and PG qualifying cutoff marks has opened a Pandora's box where percentile system has played havoc with merit, making very easy for wealthy low performers to buy seats. Next. 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 So these are the features highlighting how the MBBS seats are, how much percentage marks a student should get to get a MBBS seat. Next. 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 Shortage of medical teachers is again a very important factor which I've already discussed. Next. Next. So to sum up, my dear friends, challenges in medical education is different from public institutions, that is lack of funds and infrastructure, poor work environment and bureaucratic control, and private education system, it is excessive commercialization and increased illegal and unethical practices. Next. So this is going to impact on healthcare system. Since we are not talking about the impact on healthcare system, I will skip these few slides which are enumerating the impact on healthcare system. Next. So please rush through the slides. Next. 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 So these are all discussing what care there can be impact on healthcare system. So present healthcare statistics prove that India has a long way to go before it can achieve universal healthcare or healthcare for all. Our healthcare system has become insensitive, inequitable, unaffordable, apathic to societal needs, and we need to reform our medical education system. Next. Next. So it is surprising that there is no shrill voice of professors or professional organizations lack of interest in problem of medical education, and I must compliment the API Scientific Committee to include this subject in 2023 as well as and Dr. Bansi Sabu to include this subject here also. So the question will be asked are who will apply the brakes? Is there still time to stop and reverse? And more importantly, is there any political will to do so? Next. So medical education should find a prime place and nobody has a right to commodify it, which is being done very progressively in present times. Next. So there should not be any confrontation between private and public, but both should thrive together with more focus on public medical education than private medical education. Next. So destroying education is destroying the nation. So destroying medical education is going to destroy the nation's healthcare system. That is what we are facing today. Next. Need of the hour is to address the core challenges and pursue the inclusive medical education, eliminating the coaching culture, initiating health reforms designed to provide health for all with a focus on public health care and family medicine, not neglecting the super specialties. I think it is high time that our policymakers realize the serious challenges medical education is facing today and initiate revolutionary reforms before it is too late. Next.
Sir, just a reminder.
This is the last slide.
Okay, thank you.
So this was a report in today's Times of India, which I read, and I want to say that this is a beautiful article that in India, the weakening of public health system and collapse of three-tier health system combined with the rampant privatization of healthcare has been disastrous, especially for the poor. India's obsession with quality of doctors has resulted in opening a large number of colleges with poor facilities, infrastructure, inadequate patient load, and not enough faculty, leading to thousands of very poorly trained doctors are being produced every year. On paper, the number available to health system are constantly increasing, but in reality, in rural India, there are 2/3 of population lives. The actual shortage of doctors and nurses remain unaddressed. So despite knowing well that doctors from urban background trained in tertiary centers located in big cities would be ill-equipped and unwilling to face the challenges of working in rural areas, the government continues to do that. So my humble request to all the medical doctors who are listening today is to raise voice for reforms in medical education, which is the need of the hour. And without medical education, we are going to have a disastrous healthcare system, and our medical education is collapsing. And we are there. We should make efforts to save medical education in India. Next. Thank you very much. And then I invite all of you to Mapicon 2022 at Bathinda next week. Thank you very much.
Thank you, sir, for the nice eye-opening lecture. We'll quickly move on to our next topic, which is diabetes education during diabetes management during disasters. We just went through a big COVID pandemic, which is still a bit going on. For this, I would like to introduce Dr. Iriana Vasenko, who is a board member of the International Diabetes Federation Europe Regional 2015 to 2019. She's a PhD Pharmacy Associate Professor, Vice President of the IDF, responsible scientific editor Pharmaceutical Journal of Ukraine, member of the European Medicine Agency EMA, working party with patients and consumers, member representative steering group of the European Network of Centers for Pharmacoepidemiology and Pharmacovigilance. She's members in various organizations, and she's doing a wonderful work. She's an international expert in diabetes and has taken part in development of regulatory documents, medical standards, etc. on national and international levels. She has participated in many meetings with governments and other key stakeholders and attended many international congresses with a view to raising awareness of diabetes and effecting policy changes. She's been in the development of technology drugs for diabetic foot wounds, digital solutions in diabetes management, co-author of the state education program for doctors, for educators in self-management, co-author of the book Self-Management Training of Patients with Diabetes Mellitus, which was approved by the Ministry of Education and Science of Ukraine. She has 163 articles, 8 patents, and 9 textbooks ongoing. She's the director of the first International Diabetic Football Championship, Dia Euro 2012, European Futsal Championship for people with diabetes, that is Dia Euro. Ma'am, that's amazing, and it's very inspiring too, and it's a great pleasure and it's a great opportunity for me to introduce you to everyone. Over to you, ma'am.
Thank you so much for your represented me, for your kind words. Can I share from beginning my screen? Yeah. Hello, everybody. I'm very happy to be attend to this conference. Thank you very much for Dr. Professor Bansha. I'm very happy with this. And I want to express my respect to our audience who want to listen us and want to learn all the time. This is very important, I think. Today we will speak about the management of diabetes during disaster. And the humanitarian crisis, it's increase. Just a moment. And it's, of course, it's a major global health challenger. Chronic disease have historically been given low priority, unfortunately. And before our war, I never thinking about this subject. And now I understand how it's very important to prepare for this situation. I think what I will do now, because I from beginning involved in humanitarian aid from IDF and from another member association to Ukraine, and I will learn through the practice, but we must be prepared for this. In crisis context, the majority of people have extremely limited access to resources. The complication of diabetes, such as blindness, amputations, kidney failure, or cardiovascular events, are a heavy burden of individuals and their families, as well as on the health system. These doctors, combined with the stress and psychological challenges associated with this crisis, and we understand in increase patient need more short insulin for this during this crisis. This raises two issues for people with diabetes. They need for better management to avoid excess patient mortality, the logistical challenge of ensuring a continuous supplies of treatment, especially insulin, in a confident area. And emergency diabetes care should be prioritized in humanitarian crisis. And when it was increased a lot of crises over the world, it was many organizations signed one declaration, Boston Declaration, that they highlight many things about humanitarian crisis and what need people with diabetes, and established the unit set of clinical and operational guidelines for diabetes in humanitarian crisis. and universal access to insulin and other essential medicine and diagnostic for glycemic and blood pressure control in humanitarian crisis. And also WHO have goals and some recommendation on how to strengthen the design and implementation of policies, include those the resilient health system. This is very important to be prepared and to have many different facility. And it's not too much, but many organizations, include WHO and IDF, develop some documents for concern humanitarian crisis and diabetes. And if you look, IDF make recommendation 2017 about diabetes and in crisis. And I would like to promote my friends from IDF West Pacific region, which made update 2022 diabetes care in disaster. It's very useful now. It's a lot about, of course, many things concern COVID-19, but I think it's very, very important to know some points, all these documents. And disaster, we never prepare for this. Unfortunately, I recognize in our situation in Ukraine, we have before war 8 years, but it was local and not big part on Ukraine. And anyway, we not prepare for this war. But preparation must be include update list of all times, planning, response during disaster, and resolution and recovery, because it's huge problem will come after they finish this war. And this case I like, which it was take this from these documents, West Pacific region, IDF region, disaster, not if, but when. This is, we must be prepared. And if you look on these documents, you can finally find many things according to diabetes, which is very important during disaster. And it's not, they also promote some resource which you can find and find your questions. Very important information we got from some association who work in Diabetes Disaster Alliance, information for healthcare professionals, insulin product switch guide, switching between insulin product in disaster response set. I would like to share our experience, Ukrainian experience, that government decide from beginning exchange rules. For example, before doctor can prescribe only trade name, brand name, but when it start war, we change rules and the doctor can write like short insulin, long insulin, analog insulin, something like that. And this is depends on what we have in pharmacy. This is very important because sometimes we have not all a list of insulin. But to be honest, thanks to IDF, Direct Relief, who are our partner, and many pharmaceutical company and member association, we had normal situation and maybe not even exchange insulin, thanks God. But this is mostly in Ukraine territory. But more practical, more things which you must deliver. Yes, you may be not educator, only clinician, practitioner, but if you not deliver this information, nobody deliver. In this case, the people, when suddenly it happens, not ready, absolutely. Stress can cause a rise blood sugar, of course. It's simple, understand, we know this, but anyway, in disaster, as I say, that for people who use insulin, increase short insulin, and we must respond for this. Thanks God, our ministry very quickly understandable this and the distribution more short insulin, because we had after the humanitarian aid. Erratic meal times can cause change in your blood sugar, of course. Exercise work to repair damage caused by the disaster without stopping for snack can lower your blood sugar. And excessive exercise, when your blood sugar is over 250 milligrams, can cause your blood sugar to go higher. This we know, but many important things which must be delivered. Drink plenty of fluids, especially water, and wear protective clothing and sturdy shoes. It's could be very freezing, and people with diabetes have a problem with the immune system, and maybe we can catch disease more easier for other people. This must be protected. Check your feet daily for aeration, infection, open sores, and blisters. Never go without shoes. Food, concern for food. It's a lot of, you see this, it's a lot of recommendation, but from my side, need to make simple things. Take carbohydrate, it's very important. And of course, check blood. And this is also increase food and water intake during period, increase exertional or physical activity by either eating between meal snack before activity or by eating additional food with meals. But for me, it's very important, carry a fast source of sugar with you at all the time. Is without this must be obligation. It doesn't matter it's disaster or not, but anyway, in disaster, it's very, very important. And sick day during disaster, always take your insulin on pill on time or close to it. Take this with you. Keep an extra bottle of each type of insulin you use to hand all the time. And it's a lot, you see, but most important, do not let yourself get dehydrated. Drink plenty of liquid at between meal times. Rest, it's very important, rest. And there sometimes it's not possible. For example, when it starts war, we cannot sleep at night. We all the time waiting this bombing, and we cannot sleep. But anyway, we must sleep, and day doesn't matter, but we must find time for rest. It's very important for mental health and for your reaction on this stress. Check your blood sugar, of course. Test your urine for ketones. This is very important. This is, I even recognize for myself that I have not, unfortunately, ketone for test urine, but now I understand I have, because this is very important. Have this and check, because it must be a reaction for this if you recognize this. And and this is for your clinician. Very important subjects. Treating diabetes ketoacidosis under the resource setting. We can find this. We know that people with type 1 diabetes may develop diabetic ketoacidosis during disaster, because more stress, and can not regime, not schedule. And people with type 2 diabetes may develop severe hyperglycemic state with or without ketosis, and include hyperosmolar or not ketotic coma. And also, it could be also possible develop this situation with people even don't know that they have diabetes. I can share my experience that there was 2004 in our first revolution, and we try to help people who was in Maidan, its main square. And I recognized this one person say very red and some very tired, and we start speaking. But of course, I have a glucometer with me, and we check blood at 24, and then he don't know that he has diabetes. This case is also could be, and it's very. This is resource is diabetes in childhood in adolescence, that you can find how treatment in small resource. Storage, it's very important subject, but first of all, you must know that if temperature, because we know how it's must be done. It's normal situation, but sometimes, we have not electricity, we have not a refrigerator. And that's very important to know that insulin storage such temperature 25 and 37. It was 4 weeks period of use. This was some investigation which made before. But only also very important thing that it's insulin is not directly against the ice, brick, or frozen vegetables. Sometimes we put in, but it must be not next to, because in this case, it will be unactivated. And also very important, no, if it's not like termin, it's finish. Anyway, it's better to have this than have nothing. And the diabetes kits is very important, how prepare, what you need during. I have this bag with my corridor, my apartment, but it's a lot of need, but mostly it's insulin. And what I want to say, that it must be sugar. So I had 1 kilogram sugar is this bag, in this bag, and this is better for my even mental health. And remember also that, just lost. And we must also remember some special health concern. If you have some chronic kidney disease, you must know about mental. I have already said. You can find diabetes care plan in emergency, and it's more make easier your work. I say about this, and solidarity. This is for refugees. We will not speak about now. And occupation territory is now, unfortunately, we have not delivered any help. And please stay with Ukraine. Please don't be tired from this situation. We really appreciate your support. Thank you very much for your attention. If you have some question, please ask me.
I think, ma'am, we'll take the questions at the end of the session. That'll be okay.
Thank you.
Thank you, ma'am, for the wonderful lecture. We'll move on to our next topic now. That is perspectives of self-management, education, and support. And we have Dr. Jackie Kassoff to present this topic. Dr. Jackie is the founder and president of Dialib, the National Diabetes Organization, which is a leading diabetes organization in Lebanon, which she founded with her daughter Sylvie, living with type 1 diabetes in 2010, and has been the president since. Dr. Madhav is a candidate for the position of Vice President Non-Healthcare at the IDF. She holds a PhD in Public Relations and Communications from the University of Collins in Virginia, USA. She made it her mission in life to advocate for those living with diabetes and delivers educational and motivational talks, especially to the recently diagnosed. She has 12 years of experience in leading Dialib's awareness campaigns and activities across Lebanon. Amazing work, Dr. Jackie. I'm sorry if I didn't pronounce your name correct.
No, it's okay. It's okay. Thank you so much. And my apologies for not being able to listen to my colleagues while presenting. We are suffering from power outages here in Beirut. I'm really sorry about that. So can I share my screen now?
Yes.
Yes. Okay. And in the meantime, I really appreciate this invitation for the second year in a row. And I'm really happy and to be here presenting about, okay, 1 second, please. I need to, Okay, that's it. So again, I'm very happy to be presenting about the perspectives of diabetes self-management, education, and support, which we call DSMES. So, and knowing about how important is education, and that the title of the IDF for this year is going to be around education and the tomorrow of the people living with diabetes, I will be mentioning. Okay, sorry about that again. I'll be talking roughly about non-communicable diseases, the types of diabetes, to understand which types are preventable and how important it is to be educated about that, the burden of this disease, what is the self-management education, what is the self-management education and support when we add the support to it. I will mention some research work supporting the SMES and the management of type 2 diabetes and its relation to this perspective by itself. Also, what are the barriers and the challenges that we face in today's world? And of course, the conclusion. Okay, so just to mention very quickly how important it is to see that diabetes. Oh my God, 1 second, please. Something is happening on my screen. Oh, right, I got it. So if we think that the non-communicable diseases are killing 41 million people each year, which accounts for approximately 71% of all the death globally, this is by itself an eye-opener and a call to attention and to immediate action. And the NCD-associated mortality is expected, unfortunately, to increase. Now, if we look at the 4 main NCDs, which are the cardiovascular diseases, diabetes, cancer, and chronic respiratory diseases, we have common 4 modifiable risk factors: the tobacco use, the unhealthy diet, the physical inactivity, and the harmful use of alcohol. Now think with me how important it is to educate patients on the importance of those modifiable factors. And when we say modifiable, it means if we do simple lifestyle changes and we are well educated about the topic and about the importance of those changes and their positive impact on our health, the impact and the outcome should be tremendously positive. Oops. Sorry. Can you hear me? Hello?
Yes. Yes.
Okay.
Yes, ma'am. You're on board.
For some reason, I'm not able. Okay. Okay. So I have to mention here the types of diabetes. I'm sure you're all aware of that. We have the type 1 diabetes, which is 10% approximately of the total cases of diabetes. The type 2 diabetes, which accounts for 90% of the total cases. And here you can see that, yes, it can be prevented. How? Through education. And yes, it can be better controlled. How? Through self-management of the disease. And also the gestational diabetes, which can be preventable by healthy lifestyles, healthy diets, and physical activity. Let's talk about the burden of the disease. People living with a chronic condition makes their lives really difficult by itself. And if we are going to think about the drug and non-drug treatments, and sometimes how difficult it is to manage your disease with the drug treatments and the non-drug treatments and the self-testing and the self-monitoring, it cannot be easy. And it is mostly complicated for the majority of people. I had a power outage just now. If I get disconnected, please bear with me. I'll try then from my phone. So that by itself and how difficult it is to manage may result in psychological consequences. And we've seen that during the pandemic, people living with chronic diseases are more affected than others. It can also result by familial consequences in the family, in the household, by social consequences, by misjudgment, misconceptions around us in society, and definitely financial consequences. Leading a healthy lifestyle can be costly. And also, we can see one of the results is low treatment adherence. The patients do not comply with the treatment, resulting in that affecting their quality of life. Now, the diabetes self-management education, if we want to talk about a structured educational program that should address the comprehensive blend of the visits to the doctor, the clinical part, the educational part of the patients, the psychological and psychosocial parts, and also the behavioral aspects that are needed definitely for daily self-management. It's like a combination of many components. It provides the foundation to help the people with diabetes to navigate through their daily self-care steps. You do know, and I'm sure most of you or all of you are professionals and deal with patients, and you do know that there are several steps, there are many aspects of the life of a patient to be considered when we talk about the education. If we're going to talk about the support needed for diabetes self-management education, which is the DSMES, here we have a consensus report from the biggest diabetes organizations in the world. You can see some of them, and it was done in 2020, which states that through diabetes education, we can provide critical education and support for the implementation of the treatment. We can have, as a result, the reduction of emergency and hospital visits. Don't we all want that as an outcome of the education? It can reduce hypoglycemia, all-cause mortality, and it can lower the HbA1c. Definitely all of them positive outcomes. It addresses the weight maintenance, which we do need, and we educate our patients to always manage their weight within the normal parameters because it reflects on their overall health. It also improves the self-efficacy, and this is very important, the quality of life. We don't want the patient just to live with diabetes. We want our patients to live a very good quality of life, although they have diabetes. To continue with the same topic, let me say that diabetes self-management education and support can be provided or modified at several stages. 4 critical times will be mentioned here. Ideally, at diagnosis, there should be an offered DSMES and the proper education for the patient. Annually, or whenever we are not meeting the targets, or whenever there is no compliance or no adherence to the treatment. And when complicating factors develop, if we see that the patient is starting to develop complications, then we do need to review or modify our diabetes self-management education and support tools. And the 4th one is when transitions in life occur. Example, if the patient is a young lady who gets married, if she's pregnant, or if they're going through, any patient is going through a period of extreme stress. At those times, the tools and the policies of our diabetes self-management and education and support should be revised and modified, but we need to continue providing them. We continue with the topic stating that engaging the adults with type 2 diabetes that we all know is preventable, engaging them in DSMES can result in many beneficial ways and clinically meaningful improvement, not just the mindset and feeling good and the well-being of the patient, but clinically also it has been proven that it affects the A1C, for example, which is a major impact. The greatest improvement and are achieved when we have diabetes self-management and education and support involving both groups and individual education. Sometimes we need a one-to-one session when also it is provided by a team versus a single individual. It's been proven to have a greater impact through a team, especially having a multidisciplinary approach, when it involves participants who attend more than 10 hours. We don't want the patient to come once or twice. We want the patient to attend all the program that entailed by diabetes self-management, education, and support. And also we have best improvement or greatest improvement when it is tailored to the individual participant. We do know that every patient deals differently with the disease, so it's very important to have an individual approach. If I want to mention a couple of research made about the topic of education and support in relation to diabetes, there was a 5-year retrospective study of 59 individuals with type 2 diabetes mellitus performed in France. And therapeutic patient education was found to be very effective in reducing both the BMI and the A1C. You know, it's very important. We're talking here about a very important health indicator, which is the BMI and the A1C. And in another cross-sectional study of 100 Lebanese people, individuals with type 2 diabetes mellitus, adults, it was found that it contributed to better glycemic control, better diabetes self-efficacy, management self-efficacy scale, and also the summary of diabetes self-care activities. And this study was proudly done by Dr. El-Gerges, who is on our scientific board at Dialab, the National Diabetes Organization. So I'm very happy to be mentioning it. For the sake of time, I will skip and continue with other researches. For example, in a randomized controlled trial, and those are small samples, as you can see, we are not talking about big numbers, but when we mention DSMES, and we want really to follow up with these patients since the minute they start and discover all the outcomes and the results of this study, for my personal opinion, it doesn't matter if the sample is huge or it is limited to 50 or 600 or maybe 13, like it is in this case, where they discovered that the participants, when they were doing healthy cooking to affect their diet, it was found that they lowered their A1C and also their body weight, and they improved, again, the magic word, their quality of life. There was also this study, the meta-analysis of 696 participants with type 2 diabetes mellitus, and it was discovered that the use of diabetes self-management education and support applications had significant small to moderate effect on medication adherence and HbA1c lowering, of course, the HbA1c and the body mass index or the BMI. We can see endless studies and research being done and showing this. And this makes this topic extremely important, especially when we talk about the management of type 2 diabetes. We know that when we talk education and awareness about type 2 diabetes, we mention two pillars. Definitely after the doctor's visit. Let's not forget that. The one pillar is the physical activity, the other one is the nutrition, which lead us to say how important lifestyle changes, sometimes minor lifestyle changes, can impact tremendously how we are living with type 2 diabetes. And of course, you see how important it is, the self-management through lifestyle. The barriers are many. We have the lack of awareness, the limitation of referring providers who sometimes patients want education. They don't know where to go. They don't know who is providing this education, and the misunderstanding of the necessity and effectiveness of how important is diabetes self-management, education, and support. Also, we have the financial side, the patient-related, such as cost, and we have also the timing, the transportation, especially in the low-income countries. Another barrier is the lack of administrative or leadership support, like the policy needs to be reviewed. We also have another challenge, which is the limited number of diabetes care and education specialists and the limited resources in general to market. Hello again, sorry.
That's okay.
Okay, so my desktop died. I don't have the presentation in front of me anymore, but after the barriers that were mentioned, I will mention that in my conclusion, I'm stating that by educating our patients and by raising their level of awareness on the importance of self-management efficacy, we can reduce the costs, we can reduce the emergency visits, we can make our patients live a much better and higher quality of life, and definitely we can prevent many of the complications related to NCDs, especially diabetes in this case. And those outcomes are incredible. They should tell us how important it is to absolutely revise our policies and try to implement new ones if we find lack of efficiency, and try to implement new policies if we don't have any in our organization, given the importance of diabetes self-management and education. I want to apologize about the interruption, and maybe there was something more I wanted to talk about in my presentation. Unfortunately, as I mentioned, I don't have it anymore in front of me, but I think I was able a bit to highlight the extreme importance of DSMES. And my references were also in the final slides. And my big thank you to all the organizers of DiaCareCon, and especially to Dr. Benchi for inviting me to be on this panel. Thank you very much.
Thank you, ma'am. Even after such technical difficulties, actually your presentation actually told us and showed us how important diabetes self-management and how important diabetes education is for the masses, and especially for us in India, it is very important because there's a lot of diabetes people who are living with diabetes. And diabetes education is what we can, empower them with, because we don't know how frequently they're going to come to us with follow-ups, and how frequently they're going to contact us or connect with us. Being in remote areas, sometimes the patients are in remote areas, but this diabetes education is something that if a person is empowered with, then 10 people around him will be lucky enough to be with that person. So really nice presentation.
Thank you so much. I'll try to remain as much as I can in case there are any questions later. Apologies if I run out of battery on my phone.
No problem, ma'am. Right now, actually, it is just question and answers time. So we are open for questions. If anyone has questions, please go ahead. Dr. Mahira, are there any questions in the...
No, right now we do not have any questions on the chat box. But I would like to ask a question on diabetes education. Now, when it is said, it is more of a patient-centric, individual-centric self-management. So I would love to hear comments on how others, a peer or a doctor or an educator, how they can improve in contributing, improving the outcomes related to type 1 diabetes.
Would you like me to answer that?
Yes, sure.
Okay, great. I will maybe answer your question by talking about our own experience at Dialab. We are a patient association. We definitely have our patients at the center. Their well-being is of utmost importance. And we do use the multidisciplinary approach. So we don't offer care, but we offer what is needed after the visit to the doctor. For example, during the pandemic, it was of extreme importance. I noted on the WhatsApp group that we have for the members, especially living with type 1 diabetes, I noted how much they needed psychosocial support and psychological support, and especially after what we've been undergoing in Lebanon and the explosion of the Beirut port. We had patients suffering with PTSD, and we needed professionals. So we tailor our education as we see, So of course we have a policy that we follow, but as we see the need, wherever we see a need to alter or modify our policies, we do that for the well-being and the benefit of our patients. We invited a psychiatrist to give a talk and to give an educational workshop. We invited a psychologist. We invited a trainer, a physical education trainer, to explain how even staying at home or how they can do certain activity that can make them burn calorie. And also we had a nutritionist, a sports nutritionist at the same symposium to give you an example on how we do the approach, to tell them how to measure their blood glucose before, during, and after, and how to do the reading on that. We also did a training to our patients on carb counting. This is very important topic. They get lost when it comes to carb counting. And if we talk about people living with type 2 diabetes, we have a major barrier or a challenge, which is denial. Oh, I eat very well. And when you go down to counting what they eat, you discover that they need to modify their diet, sometimes simple modification. So usually this is how we do our approach. As I mentioned, it's a multidisciplinary approach and based on the need of our community and on the times we are living. For example, now, just to finalize, I will say that we recently, last week actually, did a symposium on how to store insulin facing the power outage challenge. This is a key component, and a patient needs to know if my fridge is out of power, how many hours my insulin is safe inside there, So, and also other medication, not just insulin. Some medication need to be stored at a certain temperature. So from what we are living, from our environment, we see what needs to be done and we proceed accordingly.
Okay. And ma'am, how long do you follow up these patients? For how long you follow up your patients?
Well, our group has started 12 years ago,
okay.
And it keeps adding, of course, people. Now, let me be realistic, and I think it is the case everywhere. The follow-up with a type 2 diabetes patient is much harder than the one, let's say we have two groups, and those living with type 1 have a higher level of knowledge about their situation, whereas people with type 2 diabetes are more reluctant to follow a certain training. We suffer, but we try to be very persistent until we succeed. But if I want to answer precisely your question, usually we start at the beginning of the year with a group, and we try to see what has changed at the end of that year. So that, to answer you, it's like a yearly assessment of the changes, the impact on what we need to change and what they need to change in order to have better outcomes.
Thank you so much.
Thank you.
Ma'am, one more question. Actually, this question would be both to Dr. Jackie and Dr. Iriana. So the first part of it is that the diabetes education that you're imparting, how is it? Is it when the patient patient comes to your clinic and meets with you, what is that education, or you do it like you have a WhatsApp group, so you send sequential messages to everyone, or every once a week, or every once a fortnight, or something like that, and then you organize some camps or something like awareness camps? Like, how do you do that awareness campaigns? Because when a person comes to us at the clinic, it's easy to explain and it's easy to impart the diabetes education, but how well it is retained and it is carried forward, that is of the question. That is one part of the question. Second part of the question is, like, we had COVID in the last 2 years. So during that COVID time, how was it possible to manage these patients in terms of not just the compliance with the medicines and everything, but also, as ma'am was talking, the psychosocial effects, and the fact that even now we have got studies, and even everyone knows, a lot of the people, they also know that post-COVID, the incidence of diabetes is going up. So a patient who has had COVID can get new onset of diabetes. So that is also creating a kind of buzz amongst all the people in the country and in the city. So how do you come about that? So it's like.
Okay, thank you, Jackie. That gave me first. First of all, thank you very much. It's very interesting conversation. I think it's I like the Jackie say realistic things, because this is very important, being realistic. To be honest, I think it's education of patient education is big gap. It's all, we did a lot. Clinician did a lot. Educator did a lot. But unfortunately, we see that we are not in a stage which we want to, that patient have this measure of glycemic. This is, I think it's also many of us exchange methods, exchange delivery, how we can deliver information. And it's also sometimes work, sometimes not. This is, we know this, everybody. And from my side, from my experience, what we did in Ukrainian Diabetic Federation was, I was before many years, and it's like I support this activity. First of all, this is absolutely multidisciplinary approach from difference, and from my side, it must be professional way, certificate way for who do this, who provide this education. And also, and then we can use have some uniform for this program. And from my side, my personal experience, that very important. Doctor must say, go to course. And I remember from beginning, many years ago, And one doctor who I was in clinic, and one doctor say, you must go to education course. They have education course in clinic. And it was very nice, but maybe not specific, but doesn't matter. But if you, after this, when start course, this is professor go through their clinic and see you in not in course, you will have problem. This is case. It's like also, I want to say that the doctor is very, very have authority of patient, and this your words is very important. And not sometimes need pressure. Please go to a course. After this course, I cannot maybe speak with you. This is also make easier for doctor explain every change. Another case, we use this for camp for adult. It's not only for children, because many people work with children, but for adults. To be honest, work with adults more easier. More you see how it's very quickly exchange situation, but of course it's most important you can engage them. This because it's like we make different type of methods, one times per week with some place which very comfortable in city center, blah 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 blah. But sometimes 1, 2, 3, 5, it's more difficult. They not come. This is not because not interesting, because very busy. And in same times, it's very important that some people who be in group also have authority, and some people with diabetes, like peer-to-peer education. From my side, it's very, very impressed on a patient with diabetes. This is, we must work from every area. We can use every resource for deliver some information. And this is about modern technology. It's a lot resource, a lot patients group, WhatsApp group difference. But it's also challenge from my side, because some people who only deliver your experience, and it's from my side, it's not very professional way, and maybe this is also big challenge for patient, because if it's deliver a professional or some certificate who certificate that education, this is more for me, it's more right way than only send to like suggesting do this. I understand this, but it's like big from my side, big challenge. For example, we have some mother groups. It's more specific, more even aggressive groups who try to deliver his experience to another parents, but sometimes it's not work, and this is not professional. This is I see this is challenge. And that's this is very, very important. Remember, it's a lot of challenges from social groups who want to deliver only this experience. So, thank you. It's too much.
I think Dr. Irina covered the first part of the question, so I will not go into that. Let me address your second part of the question, which is related to COVID and during the pandemic and what happened, because our programs are almost the same, and we address the patients as per the need. I covered it previously when I was talking. So during the pandemic, we were facing many challenges. We were facing the fear. Okay. So it's not addressing. Are you talking?
You can go ahead. No, ma'am.
Okay. During the pandemic, I think globally, we were all facing the same challenges. We were scared. It was the unknown. We heard the WHO even was delivering conflicting messages, not to blame anyone, because it was very new, very unknown. There were no studies on something that nobody knew anything about. So imagine the mindset of a patient during those times. That's why we had to create a shift in our programs. First, before the pandemic, it was all in person. All the educational sessions were in person. We wanted to see the person at our premises or in any place that we had designated for the gathering, depending on the number of participants. Whereas, since the pandemic started, we were forced to shift that online, as did everyone else, I assume. So we started the Zoom sessions. We started going to their homes instead of them coming to us. And there we had more challenges. We had the challenge of people not knowing about technology, not being tech savvies. So they didn't know how to manage Zoom, especially related to the patients with type 2 diabetes. Those are mostly above 45 years of age. So it was very difficult. We started training them on how to use Zoom first in order to benefit from the sessions secondly. And then we had to also train them on safety measures, how to stay safe during the pandemic. I do remember that we did a training in person with an international NGO, Médecins Sans Frontières, Medicine Without Borders, because we wanted them to be safe, to go out of their homes and feel safe, not to be scared. So the pandemic taught us how to manage during crisis. It was a crisis management period. So we changed many things. We started sending tips to their phones, since we are connected, through the mobile. They can see them wherever they are. We intensified our online campaigns through social media. We intensified the posts on social media. So not only the patient himself or herself would benefit from the educational tips, but also the whole family. And Irina mentioned something very important, which is educating the mothers of children with type 1 diabetes. For that purpose, we also have a mothers group, which can be very intense, because every mother pretends to know the best because she is the best for her child. And this is completely understandable. But we need to draw the line between what works for your child and what should be working for every other child. So this is very critical. Again, I believe not only Dialab, every member association or patient association in the world, anywhere on the globe, is doing what they best can. What we try to do is to give support for after the doctor's visit. We try to do the follow-up. We try to do the non-treatment part. And sometimes we do more than we are here for. For example, since the economic collapse in Lebanon and after the explosion of the Beirut port, we were forced to distribute medication. Because people were...
For a while. No, we have already completed with the session, so we need
Thank you very much.
No, you can complete it. Your last sentence, you can complete it, no problem.
Okay, so for that purpose, we were in crisis, like Ukraine now is undergoing very difficult circumstances, and my heart is always with you, my dear Irina, and all your people, and whoever is undergoing difficult circumstances over the world. But Lebanon, we had our own share of problems. We still do, and we hope the best for our patients. And I think the international communities need to keep offering solidarity and support for all the underprivileged or people living in war zones or in difficult and extreme situations. Thank you very much.
Thank you, Jackie. Thank you, Anna.
Thank you.
Wonderful session.
For this wonderful session. Thank you, Banshi sir, my mentor, my teacher, for giving me this opportunity to actually chair this session that is on education, which is really an important part of diabetes management. Thank you so much. Over to you, Dr. Mahira.
Yes, with this, we conclude this session, and thank you so much for sharing your experience and letting us more about education and that we can imply in our lives. And thank you, Dr. Shruti, for chairing this session. Thank you so much.
Can I add one word?
Yes,
Thank you,
Anna, how
Banshi.
are you? Yes.
I'm fine. I want to say thank you, Banshi, that you give the possibility to two young girls, moderate this session and be in this
You know, the
level.
young boy always gives opportunity to young girls only.
It's super great, great. I'm very happy with this.
Yes,
This is
I remember
good
you
luck,
are
girls. Good luck.
We are very young at heart, always.
Yes,
Yeah,
yes,
yeah,
definitely.
super. Yeah, I like it. Very.
Good.
Thank you.
See you in IDF. Hope so.
Hopefully, yes.
Hopefully, I hope
Waiting
so.
for your votes at IDF.
Yes. Okay. Myra, next session you can start with.
Next. AV team, if we can. Yes, sir, you can take away for the next session.
Sachin, you are reporter. If you are there, you can start inviting both the chairperson for the meeting.
So very good afternoon. Very good afternoon to everybody. Thank you, Bansi sir, for making this podium available to all the youngsters and all those who are ready to study and have very good sessions out here at Diacon. So welcoming you at this session. We have for today's session on Diabetic Food Symposium, we have Dr. Vibhakar Vachrajani sir and Dr. Rajneesh Saxena sir. Dr. Vibhakar sir is MS General Surgery, Diabetic Foot and Wound Management Surgeon at Temple of Foot, Rajkot. And Dr. Rajneesh Saxena sir is fellow of RSSDI, fellow Diabetes India, fellow of Diabetic Food Management, consultant diabetologist, food care specialist at Saxena Diabetes and Food Care Center, Ajmer. Sir, both the chairpersons, I request you to kindly introduce the speaker and chair this beautiful session on Diabetic Food Symposium.
Good evening. Dr. Rajneesh and Dr. Vibhakar Vachrajani, please.
Yeah, good evening. Good evening, Bansi.
Good evening, Bansi bhai. Good evening.
So, who should start, Bansi? Should I?
Start, sir. Please start.
Yeah, okay. So, good afternoon, everybody. I thank Bansi and the team for inviting me to chair this session. The first speaker is Dr. Manisha Singh. She is MS General Surgery. She has done fellowship in diabetic foot surgery from Amrita Institute, Kochi. At present, she is an associate professor at Department of Surgery, Gajraja Medical College, Gwalior. She is also a consultant diabetic limb salvage surgeon at Gwalior Diabetes and Food Care Center. She has done a fellowship in FIAGES 2017. At present, she is pursuing PhD and doing study on use of plant-based herbal products on diabetic wounds. And she is a life member of many organizations like IMA, DFSI, ABDI, etc. So I welcome Dr. Manisha Singh. Please, the stage is yours.
Second ACR.
Is she not there on this?
Can you hear me now, sir?
Yes, we can hear you, ma'am. Just adjust your camera. We can hear you well, we cannot see you.
Okay, you cannot see. Okay.
Yeah, now it's proper.
So I express my gratitude and immense heartfelt thanks to Dr. Bansi Sabu sir and the members organizing committee Diacon Care 2022 for holding this prestigious conference. And I'm really honored to speak on the topic clinical practice in prevention of diabetic foot complications, a very important topic. And
your face is not seen properly. So either you slightly down. Yes, now you are looking beautiful.
Thank you. Thank you.
Everyone
So
wants
nice
to
see
see
you.
the Manisha, you know. Your glamorous face is very important.
Thank you so much, sir.
Sorry, madam. Thank you.
Full screen. Share screen. Full screen. Full screen. Yeah, full screen. Okay, sir. So some minor adjustment with the camera. So Diabetic foot disease is indeed a very important disease and the major complication of diabetes mellitus, with a very high rising yearly incidence rate. And it's always, diabetic foot ulcer is always in a state of remission with very high recurrence rates. And to prevent diabetic foot disease, we have to reduce the risk to the patients and also reduce the socioeconomic burden. And so this is of paramount importance. Now, the various key contributory factors for diabetic foot complications, they include the rising age in the male population, the increasing duration of diabetes. It's more common in the males. And with increasing age, the risk of ulcers and amputations also increases. It's more common in the Hispanics, Native American individuals of African Caribbean descent, and a history of repetitive minor trauma to which patient may be unaware. It may be via ill-fitting shoe or a bichia in the feet of an Indian female, or something they're walking in the temples, or a foreign body may get impacted inside the foot, and or it may penetrate the foot. So, and also past history of ulceration in the foot or history of amputation in the foot puts it to the risk of diabetic foot disease, and both are considered to be the major risk factors. The annual incidence of ulceration may be as high as 30 to 50%. Other microvascular complications of diabetes, such as retinopathy, nephropathy, all stages, especially the end stage renal diseases and the dialysis patients, are at a very high risk. In the transplant patients, with whether it's a simultaneous kidney pancreas transplant, because of the immunosuppressants that are given, so it may lead to diabetes and its complications. The distal sensory motor neuropathy, which occurs as a result of diabetes due to small fiber nerve dysfunction, large fiber dysfunction, Charcot neuroarthropathy, that's a painless, painful foot, which is non-suppurative inflammatory condition, motor neuropathy, and they occur in the time-dependent fashion and due to uncontrolled glycemia. The autonomic neuropathy leads to decreased sweating, fissuring, increased risk of field fissures, callus formation, and increase in the ulcer risk. The peripheral arterial disease, a combination of neuropathy and peripheral arterial disease, may give rise to neuroischemic ulceration, the incidence of which is increasing in the current times compared to 50% of neuropathic ulcer, 30% of neuroischemia, which is rising continuously, and even 10% of the pure ischemic ulcers. The presence of deformity of the clotose, hammertoes, Charcot foot deformities, hallux valgus, hallux varus deformity, post-ulcer amputation deformity, they all increase the ulcer risk in these patients. So when we look at this causative pathways of ulceration and foot at risk, we can see that somatic sensory neuropathy, which occurs as a result of hyperglycemia, gives rise to decreased pain sensation, temperature sensation, and defective proprioception, making the patient vulnerable to trauma and putting the foot at risk to the foot ulceration. Similarly, motor neuropathy gives rise to intrinsic minus foot. The introtia, the lumbricals, and the intrinsic muscles of the foot may get wasted, leading to foot deformities, which is a very important factor in the causation of foot ulcers and puts the foot at risk to trauma. The autonomic neuropathy, which again, as I said, leads to dryness of skin or cirrhosis of the plantar skin, decreased sweating, callus, predisposes to callus formation, fissuring in the skin, engorged veins, which can be seen on the top of the foot, and puts the foot at risk and leads to foot ulceration. In addition to immunopathy, which occurs in the background of hypoglycemia. Not all patients with diabetes are, fortunately, not all feet with diabetic feet are at risk of foot ulceration. And however, the incidence of diabetic foot ulceration is very low or unexpected in the absence of these risk factors. So for a foot to be at risk, the diabetic should have either loss of protective sensation or presence of peripheral arterial disease, or other factors such as foot deformity, history of prior diabetic foot ulceration, history of lower extremity amputation, presence of renal disease in the patient. All these risk factors may put the foot at risk for ulceration. So we have to prevent these ulceration, to prevent the mortality, increasing mortality, morbidity associated with the disease, and also, of course, the loss of limb which occurs as a consequence of foot ulceration. So the 5 key elements in prevention, foot ulcer prevention, is identifying at-risk foot, regularly inspecting and examining this risk feet, and educating the patient, his relatives, and also the healthcare professionals to examine and to regularly monitor and follow up these feet. Ensure routine wearing of protective footwear, so that the patient wears it regularly at all times, indoors and outdoors, and also treating risk factors for the ulceration. So for identifying the at-risk foot, the foot screening does not prevent TFU. It only identifies the at-risk foot, and we have to, it also tells us whether there is neuropathy or peripheral arterial disease. But definitely, once these feet are identified, we can be cautious and alert, and absence of signs symptoms does not preclude diabetic foot disease or neuropathy or peripheral arterial disease. Even the presence of the palpable pedal pulses, there may be peripheral arterial disease, and even the foot of neuropathic feet, the patient does not complain, so no examination is done. So if once we have identified the at-risk feet, we should, it's easier for us to screen in the foot screening. Once you have identified these patients, it's very easy to prevent and protect them. Foot screening, however, should be performed by trained healthcare professional on an annual basis. And for the detection of the protective sensation or the neuropathy, we use a standard 10-gram Semseem Swinston monofilament, and this is held perpendicularly to the feet. Examination is done for 2 seconds, and it tests on the certain points on the foot, on the plantar aspect, and once on the dorsal aspect to see for the protective sensation. So once there are, it's 2 out of 3 questions whether the patient is feeling the sensation or not. If 2 out of 3 questions are there, of which one of the touch will be a mock touch, that is alternate touches with the monofilament of the plantar or the contact surface of the foot, then we can say that 2 out of 3 questions, if they are unanswered, or at 2 out of 3 places they cannot feel the sensation for the biothesiometer, Ipswich test, or the Symons-Winston monofilament, then protective sensation is lost. And for the peripheral arterial disease assessment, we can take the cardiovascular history, palpate the pedal pulses. We also do a Doppler signals, ABI assessment, blood pressure assessment at the ankle and the brachial levels. And also, if there's a doubt, if the ABI is low, then we can also go for the advanced investigation such as duplex ultrasound or the DSA or the routine angiography. The loss of protective sensation, neuropathy, and peripheral arterial disease, they are the predictors for the development of diabetic foot ulcers. So identifying the at-risk feet, it is these feet usually have abundant callus at the sites, at the elevated plantar pressure points. That is, the deposition of callus occurs at the sites of increased plantar pressure, which occurs due to the non-enzymatic tissue glycations affecting the connective tissue of the feet, and which is less supple, less elastic. And at these points, slowly callus deposit this thinning of the plantar pad of fat and the thinning of the subcutaneous tissue. And at these vulnerable points, the callus starts depositing, and these high risk points we test the sensation and for the peripheral arterial disease. So annual inspection is must, and if there is no loss of protective sensation or no peripheral arterial disease, but as we go higher up, and then once these sensations are lost, then we have to inspect more frequently. So we can see the various at-risk feet with the plantar fissures due to plantar xerosis, autonomic neuropathy, dorsal callus on the hammer toe, which can be seen, and also the blisters, which can be seen on the feet. These are the sites of continuous irritation by the footwear, the crowding of toes, which occurs as a result of motor neuropathy, the clawing of toes, which are the bent toes at both interphalangeal joints, the hammer toe at the proximal interphalangeal joint, more prone to dorsal ulceration. And so these are the tests of the monofilament, which are demonstrating whether their sensations are present or not, and biothesiometer to see for the vibration sensations, and then the Ipswich test and the tuning fork to demonstrate. To quantify the vibration perception threshold, we have the biothesiometer. Even the heat-cold sensitometry can be performed to see the areas of heat-cold insensitivity. For the PAD, pedal pulses per palpation, ABI, as I have said, ultrasound, and We can see we have to regularly examine these at-risk feet once they are identified and they are marked by the abundant callus or the presence of a small ulcer here and there, or a blister, or any other pre-ulcerative sign, or presence of limited joint mobility. And so these category 1 and 3 should be examined more frequently, once in 6 months for risk category 1, once in 3 to 6 months for risk category 2, and once for every 3 months for risk category 3. Or even for previous amputation, we can examine them every 1 or 2 months. So we can see that the previous amputation scar and the previous ulcer scar, and these are the sites, vulnerable sites for getting re-ulcerated. And we can see that in grade category 0, as I mentioned, there's no LOPS and no PAD, and they have examined annually. Grade 1, the category 1 LOPS or PAD, either of them are present with low risk feet. Grade 3, category 3, we have moderate risk patients in which there are other factors along with LOPS and PAD in combination. Third is high risk, where either of these, and also in addition to that, previous amputation, previous ulcer scars, or end-stage renal disease are present. So then we have to go on increasing the frequency of examinations. So it's important that even at the time of screening, we should start educating the patient for self-care and motivate the family. And for this, the healthcare himself must have received a training. And self-foot care interventions are more feasible, accessible, low cost, and prevent the ulcer compared to the no foot care. So health, these periodic educations must be structured. It should be repetitive. It should be more organized. It should be conducted at periodic intervals to reinforce the education. And the patient must have self-protective. They should be knowing about the footwear, how to do the monofilament test for themselves. If there is any during examination, if they find any area which is dicey, they can consult the healthcare professional immediately. And definitely they should avoid barefoot walking, and always at all times they must be using the footwear, because these are the sites of elevated pressure, under pressure, and they have to protect the feet against trauma or any foreign body. So third recommendation is instruct a patient who is at risk of foot ulceration to protect their feet in the bare and not to walk barefoot. Protect them, even not to use only socks, or not to even use thin-soled slippers or any open footwear for which they may be vulnerable, whether indoors or out there. They must wear a standard diabetic footwear, and the footwear should accommodate the deformities, should also accommodate the areas of excessive pressure, and it should be the middle. It should be half to 1 centimeter, half to 3/4 inch more than the longest length of the toe in the foot. And also width-wise, it should accommodate at the metatarsophalangeal joints, and also it should provide a good room for all the toes to move. So the shoe, it should consist of, it should have a seamless inner lining and outer lining. It should have extended strong heel counter to contract trauma. It should be made of soft leather. The inner should also be very soft and padded. And the insoles should help in the pressure redistribution. And you should prefer a shoelace footwear with accommodative toe box, which should allow the proper movement of the toes. So therapeutic footwear are the footwear which are worn. They are not the off-the-shelf shoes. They are according to the custom, they are the custom made ones, which usually are worn after any ulcer, while any active ulcer is there, or there is any ulcer scar, or there is any amputated toe. So we can use them also as offloading footwear. Now, it's very important to encourage, remind, and tell the person with diabetes to always examine the foot on daily basis, especially the at-risk feet, category 1 to 3, to inspect daily the entire surface of both the feet and inside of the shoes before wearing. Prior to wearing them, wash them daily and dry them, especially in between the toes. Use emollients to lubricate the dry skin, but not in between the toes, and cut the toenails straight. And preferably use a filer. Avoid cutting the corners, and avoid using strong chemical agents or any plasters or any corn caps. that they should be better avoided. Now, it's also important to provide these education in a structured fashion. Just now I had discussed with you and about the appropriate foot self-care for preventing the foot ulceration. And also they should self-monitor the foot skin temperature with the infrared thermometer or the digital thermometer once per day to identify any early signs of inflammation or any pre-ulcerative signs. And this will prevent the very first or the recurrent foot ulcers. However, the temperature should be examined consecutively on the 2 days, on the 2 consecutive days. And if the temperature is high and there's in similar regions of the feet, there's a temperature difference, then we should ask the patient at home itself to restrict the ambulation and immediately consult the specialist whenever the opportunity is there. Now, the patient at risk, moderate risk for foot ulceration who has healed from non-plantar foot ulcer, we should advise therapeutic footwear, the modified or the custom insoles which are made of Plastasort, Poron, Eva, MCI, which had redistribute the elevated plantar pressure at the vulnerable points. And also we should take a pedopodogram, foot scan plate if the facilities are available to see the exact site. And we should try to reduce at these sites, we should try to reduce the pressures below 200 kilopascals. There should be 30% reduction in the foot pressures after wearing these foot insoles, and it should be demonstrable. Then routine wearing of appropriate footwear is also important, and certain toe supports or toe orthoses are also available to help reduce abundant callus buildup in patients with diabetes on the tip of the toes, on the dorsum of the toes, especially in the toe deformity patients. Then silicone is a time-tested or even maybe a padded or foam can be used to separate the toes. And while dressing the foot also, I use gauze to separate the toes. And for the hammer and the claw toes also, we can have the silicone supports. Now, we should ensure that routine wearing of appropriate footwear should be there. In patients with the healed foot ulcers on the amputated toes, they should encourage the patient to consistently wear them. And in the charcot foot, which is painless foot, non-suppurative condition, but it resembles an inflammatory foot. And we should immediately refer such patients to the podiatric or the orthopedic surgeon or the experts who can treat this complication. It needs immediate immobilization, and because it can lead to deformities if not immobilized early. So we can see this deformed foot in the early first week itself, and they can lead to rocker bottom or the chronic charcot foot, which we can see here. And once this deformity occurs, then it's more liable to ulceration, and the presence of callus may be seen at high elevated plantar pressure points, and also the bony protrusion, rupture of plantar fascia can occur if there is too much elevation of plantar pressure. And dislocation, unstable joints and subluxation of the joint may occur. Bony reabsorption and fragmentation may occur in charcot foot, leading to deformity and instability and formation of the foot ulcers at the elevated plantar pressure point. So now, what we do is the serial total contact casting to reduce the formation of deformities and reduce the chances of getting a foot ulceration. And once the foot is already fused, to shift the patient to ankle foot arthritis, the minimum patient to shifting the patient for ankle foot arthritis is usually 12 weeks. And CJ plaster casting, every 10 days to 14 days, we can change the plaster till the X-rays, they show the reduction of the exudates and the bony fragments. So these are the healing shoes and the crow splint or the wedge shoes for the various type of arthritis feet, depending on the site which is showing the elevation. We can use the wedge or the lateral wedge or the anterior or posterior ortho wedge. The customized AFO to support the instability at the ankle and prevent it from deforming, as we can see. Treating the risk factor for ulceration, any pre-ulcerative sign, presence of any infections or onychomycosis in the nail or the web space infection will help to prevent they have to be addressed, antifungals have to be started, and onychomycosis has to be treated to prevent a foot ulceration. Even the ingrow toenails, they can be treated by proper foot care and maintenance of the foot hygiene to reduce the nail debris and also reducing the fungal load on the nail. A good glycemic control, early recognition and treatment of osteomyelitis can prevent amputation in a foot like this, where it was having a paronychia, and when neglected, it went on to have a wet gangrene, and consequently the toe was lost. So prevent amputation in such patients by giving early recognition and having a good glycemic control, prevent the limb loss. So surgical intervention in a person with where there is a failure of the non-surgical treatment, and despite shaving the callus every time, or the ulcer on the apex or the distal part of the non-rigid toe, then we can do for a percutaneous flexor tenotomy for the toe deformities, and also for the plantar fascial release for reducing the formation of the forefoot ulcer. Further, if the patient fails to heal with the plantar forefoot ulcer, fails to heal with despite non-surgical treatment, we should also consider for a tendo-Achilles lengthening. We can see the reduction of the plantar pressure after the performing the tendo-Achilles lengthening procedures. We can also perform the Geller gap arthroplasty so as to reduce the pressure at the metatarsalophalangeal joint, metatarsal osteotomy to release the forefoot pressure by cutting the incising the metatarsals. Claw toe by the girdle stone procedure we can consider for the relaxation at the interphalangeal and the proximal interphalangeal joint and the metatarsalophalangeal joints. Similarly, the prominent metatarsal heads can be resected, or the pan-metatarsal head resection can be considered so as to reduce the prominent metatarsal heads and causing the elevated pressure and making it prone to ulceration. And mallet correction to reduce the deformity at the distal interphalangeal joint, the flexion deformity, we can do a FDL tenotomy, flexor deuterium longus tenotomy. So we, however, recommend nerve decompression procedures should not be recommended, and although they, especially in patients with IWGDF risk score 2 to 3, and in patients who are having excruciating neuropathic pain. Related exercises and weight bearing activity, all these they improve the range of motion at the ankle, also decrease the elevated plantar pressure, and increase the foot and ankle elasticity and range of motion, with the aim of reducing the neuropathy symptoms and also increasing the mobility of the foot and also the pressure reduction at these points. And also we can communicate to a person with diabetes who at low or moderate risk of ulceration, great risks category 1 and 2, that increase in the level of walking, related exercise, weight bearing by a small level like 1,000 steps per day is likely to be safe, and especially in the weight bearing patients. Advise this person to wear appropriate footwear, because definitely wearing a footwear will reduce the pressure by 200 kilopascals at those vulnerable sites. And frequently monitor the skin temperature after coming home from a walk, and to also observe during foot care and regular foot care for the pre-ulcerative signs or breakdown of the skin. Now, providing integrated foot care, which includes the adequate knowledge about the footwear, structured education about the self-care, and professional advice, and also regular follow-up of the such feet, especially in the risk category 3 patients. This is to prevent the recurrent foot ulcers, and it focuses on regular visits to the podiatrist and other members of the diabetic foot care team so as to prevent these ulcers and also prevent the recurrence of whether for a first time or whether a recurrent ulcer. So our goal is not necessarily to prevent every wound, but we should have maximum ulcer-free, hospital-free days by reducing the number of complications of each wound recurrence. And there are, they are mainly focusing on the maximum ulcer-free days, integrated foot care, self-management activity, foot behavior, therapeutic footwear, using of therapeutic footwear on a regular basis, adherence to the protocols which are told on every follow-up visits to the patient, and if necessary, go for a prophylactic or a reconstructive foot surgery so as to reduce the deformities and the elevated plantar pressures at these sites. So to summarize, those at low risk or zero are considered to be very low risk, and we have to do an annual examination for signs and symptoms to assess whether there is development of loss of protective sensation or peripheral arterial disease, and to see whether the risk is increasing. Low to moderate, or that is category 1 or 2 risk patients, we have to instruct them to have undergo more of foot mobility exercise and monitor skin temperature, and wear on weight bearing basis, we have to increase the level of walking and ensure that you are wearing a footwear at those times. Moderate risk or grade 2 and grade category 3 and category 2, we have to self monitor the foot temperature, use a therapeutic footwear at all times, and if as advised by the professional, if necessary, customized footwear, insoles, and avoid nerve decompression procedures definitely. And for risk category 1 to 3, we have to screen for the history of previous ulcer, previous amputation, end stage renal disease, and progression of any foot deformity or a callus, pre-ulcerative signs. And we should adhere to the therapeutic footwears or the regular footwear, inspect the footwear, and to preventive care of the foot ulcers, use orthotic interventions so as to reduce the abundant callus, and treat the pre-ulcerative, treat them, the knee grow toenails, fungal address them, because with the regular foot care, we can diagnose them early, pick them up early, and we have to address them as early as possible to prevent the diabetic foot ulceration. With the very high risk patients, we have to focus on regular therapeutic footwear and also prevention of recurrence. So integrated foot care here is very important, and we have reevaluation of follow-up at regular intervals. Thank you for the patient hearing. Thank you for the patient hearing. Can't hear you.
Thank you very much, Dr. Manisha, for nice presentation. You nicely cover all the aspect of diabetic foot limb salvaging and how to prevent diabetic foot ulceration development. Congratulations for wonderful presentation. Now our second speaker is Dr. Vijay Viswanathan, sir. Dr. Vijay Viswanathan is the renowned figure. He doesn't require any introduction. He is head and chief diabetologist from MBA Hospital for Diabetes and Professor M.B. Viswanathan Diabetes Center, Royapuram, Chennai. He is first non-European president of DFoot International, based in Belgium, and consisting of expert in diabetic foot. He is national vice president of RSDI. He completed MD in internal medicine in the year 1991 and worked under Professor M. Viswanathan for 5 years. He completed 31 years as a diabetologist, PhD in diabetic nephropathy from T&. Dr. MGR Medical University in 1999. He is the recipient of the first Vivian Fonska Award from the American Diabetic Association for the research paper on diabetes and TB in the year 2013. He has research interest in prevention of diabetes and its complication, and has published over 300 research papers in peer-renowned journals. Now I hand it over to Dr. Vijay Viswanathan, sir.
Thank you, Dr. Mishra, Dr. Vibhakar, my good friend, and Dr. Rajneesh for this introduction. And I'd like to thank Dr. Bansi Sabu for inviting me. I'm so sorry that I could not make it to Ahmedabad, but definitely next time I should be able to go. So in the next 10 minutes, I'm going to talk to you on a very important subject, and that is how in India we can develop footwear for people with diabetes. And I'm going to share with you my experience in Chennai. See the full screen here. So this was a paper which we published in Diabetes Care in 2006. So people from rural India do have a lot of amputations compared to people from urban India. And we found that it was barefoot walking and improper footwear which was the cause for the greater amputation of people from the rural areas. So we recognized the need for footwear which is available at an affordable cost in India. So that's the basis for starting this foot clinic and footwear manufacture in Chennai, and it was with the aim of preventing amputation. Many people in India were wearing this sort of footwear, which is very cheap. You get it for 100 rupees, and it invariably leads to problems like these. And you can see that there's no counter for the footwear. So these are chappals. So these are called chappals, and it's very popular in India. So 1991, because we found that a lot of rural area people were getting amputations due to improper footwear, we started the work on footwear, and we started looking at materials apart from microcellular rubber. So you can see that this is PU foam and EVA sole. And I started using the services of local shoemakers who were available in the streets to make footwear. Soon I joined hands with the Central Leather Research Institute, and we did some studies. First, we saw that along with the CLRI, we found that customized orthosis will cut down the healing time. So we were able to show, along with colleagues from the Central Leather Research Institute, that the foot ulcers will heal faster if you give customized orthosis. So this was a study which opened our eyes to show that it's possible to prevent amputations and heel ulcers in India. We then use an anthropometric survey because we needed to know the foot sizes of people with diabetes. So we wanted to standardize the foot sizes of people with diabetic foot ulcer, and we did an anthropometric survey, and we used a 3D laser foot scanner and published this paper where we looked at foot sizes in India, because we had to make the last and so on to make the footwear. We then went on to some more sophisticated methods like QFD or TRIS, and you can see what is QFD here. We use the higher methods. QFD looks at quality function deployment, which is a quantitative tool which aims at giving the topmost priority to the needs of the customers. So we used some higher software, and we looked at improving the design of therapeutic footwear. With this knowledge, we developed footwear for people with low risk, as you heard from Manisha, IWGDF, class 1, just high risk feet. They have the sort of EVA sole, and you can see the EVA sole and the counter and the upper, which is adjustable through a Velcro. This is Velcro, and you can see that it's very important to have a footwear for people with high risk feet or neuropathy who have not yet ulcerated. So this was the ladies' model, this was the men's model. And in people who had past history of ulcers, we developed footwear which was developed a little more sophisticated way, which I'll show you in the next 8 minutes. So these were footwear which were developed by CLRI and our institute. We looked at the effectiveness of the different types of footwear insoles, and we published a study in Diabetes Care. And we found that those who are using the therapeutic footwear, using the methods which I told you just now, showed lower foot pressure. And also we found that the occurrence of new lesions was significantly lower in patients who used 4%, who used the customized insole and therapeutic footwear. People who used the same footwear like Hawaii chappals and so on had a much higher prevalence of new lesions. Then we moved on to people who were not accepting the designs. So we moved on to another institute called the Central Footwear Technical Institute. The CLRI and the CFT are both in Chennai, and we were fortunate that both of them cooperated and worked with us. So the students of CFTI developed some stylish footwear, and you can see that we have still developed more models now. This is an old slide. So this is for people who have not yet ulcerated, who have a high risk feet, or who do not have even LOPS, who have not yet ulcerated and have normal sensation. So you can give such footwear, and you can see that there is a counter and an adjustable. The front part should be adjustable, and the insole is soft. There won't be any stitches anywhere here, and the insole is soft, and the outer sole is quite stiff, so you can't bend the footwear in your hands like you can do the Hawaii chapel. So this is a classical footwear which is used for people with high risk feet who are not yet ulcerated. With these designs, we developed this footwear manufacturing unit about 10 years ago, and we started making machinery. We started making people make footwear using machinery to make footwear so that we could use about this modern technology to make about 30 pairs of footwear every day. In the last 2 minutes or 3 minutes, I'll tell you about how we offload patients who have active foot ulceration. So if you have a person like this who's got an ulcer and Charcot foot with a collapse of the midfoot, you can see that you need special footwear. You can't give the footwear which I showed you in the earlier slides. You need special footwear, and that also we started making. Now, one of the methods is what is used in leprosy. You can take a negative, you can put a POP cast, make a negative and then make a positive, and make a insole made of, which is called molded footwear. And this is used for people with Charcot foot. Whatever footwear you use, I think it's important they use it. So we found that people who did not follow the advice and did not use the footwear which we gave them developed a lot of problems. And this was a publication in Diabetes Care in 2005. And they required more surgical procedures if they did not follow our advice. Compared to those who took our footwear and followed our advice, the people who developed new lesions was only 5% compared to 26%. And people who required surgical procedures were only 3% compared to 14%. Now, Charcot foot, as you heard from Dr. Manisha, needs a soft crow restrained walker, but it's very expensive to import it from Europe or United States. So we developed our own crow device, which costs only about 1,200 rupees. And we have used it in people in the last two decades and found very good results. I'd like to conclude with the IWGDF guidelines, about which Dr. Manisha talked at length. I was fortunate enough to be associated with the IWGDF from 2015, and this is the 2023 offloading guidelines, where I was fortunate enough to be in the midst of David Armstrong, Brian Cruz, and all the others. And we are right now writing up the offloading guidelines for 2023, which will be published in May 2023. Now, in the IWGDF guideline, I insisted that the ankle foot orthosis or knee high orthosis may not be available in the developing world. So what we are writing in the 2023 guideline, I'm not supposed to say it, but we are advocating the use of felted foam. Felted foam is quite useful in the developing world. It's there in most of the countries and in the low middle income countries. And if you have an ulcer here, you can use a felted foam to offload these ulcers. And you can use felted foam, and it's got a fairly good evidence of using felted foam in the low middle income countries. But people like this who have an ulcer and no infection, no peripheral artery disease, they would definitely do better with a total contact cast, non-removable cast. So we are writing up the TCC and the felted foam in the IWGDF guidelines. So I'd like to once again thank Dr. Banshi Sabu and apologize for not being able to make it to Ahmedabad this time, but definitely next time. Thank you very much.
Thank you, sir. Thank you so much for very nice and very illustrative, photogenic presentation where you discussed your very eminent experience. So over to Dr. Rajneesh sir again for our next speaker.
Thank you very much, Saurabh. Next speaker is Dr. Jay Shah. He is a postgraduate and UHM CWSP FA fellow of APWCA, FCCWS, and so many fellowships he has in their credit. Dr. Jayesh Bisa is an award-winning wound care and hyperbaric physician in active clinical practice. He is trained from Columbia and certified in wound management, board certified in undersia and hyperbaric medicine and internal medicine. He is a fellow of undersa and hyperbaric medicine, American College of Physicians and American College of Clinical Wound Specialists. He is a super educator with extensive speaking experience. He is the president of South Texas Wound Associate, where he provides clinical wound care services in San Antonio since past 22 years. He is the president of Time O2 Healing Concept LLC, which provides consulting and education service in wound care and hyperbaric medicine. He is medical director of Wound Care Healing Center at Northeast Baptist Hospital and Mission Trail Baptist Wound Care Wound Healing Center in San Antonio. He has also attached with so many institutes. Now I invite Dr. Jay Shah for his presentation.
Hi, how are you? This is Dr. Jayesh Shah from San Antonio, Texas, and I want to thank Dr. Bansi Sabu for inviting me again. And today he has asked me to talk about some of the newer techniques that's out there for diabetic wound assessment. I hope you are having fun in DIACON. I'm going to miss you in person down there, but I know Dr. Bansu Sabu has planned a good entertainment evening too. So hopefully next year I can be in person. So again, some of the disclosures that I have some books and the app, which is free app, Wound Doctor app that you can use, and a textbook on wound care. But let's discuss the topic, and I'm going to talk about the wound assessment and how we can use some of the innovation to do better assessment on our diabetic ulcers. So when you are looking at an ulcer or a wound, what you're trying to do is at least assess some basic stuff. So this is from Dr. Keith's article in 2004, where he came up with a meme that at least for assessing a wound, you should remember this meme about measure. So at least the basic things you need to do is do the good measurement, and most of us do rural method, and there are now some new techniques coming out that can help you do this measurements more accurately. But right now we do rural method, so do it accurately, length, width, depth, and area. So you want to make sure you're doing it consistently and you're doing it in a right way. Basically we do head to toe length, largest length, and perpendicular to the largest width. Okay, so same thing we do with exudate management. Make sure you do proper assessment of quantity and quality. Appearance of the wound bed is so important, because if you know how the wound looks like, then you can manage it correctly. So you need to know what you see on the wound, like how much granulation tissue there is and what kind of granulation tissue is there. Is it friable, because that can indicate infection, or is it spongy, which could be again infection? If it is pale, maybe you're worried about circulation. So think about what kind of granulation tissue is, and remember the good granulation tissue is very, very strawberry appearance, and it's tough, and they call it beefy red. Okay, again, so you want to be able to know what is necrotic tissue, what is fibrinous tissue, what is slough, and so you can manage that and decide what the treatment to do. assessing pain level is equally important. Assessing for undermining or tunneling is equally important. And then looking at the edge. A lot of times we want to understand that the wound edge is where a lot of the healing is happening. So you want to be looking at whether you have an open wound edge, which is a reproductive epithelium, or is it a closed wound edge where there's no reproductive epithelium, or you have an epibole where your edge is kind of going inward in and rolling in, and it's just not letting you do the epithelialization. So again, very important to do a good wound assessment. Another important part or a concept to understand is about wound assessment is a biofilm. Now, this is getting very widely accepted. Biofilm is present in majority of hard to heal wound and is kind of barrier to healing. Right. So a lot of times biofilm is not visible to naked eye, though there are a lot of other assessment technique that can help you with looking for biofilm, like when you see a friable or spongy granulation tissue. But it's a very important concept because a lot of times these wounds are not healing because they have a chronic wound infection causing biofilm. And delayed wound healing is considered a notable, recognized kind of an indirect sign of biofilm presence. So we just want to make sure we understand. And a lot of times this biofilm rapidly forms, and even if you debride, it comes back in a week, and there's an extensive regrowth within 24 to 48 hours. And so sometimes you have to re-debride if you are not treating the biofilm. So again, how about if you can get an innovative assessment technique that can help you detect the biofilm? And as you all know, the picture is more than 1,000 words. And so if you have an innovation that can detect biofilm and infection, which cannot be seen by naked eye, that will be awesome, right? So, you know, the fluorescence signals from tissue and bacteria can help you, and take a picture, and based on the color, you can decide really what kind of infection your wound is having, and that can help you empirically treat it locally and systematically. So, so basically, if you throw a fluorescence light, you're going to see two or three main colors. The one is a cyan color. So cyan color, when you see, it is because of endogenous pyowerdines, which is unique to Pseudomonas, and that is the one which is causing that cyan fluorescence signal, and that helps us know, oh, the wound is infected with Pseudomonas, I need to treat that. Or if you see a red fluorescence signal, that is basically an endogenous porphyrin in the heme pathway that produces the red fluorescence signals. This includes gram-positive, gram-negative anaerobes and aerobes. So that at least helps you to decide really what kind of antibiotic empirically I want to treat by just doing a little picture. Now, rest of the things that you can see are sometimes give you a green fluorescence, which is basically matrix component like skin, slough, and other tissues. So again, this is kind of a basic concept where you can take a picture and really decide what's going on with this patient. Like this diabetic patient who has a long-standing non-healing grade 2 wound, and we are wondering why this wound is not healing. You take a picture and you really see that red fluorescence. So you know that this patient has some infection, and you also know what you need to debride because you want to get that debrided also. That also you know at the same time, and you know that you need to treat the biofilm. So I think it helps multiple ways by detecting biofilm as a point of testing service, because you can manage those wounds better. Okay, so again, it's a very emerging science. There are a lot of literature is still developing, but I'm just going to show you my experience of what we have used in the clinic and how it can be useful. Okay, it's still not available in majority of clinical environment, but we are going to see that this is going to be something which is going to probably become standard of care because it helps you to decide at point of service what you need to do. Okay. So if you really look at this study where they, which was published in Journal of Wound Care, they patient 43 swabs, and the swabs were basically taken using Levine technique. And you all know the Levine technique, right? You want to clean the wound with saline, and then you want to put a swab on the depth of the wound, and you want to put it so that you can get the fluid within the wound. So you're pressing on the depth of the wound in a 1 square centimeter area for 30 seconds. So, that's where you're getting that, so you're getting a more accurate swab culture. And then you want to assess this microbiology by culture analysis. And you found that, red fluorescence, the red color was, 95% of these swabs were positive for bacterial growth. So red fluorescence was associated with a positive predictive value of 95% and negative predictive value of 100%, with sensitivity of 100% and specificity of 78%. While cyan fluorescence, this is very significant, 100% sensitivity, 100% specificity. So if you see a cyan color, then you are 100% sure that this patient has, Pseudomonas infection. So this is very good to know that, even when only a lot of this patient did not have overt clinical signs of infection, we were able to detect biofilm or detect that chronic wound infection, which is delaying healing, by doing this point of care testing, and which is very, very important. So again, to really summarize, this is again from the pilot study where they looked at this imaging device in outpatient wound care clinic like ours, and they basically looked at what color you see, and like you see red, it's potentially pathogenic bacteria. If you see green, it's connective tissue. Dark and black is blood, highly vascularized tissue, necrotic tissue, or pigmented lesions. And if you see a cyan color, it's a Pseudomonas aeruginosa. All right, let's look at this case study. So again, that same diabetic wound patient, that is, as you see, where you saw the red fluorescence imaging appear as orange red or blush pink. Here, when we did the culture, it grew heavy growth of Citrobacter courseri, and this is how what looks like after we debrided the wound. So again, this is how it looks, diabetic wound. So we can exactly debride that area, and we can know, take care of that biofilm or take care of that things that's helping. And if you remember, this biofilm literature comes from dental literature, where they tell you to floss your teeth because you keep on forming plaque, and similar kind of situation we are seeing with the wound arena. Okay, so again, this is another diabetic patient with a necrotic wound. As you see from just taking a picture or clinical assessment, you see a little bit of erythema, but it's very hard to say if there is infection or not. You put a fluorescence imaging, and you find, oh wow, there is a red fluorescence right here, and we know that there is infection, and we debride, do culture, and it grows heavy growth of mixed coliform and mixed anaerobes. While this diabetic patient, as you see, there is a callus and there is an open wound. Just looking at it, it's really very difficult clinically. There is no overt clinical signs of infection. Hard to know if there is biofilm or infection or not. You take a picture and you see that little red fluorescence right there, and you need to debride that callus tissue, debride this more thoroughly and do a culture, and it does grow heavy growth of mixed bacteria. So again, these are just some of the examples where you can see that it can be very, very helpful to decide how much to debride and how to control that bacterial biofilm. Okay, so in this study, where again in Journal of Wound Care, where they looked at that, they were able to measure the wound with this device with 95% accuracy. So this is better than our length, width, and depth, because this tools are also able to measure the wound, and that is again very, very useful. In the clinical trials of 50 wounds, 70% of the study demonstrated positive bacterial fluorescence signal. Okay, and Levine sampling of wound was found to underreport bacterial loads relative to Florence guided curated sample. So again, this is very, very important that, when you do the Florence documentation of bacterial presence and the location resulted in more aggressive, like fluorescent targeted debridement. You were better able to do targeted debridement. And now there is a newer study. It's still not published. It's still under the white paper that's going to come out very soon, which they show that in diabetic foot ulcer, it improved the outcome when they decrease the improve the outcome, healing rates, decrease amputation when this tool was used. So again, this is a good tool because it helps you to have a standard of care debridement. Out of 70 to 20, this patients you can do fluorescent targeted debridement, and that helps you to do better debridement and making sure you're clearing all the biofilm edge or the tissue that could be infected with biofilm. So this is really a good technique. Like this patient, if you look at this wound, absolutely, this is, again, a diabetic, but a venous stasis ulcer. And if you look at the wound, it's shallow, it looks fine, right? Just to the naked eye, it really doesn't have any clinical signs of infection. You take a picture and you see that there is a cyan fluorescence. Again, cyan fluorescence, 100% that this is going to be Pseudomonas, both sensitivity and specificity. And now I debride that, debride it, and use antimicrobial soap that we use for 10 minutes. And you see the immediate results. You take a picture again and you see the cyan fluorescence post-debridement has gone down. And after 10 minutes of soak, that bacterial count has gone down. So you can really use this as a point of testing of really, are you doing a good job with what you're doing with your debridement or whatever therapy you are doing? Is it helping? Is it targeted? So this point of service technique is very, very good. Okay, so here there is no, as you see in this patient, again, diabetic, it's in the lateral foot. If you look at it, not clinical signs and symptoms of infection, but you can see that there is still a little friable granulation tissue, but there's little epithelialization also, and there's little maceration, little erythema, but not a very good clinical sign that you can say, just looking at this wound, there's a subtle sign, but you can't look at the wound and say, oh, there is infection. You take a picture and you see a cyan fluorescence. Okay, you debride and you do an antimicrobial soak, and you can decide, oh, I need to do a little bit more. There's still, after post-debridement, there's still little cyan fluorescence, and I need to do a culture and need to treat with antibiotics. I'm not able to get rid of everything. So you might know how much to debride by doing this picture. So this is, again, a good technique, point of care service, and really improves your outcomes on a lot of these patients. Again, this patient, if you look, diabetic wound, again, when you look at this patient, not obvious clinical signs of infection, no redness, erythema, or drainage, but you take a picture and you see evidence of red, bluish fluorescence, and now you do a debridement and you see a partially reduced fluorescence after debridement and antimicrobial soak. So this is, again, an important tool that you can use. This is just for the fun, this is a lymphedema patient, and we wanted to look at the whole leg and see what we find. And you see cyan fluorescence throughout the leg, and you know that this patient has a lot of drainage, and we know that he has a chronic Pseudomonas infection, and you can light it up on the camera and you can see. So we used antimicrobial soak and treated the whole leg for Pseudomonas. So again, this is really a great technique. This is also used to decide if there is no infection, right? This lady, a lot of times I'm always nervous when there is an hardware and then there is an open wound and you are worried, oh, is there an infection there, or I'm gonna get into trouble later on. So again, you look at the wound and you say, yeah, there is no clinical signs of infection, but you can measure the wound, and yes, indeed, you can measure and you can take a picture, and yes, indeed, there is no fluorescence, and you're kind of satisfied that this wound is not having any fluorescence, there's no infection, I'm not worried about, and it will heal. So it also is a negative help too. Like here you have an amputation, there's a little wound and it's healing well, and you want to make sure, is there any infection below that margin or anything. You can take a picture and here you find no cyan fluorescence visible. So again, this is a good tool. This wound, easily you can see that this wound has a edge which needs debridement by naked eye. But when you take a picture, you find that cyan fluorescence right there. And yes, indeed, you debride, and as you see that cyan fluorescence is very less, as you see by doing a good debridement. After that, your cyan fluorescence has gone down. So this is, again, a great technique. This is a patient with scleroderma and has this difficult, painful wound on the finger. Again, this is when you take a picture, you find that cyan fluorescence, but you find no cyan fluorescence or red fluorescence. So you know this is more ischemic and not infection, and this is after debridement. All right, this is another patient where a diabetic patient right on the ankle, this wound, and you find that red bluish visible in the wound periphery, and post debridement, beautiful, completely gone fluorescence. As you see, it tells you that, oh yeah, you did a good job with your debridement and that infection is gone, right? This is again venous stasis ulcer with little fluorescence, as you see, and after debridement or just by after debriding, you see that there is decrease in the fluorescence. So again, this is a good technique that can be useful. Another technique that can be useful that is very helpful in our outpatient wound clinic is called a newer infrared spectroscopy, which is up and coming technology, has been successfully used to evaluate functional tissue oxygen saturation in management of the wound. So this is another newer option that's out there to detect evaluation of oxygen delivery and microvasculature evaluation. So basically, again, this technology is used reflected light to calculate perfusion by taking advantage of subtle color changes that occur in hemoglobin when it is oxygenated. And this NIRS transmit very specific wavelength of light between 600 nm to 1000 nanometer. And they allows for either a selective absorption or reflection of the light. And then the amount of light which is reflected can be measured to determine the ratio of deoxygenated to oxygenated hemoglobin. So this is, again, picture is worth 1,000 words. And now you have an innovation to visualize oxygenation on the wound bed. Very good. This is the diabetic end-stage renal disease patient. You have transmetatarsal amputation, open wound, which is not healing. This is before going into hyperbaric oxygen therapy, and as you see, there is the red light indicates oxygenated, and you see that there is a 75% of oxygenation and 66 to 75% on the bed. And now after hyperbaric oxygen therapy, you check it again, and it goes on that it's gone up 69 to 77% to 70. So you can take an average, and you'll see that just after 2 hours of hyperbaric oxygen therapy, it is lightened up. Similarly, this one you can see pre and post hyperbaric diabetic wound patient, and you see that oxygen has gone up. So now just after 2 hours of treatment, so you can see that what I'm doing, whatever intervention I am doing, I can take a picture and see that, yeah, it does show an incremental increase in oxygenation. So it is going there and it's helping, right? So at least this is another one with tendon exposed. And as you see, that is here, we are doing incremental every day from September 22 to 24 to 29. And as you see, by daily hyperbaric oxygen therapy, is there any continuous increase in oxygenation? And we find that that is not only that pre and post hyperbaric, there is increase in oxygenation, but incrementally, when you are seeing it week after week, you find that there is an increase in oxygenation, as you see in this slides from 22, 24 to 29. Again, this is another patient where we did hyperbaric oxygen therapy and followed the oxygenation pre and post HBOT and try to see if there is an incremental rise in oxygenation. And as you see, from September 14 to October 7 to October 19, there is increase in oxygenation. So that's pretty neat. Okay. A lot of times we do hyperbaric oxygen therapy for radiation injury. This is someone who had a breast cancer and had a radiation wound. And again, we check this pre, and you find that pre-oxygen is very low, 39%, on the wound bed. Peri wound is around 61 to 64%. And you find that once you put them in hyperbaric environment, its oxygenation is 69 or 70%, and peri wound is 66 to 77. So both of them increase just after pre and post hyperbaric. This is a tremendous improvement, right? So I know we do transcutaneous oxygen studies. That is kind of a standard of care. I've been using this for last 25 years. Transcutaneous oxygen studies. We just recently got NIRS, and so I'm still do TCOM on most of my patients because I know the TCOM has been studied and has been used for a long time. And in a lot of studies, we have found that TCOM is more valuable in deciding healing failure than anything else. And so when you have to decide whether this candidate is good for hyperbaric oxygen therapy, whether at that level of amputation this wound is going to heal or fail, then I still feel I make my decision based on TCOM. Okay, but if you look at some of the studies, Boy et al. Found that both NIRS and TCOMs were used to predict the presence of arteriography proven lesions. The results showed that NIRS had lower diagnostic accuracy than TCPOT for prediction of arterial lesion. But the pilot study by Serena that recently came, where he compared TCOM and NIRS in hard-to-heal wound, and he found there was a strong correlation between both, with NIRS having slight advantage, allowing measurement of oxygenation within the wound bed, and a simplified approach to oxygen measurement as compared to TCOM. So again, that's something that you may want to be looking at. This is based on a very small study by Lensman, by 15 or 20 patients, and he basically kind of based on that find out how do we interpret the results when you are taking a picture and you are looking at the oxygenation. So two things you want to look at. You want to look at what is the oxygen within the wound bed and what is the peri-wound oxygen. So when you have a wound bed oxygenation greater than 60% and peri-wound between 60 to 80%, then you will find, and you find wispy and non-uniform density in peri-wound areas. And your clinical appearance, you see wound bed is granular with surrounding tissue normal in color and temperature, and you say the prognosis is excellent. If it is less than 40%, and if your peri-wound is between 0 to 50%, you know there is poor wound oxygenation in wound bed and surrounding tissue, and you probably have gangrene and necrosis when you see in the margin, possibly dusky, and your prognosis is poor. So in my clinical experience, 1 and 2, I can see that is really helpful. But 3 and 4 is not really that much helpful to decide what to do. But in general, if you have an oxygenation about 80% and the wound bed is about 60%, then you know that wound is well oxygenated, and you need to look at other things that's causing problem with wound healing. And if it's less than 40%, then you need to look at hypoxia, ischemia, and that is the reason why this wound bed is not, or wound is not healing. Okay, so let's look at other things that we have used this technology. Like I had a patient other day who had a cerebral palsy and had a contractures and so very contracted. It was very hard to do a vascular assessment on this patient. So, but it was easy to take a picture. So I wanted to make a decision whether I should debride or not debride. Am I gonna, if the vasculature is not good, and if I debride, the wound may get worse. So I said, let me check this by just taking a picture. And I looked at the picture, the oxygenation was good. So I felt comfortable that let's go ahead and debride, because I was not going to be able to send her for vascular assessments. She had a lot of contractures and there was no way they will tolerate that procedure. So there was an easy, quick assessment for me to do bedside point of testing to be able to decide whether to debride or not. Same thing here. This patient was seen by vascular doctor. He had done an angiogram. They've done angioplasty, but their post angioplasty results were not good, and they were saying there was still a lot of disease there, and they told the patient really not to debride, because we all know that if you have a bad vasculature or ischemia, then your wound can get worse. So again, that patient came to me, and when I did the NIRS picture, I found that oxygenation was not bad, and this is the picture. The center was 78% and was 74%. So I told the patient that, look, it looks like there is perfusion going in the wound, and if you want to heal this wound, I need to debride this necrotic tissue so that that wound can heal. So again, I felt comfortable debriding on a patient who had a marginal vasculature by having this good picture. Similar situation here. This is again a diabetic patient. As you see, there's a hemato, and this toe has deformed. And if you look at this wound, you find that and a similar situation. The vascular doctor was saying this person needs BKA, does not have a good circulation. So again, and already has a toe deformity. So they were feeling that this is not going to heal. But when I take a picture, I find a good oxygenation. So I said, well, we're going to work on it. We do wound care, do debridement, local wound care, and this wound heals with local care. So again, there is a way to use this technology. Again, this patient comes in to me, had a fall, had a dislocation of elbow, dislocation at the elbow, and that was fixed by the orthopedic surgeon. But after they fixed that dislocation, this patient suddenly developed the discoloration in this.
Dr. Sachin, we are already getting late. Please conclude in next 1 or 2 minutes.
I was worried, is this ischemic or
Dr. Jay, sir,
just from trauma or bruising? Quick picture, and you find good oxygenation, and I could see that this is bruising, and I followed it up, and yeah, indeed, this patient did well, and there was really not a problem. This was just a trauma and the blood and bruising from ecchymosis, and really not an ischemia. Okay, well, she did have a pulse, so yeah, there were other clinical signs which helped me decide, but her hand was cold, and so it was helpful to have another clinical image to tell me that this is really not acute arterial insufficiency.
I hope this
just ecchymosis. So in summary, new point of care assessment technology is revolutionizing wound care and how we assess this wound. This technologies do leverage best patient care, and that is what you want to use technology. That's our goal. So I feel that this fluorescence imaging and infrared spectroscopy are kind of portable devices, and that can be incorporated in our daily wound care practice. Wherever we go, we can take it with us and make a point of care decisions, and that might help our patients and really improve the standard of care. And that is what I have for you.
Rajni sir, Dr. Rajni sir, it is a recorded session, so we can ask
my email. I will give it to you if you have any questions post this presentation. You can contact me on my email. It's wounddrshaw@gmail.com. Okay, I'll ask Dr. Basu to send my email to all of you, and good luck with your conference. I think this is we hope this pandemic is over and we can meet in person. And
so thank you esteemed doctors for very patient listening and very interactive sessions by all the three speakers, Dr. Manisha ma'am, Dr. Vijay sir, and Dr. Jayesh sir at last. And not taking much time as we are running out of time, I also want to thank the chairpersons of this Diabetic Foot Symposium, Dr. Rajni Saxena sir and Dr. Vibhakar sir. So if we have any discussion points, then we can discuss. Otherwise, we can continue towards the next session, that is what a physician should know in terms of diabetes.
There is no question in the chat box, so now we
thank you
very much. Thank you very much to Bansi Sahu bhai. Thank you very much for giving me this opportunity to be here. Namaskar.
Thank you, Bansi and the team. Namaste.
Thank you very much.
Yeah.
So moving towards the next session, we have Dr. Nimi ma'am, who will be taking this session on that what a physician needs to know. Dr. Nimi ma'am is MD, fellow in diabetologist, and a founder consultant diabetologist at Dr. Nimi's Diabetes Care. I welcome you, ma'am, and request you to further take over the session.
Thank you, Dr. Sachin Mishra and esteemed faculty. So for this next session, what physician should know, I invite our chairpersons for this session, Dr. Padmanabh Jinjuwadia. Padmanabh Bhai is MD Medicine and consultant diabetologist, and he runs his own clinic, Adya Diabetes and Medical Care Center here at Ahmedabad with us. Welcome, Dr. Padmanabh. We have Dr. Viral Raj. He is MD Endocrinology, FID UK, fellow RSSTI, and he practices at Bharuch, Ankleshwar. And I welcome Dr. Viral Raj.
Thank you, Dr. Nimi, and thank you to DIACON organizing committee for inviting me as a chairperson for this session. And to chair the session in front of the renowned speaker is also an honor. And I would like to invite Dr. Samar Banerjee for the next session. And our topic is gut microbiome and the diabetes. And sir is a renowned diabetologist in the Calcutta, and also the president as well as the chairing the various organizations like RSSDI, DIPSI, Indian Society of Hypertension, president of Association of Clinical Diabetes, editor-in-chief of Journal of Clinical Diabetology. Sir has also authored 9 books on diabetes and also expert in the various super specialty in GDM. Sir has a glorious tenure in the Neelaratna Sarkar Medical College, Kolkata, and he is rendering praiseworthy experience to the medical students in Vivekananda Institute of Medical Science, and also one of the founder of DIPSI in India. He held knows of prestigious position like chairman of Association of Physicians of India and most recently president of RSSDI. So I invite Sir Samar Banerjee for the next session. Thank you.
Please allow me to share the screen.
Yes, sir. Is there anyone from the RX event group? Yes.
Okay, thank you. I am very grateful to Bongsi for giving me the chance to speak on this occasion. At the very initial point, I will declare that the subject is very unsettled now. This is a very peeping in our knowledge, so we are not very confident about the effect of microbiota on diabetes mellitus. The microbiome has been associated with pathophysiology of most chronic diseases, including type 2 diabetes, as seen in both preclinical animal models and in healthy individuals. Therefore, there is considerable interesting potential use of microbiota in clinical applications for understanding and treating type 2 diabetes. Human gut is a complex ecosystem consisting of microbiome, host cells, and nutrients. There are about 100 trillion bacteria in the intestinal tract, and they form the gut microbiota. The intestinal microflora of healthy adults principally consists of 6 phyla: Firmicutes, Proteobacteria, Bacteroidetes, Actinobacteria, Fusobacteria, and Verrucomicrobia. Bacteria is involved in type 2 diabetes. Bacteroidetes and Firmicutes occupy the dominant position in the human intestinal tract and play a pivotal role in the nutritional absorption system and support the intestinal barrier enhancement. Bacteroidetes outnumber Firmicutes. Current research continues to find association between the bacteria and diabetes, both type 1 and type 2, and these appear to involve many metabolic effects and immune response processes, and most of these associated with more specific mechanisms. Among the commonly and consistently reported findings, the genera of Bifidobacterium, Bacteroides, Faecalibacterium, Akkermansia, and Roseburia were negatively associated with type 2 diabetes, while the genera of Ruminococcus, Fusobacterium, and Blosia were positively associated with type 2 diabetes. So more Akkermansia means control of the blood sugar. This is about a gut mycobacteria composition. Dominant species are Clostridium, Eubacterium, fecal bacterium, Bacteroides, and bifidobacterium. Rare species, Streptococcus, Escherichia coli, Enterobacteria, transient species, yeast, lactic acid, and bacteria. Commensal bacteria interacts with pathogen recognition receptors, we call it as PRR, and leads to protection from pathogens. Small chain fatty acid from dietary fiber leads to anti-inflammatory effect. Tract cell expansion leads to immune homeostasis, and lifestyle changes in terms of the diet modification by avoiding high fat, low fiber diet and alcohol restriction, and with drugs like metformin, there are much improvement, and these changes in tight junction leads to pathogen escape to circulation. Long chain fatty acid production leads to inflammation, inflammatory signals leading to autoimmunity. These are all partially controlled by these lifestyle changes with its effect on bacteria. Diet is a crucial regulator of intestinal microflora. Composition of the microbial community ecosystem is dynamic and is dependent upon many factors like genes, medications, and diet. Dietary changes can induce temporary shifts in a large number of microorganisms as rapidly as within 24 hours. Gut microbiota composition also varies with an individual's age. These age-related gut microbiota changes could occur due to changes in diet at different ages, and changes in inflammation due to some age-related disease, and changes leading to decreased immune system function. The gut microbiota plays a pivotal role in the body's metabolism, and immunity response can also become a regulator of the effect of the diet on the host metabolic state. On the other hand, these factors may also provide a potential impact on the onset of metabolic disease like diabetes. The type, quality, component, and source of human food intake will affect the composition of gut microbiome as well as the functions and interaction in the microbiome ecosystem. Main energy source of the gut microflora is dietary carbohydrate, and restriction of dietary carbohydrate can limit the growth of the microflora. Incidence of type 2 diabetes is inversely associated with the total amount of dietary fiber, and this fiber also impacts intestinal microflora population, and fiber intake is associated with an increase in microbial diversity and the ratio of firmicutes and bacteroides. Increase in dietary fiber intake also increase the abundance of the human intestinal microflora and leads to higher microflora richness associated with higher microflora stability. Fiber dietary promotes the fermentation of intestinal microbes, and these appear to cause an increase in short chain fatty acids, which participate in the regulation mechanism of glucose homeostasis. Soluble fiber directly lowers blood glucose and increases the viscosity of gastric juices. The more viscous fiber leads to longer gastric entry time, and more gastric entry time means less slow glucose absorption. Additionally, these changes lead to small intestinal transit time, slowing and increased starch digestion, which is associated with a reduced rate of glucose absorption, leading to changes in blood glucose and cholesterol concentration. More dietary fiber reduces the risk of type 2 diabetes and is also associated with maintaining a healthy weight. Healthy weight adults and children can increase their intake of plant fruits rich in fiber while reducing total energy intake that is more often associated with high sugar, high fat, and low fiber foods. A personalized diet can successfully improve postprandial blood glucose elevation. Use of more specific medicinal nutrition recommendation shows the possible prevention and management of type 2 diabetes. Additionally, the ratio of firmicutes and bacteroides is also significantly lower in type 2 diabetic patients than in non-diabetic patients. In type 2, there is an abundance of bacteroides and Faecalibacterium. Abnormal gut microbiota is often observed in pre-diabetic patients also. Early intestinal microorganism ecology is impacted by breastfeeding and childbirth, which prevents the onset of diabetes. The full implication of this observation, although not conclusive, appear to indicate that there is developmental impact on microbiome development, and strength and outcome of these factors will need to be more fully explored in future research. regarding studies on animal models. In intestinal microflora transplantation experiment, germ-free mice that received transplanted gut microflora from OB mice showed a significant increase in obesity and associated insulin resistance. In subsequent weight loss surgery experiments, the correlation between obesity and intestinal microflora was also demonstrated with an observed increase in fat mass in germ-free mice transplanted with altered microbiome. These studies all started to substantiate the potential cause and effect of relationship. The results of gut microbiology studies in mouse models can, of course, be simply directly translated into human comparison. That means the animal results are not similar in human, and these pitfalls of direct comparison need to be avoided. The reproducibility of human experimental studies is also sometimes limited, which may also be influenced by variations in difference among study settings, geographical location of the sample preparation, as well as inconsistency in data analysis. Moreover, there are some studies which have produced contradictory observation and data in human research. It is unclear as to the root cause of this variation. However, it may be partially attributed to different dietary habits and environmental cultural factors around the world, as well as to different experimental methods used. However, future conclusion regarding human microflora connection to diabetes will require intervention studies. To date, fecal microbiota transplantation, called as FMT, antibiotic therapy and probiotic therapy are considered effective in various intervention studies. FMT has also been considered an effective tool to gain evidence of microbiome association and the causality of many diseases. When insulin-resistant men received gut microbiota from lean body mass donors, analysis of the experimental result demonstrated that FMT improved insulin sensitivity and the number of butyrate-producing bacteria also increased significantly. More butyrate means less chances of diabetes. However, not all patients receiving FMT show the equal results. Out of the anti-diabetic drug, the metformin is very promising on its effect on the microbiota. They lead to upregulation of GLP-1 and PPAR receptors in healthy individuals and in type 2 diabetes. Has multiple effects in the intestine, such as increasing GLP-1 concentration in the intestine and extraction of glucose. They reduce lipid absorption and inflammation caused by lipoprotein saccharide, also reverse type 2 diabetes related changes because of the abundance of several gut microbiota appears more similar to non-diabetic control level when treated with metformin. So metformin changes the microbiota of a diabetic person to like a non-diabetic microflora. Metformin disrupts the microbial characteristic associated with diabetes, including changes in the composition of the intestinal microflora. They alter the intestinal microflora balance in treatment named type 2 diabetes, while germ-free mice had glucose tolerance after receiving metformin modified microbiota and so improved results. Metformin in mice fed a high fatty diet showed abundance of the mucin degrading bacteria, Akkermansia encephalia, and which means better diabetic control. Similar conclusions have been found in other human studies. A metformin recipient saw enrichment of also Trudicibacter and spirochete, Akkermansia encephalia, and several small chain fatty acid producing microbiota are low when compared to non-diabetic patients who had a relatively high abundance. And this study reveals some of the mechanisms by which metformin can change the microflora. Probiotics appear to have a wide range of effects on the host, including improved regulation of insulin sensitivity by improving host metabolism composition, by reducing pro-inflammatory cytokines, and by reducing intestinal permeability, directly improve host metabolism and increase small chain fatty acid production, also improve intestinal balance through the production of antibacterial compounds and competition with pathogen, also regulate the host immune response and activate specific gene activation and impact extraintestinal process. So probiotics are of many help. Multiple probiotics reduces insulin resistance by effects on gut microbiota. Injection of yogurt can transport lactic acid bacteria to the gut. alter gut microbial composition, inhibit the production of lipoprotein saccharide, and increase the close connection of gut epithelial cells. Oral administration of Lactobacillus reuteri also improve insulin secretion. Amenophilia reduces insulin resistance and reduces destruction of the intestinal barrier. Low levels of encephalia may be a biomarker for impaired glucose tolerance. So more encephalia means better glucose control. Amenophilia derived extracellular vesicles can regulate gut permeability and a low in type 2 diabetic patient. Supplementation of them can reduce low-grade inflammatory response and metabolic reducer. It is a mucus degrading bacteria and its abundance is negatively correlated with glucose tolerance and fat accumulation. The mechanism of decreasing insulin sensitivity of this encephalia may also be related to its membrane protein called as AMAP 1100. Is a special membrane protein isolated from the bacteria. Studies have shown that this special protein binds to toll-like receptor and participate in protective mechanism for the intestinal barrier. This amenophilia play a role in reducing biomarkers associated with the inflammatory response leading to diabetes. They improve insulin sensitivity. The regulatory effect of probiotics on improving insulin sensitivity have population limitation and may not work for everyone. It is worth noting, for example, that 2 recent studies have shown that probiotics have no effect on gestational diabetes. Obesity type 2 are often characterized by changes in intestinal microflora, inflammation, and disruption of intestinal barrier. The gut microbiome can interact with dietary components and habits to influence host-insulin sensitivity. Intestinal microflora type 2 and healthy individuals is often markedly different. Modification of gut microbiome by diet leads to dysregulation and secretory changes of intestinal microbial metabolism, leading to insulin resistance and diabetes. Intestinal microflora can also affect metabolism and the potential risk of diabetes by changing the way they respond to dietary ingredients. Lipopolysaccharide induce inflammatory cytokines through immune cells and adipocytes, causing low-grade inflammation, while acetic acid or butyrate can regulate the function of immune cell. That is, they antagonize the effect of LPS, which is derived from the cell wall of the gram-negative bacteria. The LPS of gut microbiota binds with the TL toll-like receptor 4, inducing the inflammatory response. The TL4 signaling pathway is considered to be one of the main triggers of the obesity-induced inflammatory response, and saturated fatty acid can cause insulin resistance and low-grade inflammation by activating TL4 signaling pathway. The intestinal epithelium acts as a barrier and its basic function is to limit the interaction. Increased production of LPS by intestinal microflora will also activate the endocannabinoid system and ultimately lead to adverse glycemic control. The small chain fatty acids composed of acetic acid, propionic acid, and butyric acid deficiency is thought to be associated with type 2 as a protective effect on the gut barrier, result in decrease in the number of butyrate producing bacteria, which can promote the expression of tight junction protein, reducing mucosal permeability, enhancing the intestinal barrier function, leading to less absorption of the nutrients. Then dietary fiber promotes the small chain fatty acid production by gut microorganisms, while most other potential producers are relatively reduced in type 2 diabetes. Intestinal microflora before and after dietary fiber intervention in volunteers are transplanted into germ-free mice, and that indicated the strong and significant association between gut microbiome and improved fiber glucose-induced post-glycemic control. At the same time, the study proposed that when the small chain fatty acid producing bacteria promoted by dietary fiber have greater abundance and diversity, participant glycated hemoglobin levels so as improved. Butyrate insulin resistance patient receiving fecal microflora from insulin sensitive donors had a significant improvement in insulin sensitivity with improved abundance of butyrate producing. The Faecalibacterium prausintigi are the main butyrate producing bacteria. They are better group of bacteria. They prevent the onset and worsening of the hyperglycemia. Bile acids are transformed into secondary bile acids through the enzyme metabolism of gut microbiota. And the intestinal microbiota of oral bile acid treated rats was analyzed and showed there is significant change in phylum levels and increased ratio of firmicutes. And study reported reduced genetic and diet-induced insulin resistance in FXR knockout mice. More bile acid in the abdomen means more chances of absorption of the glucose. A strong association exists between the bile acid and branched-chain amino acid, as well as the potential role of amino acid metabolism in the early stage of diabetes, and they can lead to more in diet, lead to increased risk of type 2 diabetes and insulin resistance. In a recent study, patients with type 2 received a short-term dietary supplement of branched-chain amino acid, which showed reduced insulin secretion. The synthesis pathway BCA have been shown to be related to Prevotella copri. These are the bacteria, and the Bacteroides vulgaritis. These are concerned with more synthesis of the BCCA. Gut microbiota and relation in type 2. These are also associated in the pathogenesis of type 1 diabetes. Occurrence of type 1 diabetes in NOD mice depends on the composition of gut microbiota and LPS-mediated gut signal involving TLR4 and MYT88 receptor. NOD mice lacking MYT88 protein will not develop type 1 diabetes. The key characteristic of the disease are negatively correlated with the concentration of butyrate and acetate in the blood and the feces. Small chain fatty acids are involved in prevention of mechanism of early onset type 1 diabetes. The preclinical type 1 diabetic patient intestinal microflora is characterized by a dominant bacteroides with the low stability and diversity of intestinal microflora. The role of gut microflora in activity in type 2 diabetes is still very vague concept. Current studies have few observations to support the explanation that gut microbiota activates type 1 diabetes. Most studies focus on involvement of gut microbiota in the beta cell autoimmunity process. Characteristics of gut microbiota in LADA. Remarkably, the gut microbiota patients with LADA showed distinctive characteristics, significantly decreased abundance of Faecalibacterium species, Rosebaria species, and Brosia species compared with other groups. So more Faecalibacterium, Rosebaria means less chances of LADA. These are short-chain fatty acid producing bacteria. The relation with gestational diabetes, gut microbiota dysbiosis during pregnancy may contribute to the pathogenesis of GDM and risk of type 2 diabetes in post-GDM women. And this dysbiosis was linked with adiposity, low-grade inflammation, insulin resistance, and hyperglycemia. Probiotic supplementation in GDM, especially multi-strain probiotics from Bifidobacterium and Lactobacillus, was found to modulate gut bacteria, reduces lipoprotein maintains small-chain fatty acid concentration, and enhance health outcome. Therefore, a synergistic approach involving both lifestyle modification and probiotic supplementation would be a novel approach to prevent glucose intolerance in women with GDM. Oral microbiota and another factor of gut microbiome and diabetes. The oral cavity serves as an endogenous reservoir for gut microbiota strains, and oral fecal transmission is important process. Oral bacteria can translocate to the gut and lead to changes in the microbiota. Oral microorganism may cause disease mainly by synergistic or cooperative way, and oral diseases like caries, periodontal disease, and type 2 appear to be mutually correlated. Oral microbiota is an important factor in the development of diabetes, and on the other hand, oral microbiota also an important avenue for diabetes to cause other oral or systemic complication. Personalized microbiome-driven effects of non-nutritive sweeteners or human glucose tolerance. These non-nutritive sweeteners are affecting the microbacteria. When used in excess, they alter the glucose metabolism. All 4 tested sweeteners like saccharin, sucralose, aspartame, and stevia significantly and distinctly altered the human intestinal oral microbiome. But sucralose and saccharin supplementation impairs glycemic response in healthy adults and adversely affects the blood sugar control. In the conclusion, I just like to say the current research into the gut microbiome in the field of diabetes has gradually moved step by step from initial correlation studies which proved a strong association to excluding the causality and potential mechanism. It is very clear that as science looks to the future, this will be a very promising frontier. It can be foreseen that the gut microbiota will be used not only as biomarker for diabetes, but also as a target for potential therapeutic treatment. Through the intervention of gut microflora, it will eventually be possible to achieve a more precise and personalized diagnosis as well as treatment of diabetes. This is only going to be possible with a significant investment in extensive multi-center, longitudinal, interventional, and double-blind random clinical trials. Additionally, this will yield an extensive knowledge base upon which data science and exploration can occur. The scientific research community must proceed with a sense of urgency if this data are to be used to their fullest advantage, as many new discoveries are waiting just ahead. I just like to conclude by the saying that some informations are peeping at our door, whether microbiota may be a marker for the development of diabetes, leader and GDM, or their alteration to the satisfactory microbacteria can help in controlling diabetes. Thank you for your patient hearing. Thank you.
Thank you, sir, for delivering the excellent speech on the gut microbiome, the diabetes, and usually it is also very informative. We have question answer session at the end of all the three sessions. So for the next section, I would like to invite Dr. Anuj Maheshwari from Lucknow, and he is also renowned diabetologist and has various sir is very well known, and he is also chairing so many organizations, as well as have presented so many international national papers in the reputed academic index journals. I would like to invite Anuj Maheshwari, sir.
Thank you, Diacarecon and Dr. for giving me this opportunity virtually to speak with you, as every year I am here. I am always being invited and remained present physically. This time, for some reason, I am speaking virtually. So again, thank you. Next 15 minutes, I shall be talking about the approach to hypertension in diabetes. Let's start with a case scenario. A 52-year-old woman with type 2 diabetes, first diagnosed 2 years before. She presents now for routine follow-up and is noted to have a blood pressure of 160 by 100 millimeter of mercury. She is asymptomatic. Medical history is 5 years. She is having hypothyroidism, dyslipidemia, taking thyroxine 25 microgram, gliclazide metformin combination 60 milligram and 500 milligram, and statin 20 milligram. On physical examination, she was found to have height 5 feet 5 inches, weight 65 kg, 160 by 100, blood pressure 84 beats per minute pulse, and any other abnormality. Systemic examination, there is no retinopathy, no thyromegaly, no clinical evidence of congestive heart failure or peripheral vascular disease, and no other abnormality detected. Laboratory evaluation shows that urine analysis having trace protein, blood urea nitrogen 14, serum creatinine 1.2 normal, and fasting blood glucose is 108 milligram per deciliter, HbA1c 6.9%. Electrolytes normal, thyroid stimulating hormone is 1.75, and 24 hours urine collection, urinary albumin excretion rate of 250 milligram per day. The patient is diagnosed as hypertensive with type 2 diabetes and microalbuminuria. The question arises, what should be the clinical approach in this case? Should her blood pressure be treated? What if her blood pressure is 150/90? What if her blood pressure is 138/86? What treatment strategy should be used? As per the current guidelines, we see that guidelines suggest to keep the blood pressure 130/80. Let's find the evidences. Let's check the rationality of these guidelines with the evidences. We all know that diabetes and hypertension are running as a twin epidemic in our country as well as across the world. The enormity of the problem is that effect of these two diseases are compounded. Whenever they are together, they are impacting not 1 plus 1, 2, but 1 plus 1, 3. Each perpetuates the others. Both are generating from the same soil. So that's why they are having the similar side effects. They are having the similar complications. They are having the similar risk factors also. The question arises, when should we start treating systolic blood pressure to treat hypertension? And this is a very old question, has also been asked in 50 years before or 70 years before, and every time it has got its different answer. Like in GNC 4 and 5 recommended to treat the blood pressure at 160 systolic blood pressure. GNC 6 has revised its recommendation in the form of 150 mm of mercury blood pressures to be treated as systolic. In GNC 7, American Society of Hypertension, International Society of Hypertension at the same time recommended to treat the blood pressure if systolic is 140 mm of mercury. Sprint brought it down up to the 120, but it was in quite ideal conditions which are usually not met in our routine clinical settings. American College of Cardiology and American Heart Association has given its recommendation in 2017 to keep systolic blood pressure less than 130, not only for the purpose of treatment, but also for the diagnosis of hypertension. Even in 80 years individuals, we found that blood pressure keeping less than 120/80 is beneficial as far as the cardiovascular events are concerned. It has been found that even in 80 years individuals, those who are having so much of the arterial stiffness, still they are not supposed to keep their blood pressure on the higher side. If they are keeping their blood pressure less than 120/80, probably they may be having lesser number of the cardiovascular events. As far as the blood pressure and cardiovascular disease risk is concerned, it increases with the pre-hypertension stage only. That's why it is required to reduce the cutoff of hypertension diagnosis. Once the diabetes is there, then again it becomes compounded. And not only with the hypertension, not only with the pre-hypertension, even a person is having only diabetes, he is carrying the risk equivalent to the cardiovascular disease already existing. So that's why diabetes is most of the time is set to the cardiovascular equilibrium. Pre-hypertension and diabetes, once these two are together, then the risk becomes the highest, as you can see in this particular chart. Diabetes approximately doubles cardiovascular disease risk in patients with hypertension. What we found in our Indian data, as far as in regards of the ischemic heart disease and cardiovascular adverse events are concerned, we could see if the blood pressure is kept between 120 to 129 systolic, the risk of getting death and ischemic heart disease was 1.16 per adjusted hazard ratio, which elevated to the 1.19 only if it changed its systolic blood pressure to the 130 to 139 range. But it makes a significant impact if we talk about the stroke and cerebrovascular accident. Then if we change the category of the systolic blood pressure from 120 to 129, the risk of death and cardiovascular, cerebrovascular accidents and cardiovascular disease jumps significantly from 1.16 to 1.73 hazard ratio. So this is a very significant higher risk in segment of the 130 to 139. That's why recommendations of keeping less than 130 have been found to be genuine. Major outcomes by achieved systolic blood pressure category in the accomplished trial have been seen U-shaped. We could see that events per 1,000 patient years, when they have been compared with the systolic blood pressure category, we found in reference of the primary endpoint as well as in reference of the cardiovascular death, the relationship was U-shaped. Means least amount of the risk was there at 120 to 130 mm of mercury. If we further go down less than 120, then probably we are increasing the risk of getting cardiovascular events as well as the primary endpoints of the risk of hypertension in forms of the non-fatal MI and non-fatal stroke. Blood pressure lowering for the prevention of cardiovascular disease and death, once it has been systematically reviewed in a meta-analysis of 123 studies, which included more than 6 lakh participants, it was found that every 10 mm of mercury reduction in systolic blood pressure significantly reduced the risk of major cardiovascular disease events. The results were quite supportive for lowering blood pressure to systolic blood pressure less than 130 mm of mercury. Even at the age of 75 years, the people, those who were old, it was found that intensive blood pressure control were more useful and it was providing more benefit as far as the cardiovascular end outcomes are concerned, may it be in reference of the primary outcome or in reference of the all-cause mortality. So ultimately, BP thresholds for the goals as well as pharmacological therapy to be initiated in patient with hypertension according to the clinical conditions has been summarized in the way that for all clinical conditions, that BP threshold for initiation of the therapy and BP goal for the target of blood pressure treatment achievement have been found less than 130/80 almost in all clinical conditions, except if you are not finding any clinical cardiovascular disease and 10-year associated cardiovascular disease risk is less than 10%, then only you can take the liberty to diagnose hypertension by 140 and 90 for the blood pressure threshold to initiate the treatment. And another category which has given the liberty to keep the blood pressure little higher for a diagnosis was the secondary stroke prevention. Once a stroke has already occurred, then you can give a liberty to keep at least up to the 140/90 blood pressure for the secondary stroke prevention strategy. The new target blood pressure and new cutoff for the diagnosis have been found to be 130/80 mm of mercury. Let's talk about the preferences for the medicine. For primary drug treatment of hypertension, any of the following drug can be used as an initial choice as per the recommendation of the American College of Cardiology and American Heart Association in 2017. Diuretics, ACE inhibitors, ARBs, calcium channel blockers. You must be remembering 20 years before in GNC7, diuretics were most preferred agent. Again, the recommendations are coming back towards the diuretic being most preferred agent as far as the cardiovascular risk prevention is concerned. But in terms of the diabetes, in presence of the diabetes, we will have to be little more careful because most of the diuretics are having the hyperglycemia potential. As far as the beta blockers are concerned, these are almost listed out from the list of the primary agents to treat hypertension. Although they are included in the list of the secondary agent, to be considered as any treatment is there when there is a specific indication like heart failure, angina, post-MI, atrial fibrillation, or it may be younger women, those who are planning pregnancy. These are the recommendations recently received from the European Society of the Cardiology in 2021. ACC-AHA guidelines in 2017 has also said that under primary agent, chlorthalidone is preferred on the basis of the prolonged half-life and proven trial reduction of the cardiovascular disease. This slide makes more understanding clear about the hypertension and diabetes and as well as the treatment protocol is concerned. Whether to treat hypertension early in diabetes or if we are treating with the medication, is it really impacting diabetes and how much it is impacting? This is important to know. The risk of diabetes associated with antihypertensive drug therapy appears to be explained by presence of hypertension. Among the subjects who had hypertension, the risk among those not taking medication was similar to that among those taking one or more agent. Among the subjects who were not taking any antihypertensive medication, the risk of diabetes was much higher among hypertensive patients than in non-hypertensive. In all-head trial, it has been proven that incidence of the new onset diabetes at the 4 years of the treatment of hypertension was 8.1% in the patient those who have been treated with the lisinopril, 9.8% those who have been treated with the amlodipine, and highest that was 11.6% those who have been treated with the chlorthalidone. So it is important to know that the treatment for the hypertension is again increasing the hyperglycemia potential, especially if the person is already diabetic, it becomes quite detrimental. So we'll have to be more cautious about the management of diabetes once trying to treat the hypertension with medication. Beta blockers are also supposed to be having a risk of new onset diabetes mellitus. 25% increased risk could be seen with the atenolol and 28% increased risk with the other beta blockers. Thus, choice of the antihypertensive drug matters. In this reference, yes, it definitely matters. We know that effect of ACE inhibitors or ARBs on the renal outcome has been found quite favorable, and as compared to the other medications which have been used for the hypertension treatment. As far as the intensive management is concerned, we know that more intensive blood pressure lowering improves the cardiovascular outcome, irrespective of the baseline systolic blood pressure and atherosclerotic cardiovascular risk. Mortality and CV outcomes with RAS inhibitors, which includes the ACE inhibitors and ARB, compared with the calcium channel blockers in patients with type 2 diabetes. And here you can see that RAS blockers have been found to be more weightage and more risk reduction in terms of the all-cause mortality, cardiovascular mortality, myocardial infarction, angina, stroke, heart failure, revascularization, and drug withdrawal, and end-stage renal disease as compared to the calcium channel blocker. Mortality and cardiovascular outcomes with RAS inhibitors, when it has been compared with the diuretics, and it was found to be having more beneficial with the RAS blockers as compared to the diuretic. Mortality and CV outcomes with RAS inhibitors compared with the beta blockers, and again we could find that RAS blockers were more beneficial as compared to the beta blockers. Another recommendations which makes our impact on the approach, or it changes our approach and it gives a new variety of the approach and new concept to the approach, that is the preference for the combination therapy. Almost all guidelines and all recommendations are favoring the combination therapy, even from the very much start of the treatment. Dual dose, low dose may be started with the dual therapy in the step 1. Once we are going to start the treatment, it can be upgraded with the full dose dual therapy and finally to the triple combination. And once we are progressing to the resistant hypertension, spironolactone can be added. Majority of the trials which have been done since from the very beginning, from UKPDS to the all-head, we have seen majority of the antihypertensive are used in the patients of hypertension to treat their blood pressure were more than 2. So that's why it is proven that multiple drug therapy is more beneficial for the treatment of hypertension. All-cause mortality have been found to be reduced significantly by the perindopril and the pomade. As far as the advanced trial results are concerned, it has also recommended the combination of the ACE inhibitors with the thiazide-like diuretics as an excellent first-line combination, which can increase the hypertension control and reduce hypokalemia. Cardioprotection is better and increased adherence is also there. Amlodipine have been found to be superior to hydrochlorothiazide in combination treatment with an ACE inhibitor in the accomplished trial. Cardiovascular mortality have been found to be significantly dropped when the perindopril have been used with the amlodipine. It was dropped for around 24% as compared to the atenolol and thiazide, which has been used as an antihypertensive combination. Correction of the hyperglycemia also makes a big difference on the control of hypertension. What drug you are choosing for the glycemic control, that also makes impact on hypertension management. Apart from vasodilating effect, there are certain drugs, may it be GLP-1 receptor agonist, may it be 5-glitazone, or may it be DPP-4 inhibitor, and finally the SGLT2 inhibitors, which directly inhibit the natrium hydrogen exchanger in the proximal tubule, resulting in blocking the reabsorption not only of the glucose but also of the sodium. So one glucose molecule is lost with one molecule of the sodium, promoting the natriuretic activity, thus not only reducing hyperglycemia but also reducing the blood pressure too. The effect of SGLT2 inhibitor have been well established on HbA1c reduction, body weight reduction, systolic and diastolic blood pressure reduction. Circadian rhythm has also its important impact on management of the hypertension. Morning hypertension had significantly higher frequency of the developing nephropathy and retinopathy, and it is important and impactful if we somehow control the morning hypertension in majority of antihypertensive treatment. Blood pressure characteristic in diabetes is very much different than from the non-diabetic, because we see majority of the diabetic patients are non-dipper, or they have got the dipping reduced. Normally, we find a 10 to 20% dipping in the blood pressure from daytime to the nighttime, but in non-dipper, it is less than 10% dipping, and reverse dippers are those who actually find rise in the blood pressure at the night, and extreme dippers are called those who are having more than 20% dipping. So that's why for these reasons, ambulatory blood pressure becomes more important to be used in the diabetic patient, because they can only catch the non-dippers and dipper to the ambulatory blood pressure monitoring. Nocturnal hypertension and non-dipping put up the worst prognosis regardless of the 24 hours blood pressure. So take home message is that hypertension management mitigates vascular risk in diabetes. Therefore, blood pressure should be checked every visit. Try to catch them early. We can start lifestyle modification even at times it crosses 120/80. Loss of night dipping, nocturnal hypertension, and mass hypertension is more common in diabetes. Therefore, ambulatory blood pressure monitoring or home blood pressure monitoring should be preferred method of monitoring blood pressure. Many recommendations are favoring to use cutoff 130/80 for both diagnosis and treatment, though we still need to gather scientific evidences to support, but keeping in mind our population is prone for metabolic diseases and their adverse outcomes, it may be good idea not to allow the blood pressure cross 130/80 mm of mercury since from the very beginning of life. Approach each patient individually. There are recommendations to start the treatment with combinations from very first visit together with lifestyle modification. Attempt to offer the best of available treatment options without compromising patient safety should be the ideal for approach of hypertension in diabetes patient. Thank you very much for your kind listening.
Thank you, sir. Giving the excellent talk on the topic of hypertension in diabetes, that is a deadly duo combination. And this is a vast topic, and cover it in a precise session is very also appreciable. For the next session, I invited Dr. Usha Sriram from Chennai, and she is going to deliver the lecture on the GDM is a mother of non-communicable disease. And Madam is a graduate of Madras Medical College and also the head of the Department of Endocrinology, Diabetes, Metabolism at Voluntary Health Service, Chennai, President, Indian Society for Bone and Mineral Research, founder of Divas, and special interest in the GDM, women's health, osteoporosis, preconception care, and medical ethics. So this is for you, Madam. Please, Madam.
Thank you so much. And thank you, Padmanabh, for that kind introduction. And an honor to be in the same panel as Samartha. And can I control my slides? Hello? Hello, can you hear me?
Yes, ma'am, you can control your slides.
Okay, fantastic. Thank you so much. A great honor to be in the same panel as Samartha and Anuj Maheshwari on these very important topics. And most importantly, my gratitude to Panchi. My apologies for not being there. I'm actually in Vancouver. It's 5 o'clock in the morning here, but delighted to be with all of you, looking forward. This is a very important topic that I want to speak on for the next 20 minutes or so. Only this condition itself has been described formally in the last 50 to 60 years. But can you imagine in 50 to 60 years, a medical condition has taken this kind of a Vishwaroop and is also now being thought of as the mother of all NCDs. I'm actually not able to move the slide. Can you? Hello?
Ma'am, you have to accept my request. Then you can control your slides.
Should I just say you can control that one?
Yes, ma'am.
Doesn't allow me to do that. It just, should I view options? Can you do me a favor? Can you exit and I will just share my slides and control it?
No, ma'am, you get a
is going to be very quickly what NCDs are and the rise of NCDs, as I call it, what COVID has done to NCDs and the rise of gestational diabetes, especially now during COVID. And then there's this link between GDM and the non-communicable diseases and the transgenerational NCD risks. And as the title of this session, what should physicians know and do? Okay, so again, I'm stuck in this. Okay, can you move the slide? I'll just say next. Next, please. So the four major non-communicable diseases the four big ones are cardiovascular disease, type 2 diabetes, or diabetes in general, chronic respiratory diseases, and cancer. So what is the connection between gestational diabetes and all of these conditions is what we will talk about. Next slide, please. So first, to show you the rise of communicable, non-communicable diseases in India, as you can see from this graph, it has just skyrocketed between 1990 and 2020. Of course, 2020 changed things a lot on its head due to COVID. So communicable diseases became the big topic in the last 2.5 years. But still, be that as it may, non-communicable diseases are the biggest players for so many reasons, and I'll show you. Next slide, please. So you can see cancers, ischemic heart disease, cerebrovascular disease, all showing tremendous rise. And the other things, the infections, usually either going down or kind of, plateauing, except of course injuries and road traffic accidents. But all of those things, whether it's ischemic heart disease, cerebrovascular disease, and also now cancers, are high in people with type 2 diabetes. We know that. and also the link between gestational diabetes and this is something that I will show you now. Next slide, please. The top three things that I just mentioned, ischemic heart disease, COPD, and stroke, all of these things are, even though diabetes is mentioned only as number, gone up from number 11 to number 8, diabetes is a big, giant risk factor for the top three non-communicable diseases. Next slide, please. And not only is there an increase in the scope of the problem is very high, but if you also see an uneven economic burden of non-communicable disease among Indian households, this is both in the public sector and private sector. This is particularly relevant to women because 70% of the world's poor are women, and many people, when they, especially post-COVID, have been pushed below the poverty line. Next slide. And about missing work, caregiving, and premature death, non-communicable diseases play a very big part. Next slide. What has COVID done to non-communicable diseases? This is a wonderful slide, and I would like everyone to take a few seconds to look at it. Whether it is TB or malaria, which are communicable diseases, but look at things like non-communicable NCDs, look at things like maternal and child health and poverty, which I've already mentioned. All of these conditions have taken a giant beating due to COVID. Patients have not been able to come for follow-up or have been ignoring their symptoms, have not had access to healthcare. More importantly, COVID itself has increased the risk of many of these conditions. Next slide, please. Now, coming to gestational diabetes, I'm just trying to marry the non-communicable diseases with gestational diabetes. Look at gestational diabetes, and this is and you look at Southeast Asia, the green line on top between 1990 and projection for 2030, the tremendous rise in the increase in gestational diabetes, and reports from the US and other places have said that post-COVID in the US, there has been a 30% increase in the risk of gestational diabetes. The reasons are many. I'm not going to go into it. Nevertheless, the risk of GDM has gone up, probably in our country as well. Next slide, please. Now, the essence of today's presentation is this. When a mother has gestational diabetes, it's not only her, but also the child, especially in the index pregnancy, the first offspring. You can see there, if she has GDM, first GDM pregnancy, she goes into a high-risk trajectory for chronic diseases. If she has GDM in the next pregnancy, the trajectory goes up even higher. The same risk, corresponding NCD risk, is also present, typically in the first offspring. Next slide, please. Now, first non-communicable disease link that I want to show is type 2 diabetes. We have known forever that the gestational diabetes biggest risk is future risk of type 2 diabetes. We knew that it was high, but more recent data and meta-analysis have shown that the risk could be 10 times, 11 times higher in women with GDM than compared to women who did not have GDM. Next slide, please. When does this risk start? You can see from this wonderful study that it can, even within the first 3 months, 1 year, within 3 years, the risk of dysglycemia is much higher, not only in people with frank GDM, and also people who have abnormal glucose challenge tests or a gestational impaired glucose tolerance. Even they are at greater risk for dysglycemia in the near future and not in the distant future. Next slide, please. So Dr. Ravi Ratnakaran has very nicely shown that women who develop GDM are people who actually start out with a poor beta cell function. So therefore, you can see what could happen to them in the years going forward. That this pregnancy was actually more like a stress test. It brought out, it unmasked their tendency for these conditions. And many researchers have shown this connection, which means The women with GDM are already marked individuals, and therefore, as physicians, the most important thing that we can do is not let them out of our sight as soon as this pregnancy is over, thinking this is only a transient hyperglycemia of pregnancy. Next slide, please. Now, look at this. Underlying metabolic defect is a chronic beta cell dysfunction, insulin resistance. Then there is an accrual of all the cardiometabolic risk factors, and Anuj had talked about this. And then there is cardiometabolic disease outcomes like type 2 diabetes and cardiovascular disease. And we should stop thinking that it is only diabetes and only cardiovascular disease, which are big by themselves. But there's also been linked to chronic kidney disease, and then of course liver disease and retinal disease. These are all linked to type 2 diabetes, and then heart failure, which is very, very high in women compared to men. Next slide, please. Next slide, please. And obviously, if the woman is overweight, the BMI is higher, she is going to have a much greater risk and an earlier onset of type 2 diabetes if she has had gestational diabetes. Next slide, please. You have to move the slides faster. Okay, so how long does this heightened risk of type 2 diabetes last? We used to think 10 years. There's data to show it can be as long as 23 years, and more recent data, which was just published in 2022, has said that this risk can last up to 35 years after the gestational diabetes pregnancy. Next slide, please. So, which means a lifelong protection of these women is very, very important by all of us. And how do we screen these people? This lovely study showed that just a fasting sugar could miss people who had GDM, who go on to develop, type 2 diabetes, the normal glucose tolerance versus the GDM, that we should really be looking at a 2-hour post 75-gram glucose. Next slide, please. Or definitely a postpartum. The other postprandial, the other risk of GDM is, of course, that GDM recurs in the subsequent pregnancies. And as each pregnancy, the GDM comes on, their risk for future chronic disease keeps going up. Next slide. And then this very important slide, persistence of risk for type 2 diabetes. I think I showed this about obesity. Let's come back again. Next slide, please. Now, cardiovascular disease. I talked about type 2 diabetes, now about cardiovascular disease. So, very important that pre-existing phenotypes like obesity, hypertension, dyslipidemia, glucose intolerance, we know are risk factors for cardiovascular disease. But these non-traditional risk factors like preeclampsia, gestational diabetes, babies who are born small, preterm deliveries, we tend to miss these non-traditional risk factors as risk factors for cardiovascular disease in women, because we see inflammation, endothelial dysfunction, impaired hemodynamic adaptation are all common soil for all of these conditions. Next slide, please. Now, so gestational diabetes leads to abnormal maternal glucose lipids inflammatory response. In the fetus, fetal insulin goes up, therefore fetal macrosomia is happening. There are epigenetic DNA modifications that are affecting the offspring energy balance and metabolism. Now, this leads to childhood, and then the child, as it grows into adulthood, increased risk of diabetes and cardiovascular disease. Now you can see not only NCD risk is going up in the mother, NCD risk is going up in the offspring as well. And now you can see why truly GDM is the mother of NCDs. Next slide, please. Now, ischemic heart disease, hypertension in women with previous GDM. So in general practice for preventive intervention, this is a very important group. Next slide, please. So you see here, very lovely representation. Diabetes goes up tremendously. Hypertension is high. Ischemic heart disease is high. Stroke and TIAs, they did not show a very significant difference, but definitely the risk is high. Next slide, please. The American College of Cardiology has taken it upon itself, and I think a wonderful thing, to educate physicians and cardiologists and OBGYNs about what are the risk factors for cardiovascular disease in women. And I want to show on the left panel gestational diabetes is something I have circled. But on the right panel, the under-recognized some more risk factors like psychosocial risk factors, intimate partner abuse, socioeconomic deprivation, environmental risk factors like pollution. So as physicians, I think we should also pay attention to these risk factors in our women and not be typically how we have been A1C centric or just a lipid centric. Next slide, please. Cardiovascular disease, Dr. Ravi Ratnakaran has shown that this is not due to type 2 diabetes developing in women with GDM. The GDM itself increases the risk of cardiovascular disease in women. Next slide. And significant risk factor for maternal long-term renal disease, something that we have not appreciated for a very long time. This was published in the AJOG. Next slide. One of the big reasons for all this happening is also postpartum gestational weight gain. So as physicians, I think we need to counsel our women on what they should do about gestational weight or shedding it and not gaining weight postpartum. And as you can see, as the gestational weight gain is retained, there greater chance of non-communicable diseases in the future. Next slide. The link between cancer and GDM, there are studies showing there is a link and studies showing that there may not be a link, that it may be primarily due to development of type 2 diabetes. But be that as it may, women with type 2 diabetes have a 27% increased risk of cancer compared to women who do not have diabetes. So that itself is a huge cancer risk that we need to keep in mind. And postpartum weight changes, which I just mentioned, in the first year after delivery, women start having abnormal lipid profiles and abnormal cardiometabolic profiles in the first year. Next slide. And therefore, in the next two slides, I'm going to show something about offspring and a little bit about what physicians can do. And mental stress. When women is given a diagnosis of GDM, they may develop a lot of an emotional reaction. They may have concerns about dealing with it, and they may have anxiety and even get depressed. And this could continue postpartum. We've heard about diabetes distress. Next slide. When women are stressed, this has impact on the baby as well. So on stress, what GDM does to stress, 2 times increased risk of stress. Next slide, please. And this is a very important concept. What does GDM do to the baby, and what does the stress do to the baby? Next slide. When mother is stressed during pregnancy, the cortisol levels, the CRH production can go up, and the baby can get stressed also. Next slide. And there is a new concept that I want to introduce today, that we have to really, the next generations matter, and transgenerational impact of whatever we do and whatever illness we're dealing with is very, very important. You will see that there is a baby within this baby in this picture, which I have put in, just to show that it's not just transgenerational, but a multi-generational impact that GDM is causing. Next slide, please. So you can keep moving the slide. This is an animated slide. So when a mother has GDM, her baby can develop diabetes. If it's a girl, she can develop GDM, and if she has a baby girl, that girl can also develop diabetes and gestational diabetes. So truly, mother of NCDs. And offspring diabetes, excellent representation of that, and offspring overweight and visceral adiposity in mothers who have had GDM or mothers who are overweight. Next slide, please. Traditionally, we have never looked at stress as something more than, what could happen to the mother, but maternal stress, how it affects the baby, not only brain development, emotional development, but also low birth weight has been linked to stress in maternal stress and low birth weight. So birth outcomes have also been affected by stress. Next slide, please. So as I mentioned before, stress actually induces some changes in fetal programming, the Barker hypothesis. Next slide. So we need to start looking at very important concept. And low birth weight is associated with increased risk of adult chronic disease, which is what we are talking about. The non-communicable. Next slide, please. And if the mother, if low birth weight happens to a baby, and if it happens to be a girl, she is at risk for future gestational diabetes. So optimizing birth weight is another thing that practicing physicians have to look at, and that comes from maternal nutrition, something that we need to look at pre-conception and during pregnancy, not overnutrition and definitely not undernutrition as well. Next slide, please. So I want to extend the Barker hypothesis. Is maternal stress a teratogen or a developmental origin of adult disease? And if we start thinking on these lines, some of the answers we have been looking for: why babies are born small in our country, why mothers don't gain enough weight. So we need to pay a lot of attention to mental health as well. I just want to mention here, mental health is also now the fifth most important non-communicable disease that we look at. Next slide, please. So we have been somewhat myopic about looking at, babies and pregnancies and looking only at the health of the baby in terms of pregnancy. We are all very happy as soon as a healthy baby is born. We're not looking at the mother and what is our long-term, chronic disease outcomes, and also for the baby as well. Next slide, please. So as physicians, we have to change the way we think. We have to pay attention to the whole Barker hypothesis. Next slide, please. And there is another new concept I want to introduce. It's called the reverse Barker hypothesis. We only talk about baby and fetal programming. Next slide. But when the mother has gestational diabetes or gestational hypertension, or she delivers a low birth weight, we know that these complications are predicted by first trimester algorithms. These are pre-existing maternal phenotypes. They accelerate chronic disease. So therefore, they also indicate the mother's future chronic disease, maybe even the grandparents' risk for chronic disease. So we have to think of also reverse Barker hypothesis. Next slide, please. So one non-communicable disease we did not talk about was chronic obstructive lung disease. Just want to show you, even that is affected by GDM. As you can see here, there are functional defects and mechanisms as far as the baby goes and in future developing chronic lung disease. So the whole picture is complete. GDM increases the risk pretty much of all non-communicable diseases, either directly or indirectly through development of type 2 diabetes, and therefore we need to give it the importance that it deserves and elevate it to a most important public health issue of our time. Next slide, please. So what should be done? I'll finish in the next 3 slides. Next slide, please. What should we do? World Diabetes Day is coming up. This year's theme is education to protect tomorrow. Let's bring in gestational diabetes as an important topic for us to talk about. Next slide. When mothers with GDM deliver and go home, let us bring them back within 6 to 12 weeks, recheck them for glucose, prescribe contraception, prescribe exclusive breastfeeding, which we should do right from the beginning, talk to them about it, and keep following them up every 6 months to 1 year for, for the dysglycemia and development of type 2 diabetes. And also look at this as pre-conception care for the next pregnancy. Next slide. So most important that physicians should do is all pregnancy should be planned, not intended, but planned, and make sure that we are not dealing with any degree of glucose intolerance, and that we correct that and optimize their weight before they walk into a pregnancy. That is the best thing that we can do for our women. Next slide. And this wonderful, lovely slide summarizes everything. So current challenges and research gaps in GDM. We have to do preconception counseling. We have to optimize risk factors, pay attention to maternal nutrition, reduce maternal obesity. This is all preconception. Then first trimester, identify existing DM or MODI, should have been done sooner. Early detection of GDM, and we keep looking for the novel biomarkers. And then in the last part, how do we deal with the management of GDM and following up these women, especially postpartum breastfeeding and a lifelong preventive a preventive health approach lifelong after this pregnancy and not forget about it. Thank you so much for patient hearing. I apologize for this delay in the slides moving forward. And thank you so much again.
Thank you, madam. As the madam has a special interest in the gestational diabetes, and she justified the topic very well. And in the given time, she has given the excellent insight about the topic. So we are running late in the session. So I request all the speaker for the canceling the question answer session, and because there is a 2 other session are going there after our session.
Yeah.
So Nimi, sir, want to say, Samar sir?
Yes, Dr. Samar.
I just congratulate Usha for excellent slides. Very knowledge-inducing, excellent slide. If I have good any chance, then I could steal the slides. Excellent slides.
I'll send it
very
to you, sir.
Good. And the simile of the specs gives so much insights into the lecture. I accept Usha has worked very hard for this lecture. Congratulations to Usha. Thank you.
Thank you, sir.
So true, sir. So true. We cannot agree more, sir. So I thank the eminent faculties, Dr. Samar sir, Dr. Anuj sir, and Dr. Usha ma'am for letting us, for teaching us the insights of what physicians should know. Now, for the second session of clinical insights, I welcome Dr. Meet Shah to proceed further.
Thank you, Dr. Nimi. Myself, Dr. Meet. I am a consultant physician and diabetologist practicing at Kalol My Life Hospital, Gandhinagar. And I'm really thankful to Bansi sir for giving me this opportunity. We have a wonderful sessions going on. And the topics we have is clinical insights. And for this session, we have 2 excellent chairperson. The first one is Dr. Sandeep Rai. He is senior consultant diabetologist from Apollo Hospital, Mumbai. And the other one is Dr. Jitendra Anand. He is a consulting physician from Anand Multispecialty Hospital, Gandhinagar, and he has been the president of Association of Physicians Gujarat as well. So I welcome both the chairperson for this session. Thank you.
Yeah, thank you, Dr. Meet, and me and my co-chairperson also thank Dr. Bansi Sabu for giving us this opportunity. As we are going late, we'll start with the first speaker, Dr. Arvind Jagdisha. He needs no introduction. He lot of awards and allocates, the chief diabetologist at the Arvinda Diabetes Center. He has been past president of RSSDI Karnataka. He has many awards, Times of India Award and Bengaluru highest civilian award. And he has worked in UK in many positions as diabetologist and endocrinologist. He'll be speaking on a very, very important topic, a deadly trio of diabetes, heart failure, and renal dysfunction. Dr. Arvinda, please.
I'll share my slide. Are you able to see my slides?
Yes, yes.
So, good evening, everybody. At the onset, I'd like to thank Dr. Bansi sir for making a part of this wonderfully organized conference. I wish I could have attended the conference physically. Because of the unavoidable circumstances, I am not able to do that. But no worries, virtually we can always meet up. And I'll thanks Dr. Sandeep for the nice words. So, a deadly trio, diabetes, heart failure, and renal dysfunction. So first of all, greetings to all of you from Bangalore. So patients with type 2 diabetes are at increased risk of complication such as CVD and heart failure. If you see in this slide, approximately 1 in 3 patients with type 2 diabetes has CV disease. There is a 2 to 5-fold increased risk of hospitalization for heart failure in patients with type 2 diabetes. CV disease is the leading cause of mortality in patients with type 2 diabetes. So this slide looks busy, But this is what actually, it's a vicious circle between the type 2 diabetes and heart failure. You can see on the right hand side about the pancreas and left hand side the heart, and you can see the various mechanisms which are interlinked between hyperglycemia and heart failure, and in between comes the obesity. So we have a circle which is interlinked between the diabetes and the heart failure. So effects of diabetes on outcomes in patients with heart failure. You can see in this slide, the patients with diabetes, like CV death for hospitalization for heart failure, if you take in this slide. So patients with diabetes have a higher risk of heart failure with reduced ejection fraction when compared to the diabetes with next comes the diabetes with heart failure with preserved ejection fraction. If the person is having no diabetes, the incidences of reduced ejection fraction and preserved ejection fraction comes down. So what does this slide says is the persons with diabetes are more prone for heart failure. So the patients with type 2 diabetes are also at increased risk of complications such as CKD. You can see in this how the things are interlinked between type 2 diabetes, CV disease, and CKD. So CKD affects up to 40% of the patients with type 2 diabetes. Diabetes and hypertension is the cause of more than 80% of the end-stage kidney disease cases worldwide. Life expectancy is reduced in patients with type 2 diabetes and early CKD by 16 years, 10 more years than the CKD alone. So different pathways and networks involved in the initiation and progression of type diabetic kidney disease. You can see here, diabetes, the pathophysiological factors like increased RAS, increased TGF, increased age, increased TGF alpha, increased TGF beta, leading to intercellular signaling pathways, leading to increased PKC, leading to increased transcription factors like increased NF-kB, leading to glomerular hypertrophy, mesangial expansion, tubulointerstitial fibrosis and inflammation, glomerulosclerosis, and kidney fibrosis. You can see in this slide the normal kidney morphology and the structural changes in the diabetes mellitus. You can see the diabetic kidney disease includes structural changes, including the thickening of the glomerular basement membrane, fusion of the foot process, loss of podocyte with denuding of the glomerular basement membrane, and the mesangial matrix expansion, which is depicted on the right-hand side of the slide. When it comes to 10-year mortality in type 2 diabetes by kidney disease manifestation, you can see on the left-hand side, you can see there is no kidney disease, only 4.1%. If there is albuminuria, it is 17.8%. If it is impaired GFR, 23.9%. Albuminuria and impaired GFR, the 10-year mortality rises up to 47%. So the presence of CKD increases the risk of CV morbidity and mortality. Up to 67% of patients with heart failure are estimated to have CKD. The risk of CV death increases as kidney function declines. The presence of CKD in patients with heart failure increases the risk of mortality by 25 to 28%. So patients with type 2 diabetes have multiple risk factors that contributes to CRM diseases. What is CRM? Cardiorenal metabolic diseases. Over half of the patients with type 2 diabetes are reported to be obese. So type 2 diabetes reduces life expectancy by 6 years. Type 2 diabetes further reduces life expectancy in patients with cardiorenal comorbidities. So the diseases of cardiorenal metabolic systems share many of the same risk factors. There is numerous time points to retard progression. You can see in this slide how the things are involved from heart, that is MI and stroke, chronic kidney disease, heart failure, end-stage renal disease, all are interlinked. That is the reason my topic is about the cardiorenal metabolic systems that are interlinked to each other. The vicious cycle, we know that type 2 diabetes, diabetic kidney disease, and heart failure leads to sodium retention. The This is a cycle where one and each other are interlinked. So coming to the cardiorenal syndrome, there are like 5 types of cardiorenal syndrome. The first one type is the acute cardiorenal syndrome. The second one you can see on the left-hand side of the slide, the chronic cardiorenal syndrome. Third one is the acute renocardiac syndrome. Fourth one is the chronic renocardiac syndrome. The fifth one is the secondary renal syndrome. So these are the 5 types where a person can develop cardiorenal syndrome, which are interlinked to each other. So depending upon these, the management protocol changes. So the traditional hypothesis of cardiorenal interactions, you can see in this slide, heart failure, renal hypoperfusion, that is low flow, leads to increased renal vasoconstriction, renal tubular hypoxia, leading on to acute tubular necrosis. You can see in this slide the hemodynamic mechanisms in cardiorenal interactions. Like it looks a busy slide. You can see how the increased cardiac congestion and increased right heart arterial pressure, increased venous pressure, leads to decreased cardiac output, increased effective arterial blood volume, increased fluid load, overload, and increased salt and water retention, leading to increase sympathetic nervous system activity, increase RASC, increase inflammation, and immune cell activation, leading on to increased fibrogenesis, leading to loss of renal function, that is decreased GFR, decreased urine output, decreased sodium excretion, and decreased water excretion. The neurohormonal mechanism in cardiorenal interaction, once again, you can see in this slide, very pictorially depicted in this slide. So how the cardiac output matters in the eventual loss of renal function. So cardiovascular disease is associated with mechanisms leading to the progression of heart failure, CKD, and or acute kidney injury. You can see in this slide the various mechanism, how the things heart failure goes on are interlinked between the chronic kidney disease and acute kidney injury as well. The hemodynamic mechanisms where like fluid overload and retention of salt and water, renal and cardiac congestion, limited organ perfusion, vasoconstriction in end organs, leading to the activation of RAS, activation of the sympathetic nervous system, leading to cardiovascular disease associated mechanisms like chronic inflammation and activation of the cellular immunity, malnutrition, cachexia and wasting, bone mineral disorder, acid-base metabolism disorder, anemia, and cardiorenal anemia. So one most important thing is not to be forgotten is about the potassium. The association of serum potassium with all-cause mortality in patients with and without heart failure, chronic kidney disease, and diabetes. You can see in this slide how the baseline serum potassium plays an important role in the incidences of heart failure, CKD, and diabetes. So serum potassium play a significant role. This particular study published in 2017, like relationship between serum potassium, mortality, and conditions commonly associated with dyskalemias such as heart failure, chronic disease, and or diabetes mellitus is largely unknown. What was the conclusion of this particular study was the mortality risk progressively increased with the dyskalemia and was differentially greater in those with heart failure, CKD, or diabetes mellitus. So coming to an important aspect in the management of this particular condition where the 3 things are involved, that is diabetes, CKD, and heart failure, you can see the first one is the nutrition and lifestyle changes, that is the obesity, paradox, protein, iron, vitamin D, blood pressure, dyslipidemia manage, and glycemic control. The most important drugs as of the now, which is the blockbuster, is the SGLT2 inhibitors. We have evidence with DAPA heart failure, Credence, DAPA CKD, Emperor, and the role of GLP-1 receptor analogs, angiotensin receptor, neprilysin inhibitor, that is sacubitril valsartan, as seen in paradigm heart failure study, and diuretics, which can be a double-edged sword. Now coming to an important drugs like HDL2 inhibitors, I should say this is one of the molecule of the decade, which we are going to hear in the next couple of sessions by Dr. A.K. Singh. So then next comes to the AC inhibitors, ARB, mineralocorticoid antagonistics. So careful about hyperkalemia and worsening EGFR. Then comes to cardiorenal anemia, treating with erythropoietin and iron, CKD, that is metabolic bone diseases with phosphate binders and cinellacalcet. The newer agents, that nesiritide, a recombinant form of human B-type natriuretic peptide. Next is the serilaxin, is a recombinant form of human relaxin 2 that binds to the G protein coupled receptor, relaxin receptor, that is the heart and kidneys. So coming to the heart failures with SGLT2 inhibitors, I'm sure all of you are aware of these many trials with SGLT2 inhibitors, that is the Emperor Reduce and DAPA heart failure, where shown the beneficial effect of SGLT2 inhibitors in the management of heart failure. Could dapagliflozin improve kidney and cardiovascular outcomes in patients with CKD? That is a question always asked. Yes, we can say among the patients with chronic kidney disease, the risk of any composite kidney or cardiovascular outcomes or death was significantly lower with dapagliflozin than with the placebo. So empagliflozin phase 3 EMPA kidney trial was stopped early due to the clear positive efficacy in people with chronic kidney disease. So the rationale for apparent cardiorenal benefit like diabetes, cardiovascular, and renal, as of now, the blockbuster molecule is the SGLT2 inhibitors. So the long arc before this vicious cycles, like if you take the three conditions, the sacubitril valsartan, diuretics, beta blockers, when it comes to metabolic effects of cardiorenal benefits like reduction of MACE, CV death, hospitalization for heart failure, heart kidney outcomes, albuminuria, EGFR worsening, you can consider SGLT2 inhibitors. Then comes the statins as a role in reducing the albuminuria and CV deaths, CV benefits. AC inhibitors are ARB, which has got the cardiorenal effects. Then the metabolic effect, that is the cardiorenal benefits, which leads to reduction of MACE, CV death, and albuminuria. So, ladies and gentlemen, the take-home message from my talk today is the three things, that is diabetes, CKD, and heart failure, are interlinked with a vicious cycle. So identifying and treating aggressively from the beginning, in the long run, you will be able to prevent the cardiovascular, renal morbidity and mortality. Thank you for your patience hearing.
Thank you, Dr. Arvinda, for a very lucid presentation. In fact, you summarized the very difficult topic and amalgamated the deadly trio. Thank you very much. And I will request my co-chair, Dr. Jitendra Anand, to kindly introduce the next speaker. Sir, please unmute.
Thank you, sir.
Please
Thank
unmute
you,
yourself.
Hello.
Yeah, yes.
Yes. Thank you, sir. The next speaker is Dr. Anil Kumar Virmani. He is consultant physician and cardiodiabetologist at Jamshedpur, President-elect Clinical Cardiodiabetes Society of India, Chairman, Indian Association of Clinical Medicine, Jharkhand Chapter, Faculty, New Yorkshire Foundation Teaching Program, UK, Faculty School of Diabetes, PHFI, Advisory Council member, ACP East Don. He has published number of the chapters in API, RSSDI update textbooks, JIMA and JAPI. Over to you, sir. Dr. Anil Kumar Virmani. Thank you, sir.
Thank you, sir. I just share my screen. Okay. Is it visible? Is my screen visible?
Yes, sir. Yes, sir.
Yeah, yes, sir.
Okay, good evening to everyone. At the outset, thank you, Dr. Bansi Sabu, for giving me this rare opportunity of being virtually talking to in this conference, because normally I attended physically. Unfortunately, due to circumstances, I will be missing the fun tomorrow. We had a wonderful talk by Dr. Avinda. So from one trio to the other trio, diabetes, cardiovascular disease, and non-alcoholic fatty liver disease, what is the link? We all know the relationship between diabetes and cardiovascular disease, but where does NAFLD fit in? Now, non-alcoholic fatty liver disease is defined as excessive hepatic fat accumulation with insulin resistance. And there is steatosis in more than 5% of the hepatocytes, either according to histological analysis or proton density fat fraction of more than 5.6% by proton MRS or quantitative fat water selective MRI. And we must exclude secondary causes, and especially alcoholic fatty liver disease, which has been defined as daily alcohol consumption of more than 30 grams for men and more than 20 grams for women. Now, it has been divided into non-alcoholic fatty liver, which is nothing but pure steatosis and mild lobular inflammation, and that leads to steatohepatitis, non-alcoholic steatohepatitis, which can be classified according to the FIB-4 calculator scoring from early fibrosis, that is F0, F1, fibrotic, more than F2 to more than F3, and cirrhotic F4, and ultimately can lead to hepatocellular carcinoma. We must remember that the definitive diagnosis of NASH requires a liver biopsy. It affects more than 25 to 30% of the adults worldwide, is typically silent until advanced, and ultimately potentially irreversible liver impairment develops. Normally, we see patients who go on routine ultrasound coming to us with a fatty liver. Earlier, we used to ignore it, but today we are more learned. Associated with insulin resistance with or without diabetes, obesity, especially visceral adiposity, metabolic syndrome, and dyslipidemia. The various genetic factors, both monogenic and polygenic, which can modulate the risk of development of NAFLD and progress to steatohepatitis. The liver enzymes, AST and ALT, are not useful for the diagnosis because of poor sensitivity and specificity. They can be normal even in patients with steatohepatitis. Liver biopsy is the gold standard, but may not be available everywhere, is expensive, and may cause various complications. One of the best modalities is vibration-controlled transient elastography, which is a fibroscan, and this gives us an assessment of hepatic elasticity and steatosis, and useful for disease staging and longitudinal monitoring, but usually underused. Most patients with hepatic steatosis do not progress to develop NASH cirrhosis or hepatocellular carcinoma, but some undoubtedly will. If you look at the mortality, cause of death in patients with non-alcoholic fatty liver disease, almost 12% is cardiovascular disease. Now, multiple organs are likely to be involved in NAFLD, whether it is the adipose tissue, the liver, hepatocytes, or the gut, or the pancreas. And that is why, because of the multifocal involvement of the various organisms, this is now been termed as metabolic associated fatty liver disease. And this has been proposed by a panel of international experts from 22 countries. This new definition, metabolic associated fatty liver disease, basically emphasizes the bidirectional relationship and increases awareness in looking for fatty liver disease among patients with type 2 diabetes and cardiovascular disease or its risk factors, as well as looking for those diseases among patients with non-alcoholic fatty liver disease. So it is a progressive metabolic liver disease, and you can see it is linked to insulin resistance, type 2 diabetes, obesity, and basically there is dysregulated metabolism. The purpose of showing this slide is to give us the impression that the patient should be treated holistically. That is the message very important message that should go. Now, the common related metabolic disorders, as I said earlier, is insulin resistance in the not only in the liver but also in the adipose tissue and muscle tissue. The metabolic syndrome, which may consist of either impaired fasting glucose or type 2 hypertriglyceridemia, then low HDLC, increased waist circumference, high blood pressure. All these components correlate with liver fat content. And one should evaluate the risk of non-alcoholic fatty liver disease in all patients with metabolic syndrome, and conversely evaluate metabolic syndrome in all patients coming to us with an ultrasound diagnosis of a fatty liver. Irrespective of liver enzymes, diabetes risk and type 2 diabetes are closely associated with the severity of non-alcoholic fatty liver disease, progression to steatohepatitis, presence of advanced fibrosis, and development of hepatocellular carcinoma. In individuals with non-alcoholic fatty liver disease, screening for diabetes is mandatory, either by fasting or random blood glucose or A1C, or if available, the standardized 75-gram OGTT in high-risk groups. We must look for NAFLD patients with type 2, irrespective of liver enzyme levels, due to the high risk of disease progression. Now, overall prevalence of NAFLD among patients with type 2 diabetes is almost 55.5%, and NASH is almost 38%. And 17% of the type 2 diabetes patients who underwent liver biopsy had advanced fibrosis. NAFLD itself increases the risk of type 2 diabetes incidence, and the risk of new onset type 2 diabetes is doubled in patients with NAFLD. Moreover, 25% of the patients with fatty liver also have type 2 diabetes. So there is a very strong relationship between fatty liver and type 2 diabetes, which is a complex bidirectional relationship. Indeed, the coexistence of these two conditions pejoratively affects the course and prognosis of both the diseases. And type 2 diabetes is associated with higher risk of hepatocellular carcinoma. The basic pathogenesis remains same: lifestyle and genes. The Western diet lifestyle has been associated with weight gain and obesity and fatty liver. So high calorie intake, excessive saturated fat, high fructose intake, sedentary behavior, etc. So the recommendations of the EACL and EASD are: unhealthy lifestyle play a role in the development and progression of non-alcoholic fatty liver disease. So it is very important to assess both dietary and physical activity habits as part of a comprehensive screening. Now, what is the relationship with fatty liver and cardiovascular disease? There is a strong relation. And looking at the four surrogate markers like carotid artery intima media thickness or plaques, arterial stiffness, coronary artery calcification, and endothelial dysfunction, a meta-analysis performed by Zhou showed that there is a lot of subclinical atherosclerosis. So in the systemic review and meta-analysis, which included 26 observational studies, almost more than 85,000 patients, which had almost 30,000 fatty liver disease cases, they exhibited a significant independent association with subclinical atherosclerosis compared with the non, almost 60% more. Another meta-analysis by Target et al. Based on 16 observational studies, including almost 34,000 patients, median follow-up of 6.9 years, confirmed the strong association between fatty liver, biopsy-proven, and incidence of cardiovascular events. The fatal and non-fatal CVD events were 64% more. Another study, Pike et al. Have recently reported an increase in the non-alcoholic fatty liver disease-related deaths in the USA based on data from the National Vital Statistics System between 2007 and 2016. Interestingly, cardiovascular disease was the second leading cause of specific death. And the shared common pathophysiological pathways include low-grade inflammation, oxidative stress, and insulin resistance. If you look at the natural history and complications, prevalence of cardiovascular disease is higher in fatty liver than in MASH controls, and CVD should be identified regardless of traditional risk factors Both CVD and metabolic risk factors are also reported in adolescents and children with a fatty liver. So the recommendation is that it is mandatory to screen all patients of NAFLD for cardiovascular complications, and they should be screened. Now, when you look at the three together, type 2 diabetes has long been recognized as an independent cardiovascular risk factor and is a frequent finding in fatty liver disease. 60% of patients with type 2 diabetes have a fatty liver disease. And this is increasingly common, underdiagnosed, and underappreciated independent risk factor for atherosclerotic cardiovascular disease. In fact, it has been said that the presence of NAFLD is basically a risk enhancer. Now, given the strong association with the fatty liver and type 2, assessing the independent cardiovascular effect of these two conditions remains a bit challenging. However, patients with type 2 and a fatty liver exhibit higher risk of cardiovascular disease compared to those diabetic patients without fatty liver, suggesting a potential synergistic increase of cardiovascular risk in patients with both type 2 diabetes and non-alcoholic fatty liver disease, as I showed you the various shared pathophysiological pathways. In fact, the CVD is one of the leading causes, as I've earlier mentioned, in a fatty liver. And we have now several anti-diabetic therapies which have shown beneficial effects in both fatty liver and cardiovascular disease. There was another study, cohort study from Diabetes Registry in Scotland in more than 134,000 patients. And there it was shown that NAFLD were independently associated with increased risk of CVD events and mortality over a period of almost 4.5 years. And this was further confirmed by meta-analysis 11 studies in around 8,000, more than 8,000 patients, where almost 4,000 were NAFLD diagnosed by abdominal ultrasound. Now, analysis of the pooled effects showed that there was a double the risk of cardiovascular disease in patients with diabetes but without NAFLD compared to them. This suggests that there is an additional effect of fatty liver disease in patients with type 2 in the long-term risk of cardiovascular disease. Now, what are the potential pathophysiological mechanisms? The classical pro-atherogenic lipid alteration. We all know about the diabetic dyslipidemia, elevated triglyceride, low HDL, increased small dense LDL. There is a fat accumulation in the liver, insulin resistance, and there is increased production of VLDL and increase in the CETP or cholesterol ester protein activity. And this leads to increased triacylglycerol in the HDL and LDL, and hence small and dense LDL. Then there are various thrombosis factors like the PI1 levels, which are mainly determined by the liver. And we also know that type 2 diabetes per se is a prothrombotic condition due to increased platelet reactivity, higher levels of coagulating agents, and lower concentrations of endogenous anticoagulants. Insulin resistance, especially in the liver, and hyperglycemia per se can influence coronary artery disease through a direct effect on the structure of the arterial wall, while the promotion of monocyte macrophage addition to the endothelium, enhancement of vascular smooth muscle cell proliferation, and induction of endothelial dysfunction and inflammatory macrophages. Then there is low-grade inflammation because of endoplasmic reticulum stress. It has recently been seen that there is a microbiome alteration. Obesity, type 2 diabetes, and fatty liver share common gut microbiome alteration, such as a decrease in the abundance of lactobacillus and increased abundance of Roseburia and E. coli. And this biosis is also associated with cardiovascular disease. And there are very potential important factors like the trimethylamine N-oxide and short-chain fatty acids and polysaccharides that come to. Just to summarize the pathogenesis, we have seen there is an increase in the VLDL, increase in the small dense LDL, increased ACTP activity. I talked about the thrombosis factors, increase in PA1, platelet reactivity, procoagulant agents, and decrease in endogenous anticoagulants. Low-grade inflammation, hyperglycemia per se, increased cytokines, interleukin-1, 6, and tumor necrosis factor alpha, increased CRP, fibrinogen, peptidin A, mitochondrial dysfunction, oxidative stress, and microbiome alteration. Now, as far as the management is concerned, diet and lifestyle changes play a very, very important role, and modest weight loss reduces liver fat, improves hepatic insulin resistance, and can result in the regression of a fatty liver. Weight loss of more than 7% has shown histological improvement. Now, structured programs aimed at lifestyle changes towards healthy diet and habitual physical activity are advisable. They should receive counseling for a healthy diet, physical activity, but no pharmacotherapy as such. In overweight, obese patients, the target should be a weight loss of around 7 to 10%. Dietary restriction plus a progressive increase in aerobic exercise, resistance training, which is tailored approach. And these are basically based on energy restriction and exclusion of processed food and beverages high in added fructose. Now, both aerobic exercise and resistance training effectively reduce liver fat. So the comprehensive lifestyle, the energy restriction, the decrease in the fructose intake, avoiding abuse of alcohol, coffee consumption has no problem, looking at the macronutrient composition and a physical activity. And then we have a lot of emerging therapies that can lower the activity of liver enzymes, fibrosis and inflammation, such as the pioglitazone, SGLT2 inhibitors, GLP-1RA, and saroglitazone, as well as modification in gut microbiome. And as the next speaker is going to talk on the statin of this century, SGLT2 inhibitors have a role not only in they suppress type 2 diabetes, they suppress cardiovascular disease, and they suppress kidney disease, but they've also shown histological improvement in the liver. And with the present data, we know that the dual inhibitors, SGLT1 and 2 inhibitors, sotagliflozin, is likely as effective as SGLT2 inhibitors as far as the cardiorenal benefits are concerned. But they have an added benefit of reducing non-fatal and fatal stroke, as well as non-fatal and fatal MI by more than 30%. So if available and when available, I think they would be a preferred choice. So to wrap up, metabolic associated fatty liver disease is the new clinical definition for fatty liver disease, which shifts from a disease of exclusion to one of inclusion, where the pathogenic processes originate from underlying metabolic dysfunction. There is a strong evidence of association between fatty liver disease and increased risk of cardiovascular disease. And given the strong association between CVD, type 2 diabetes, and fatty liver, it is very important that the assessment of individual impacts of these two diseases on cardiovascular disease is in fact very challenging. And studies performed in patients with type 2 diabetes have shown that the coexistence of both diseases tends to increase the risk of cardiovascular disease. However, there are several common pathophysiological pathways which I discussed, and patients with both type 2 diabetes and fatty liver should be considered at high risk for cardiovascular disease, and they require a very aggressive, intensive cardiovascular prevention approach. Furthermore, as I talked about the current drugs, the SGLT2 inhibitors, GLP-1RAs, they have shown beneficial effects in both of these conditions, and it is important that they should be used in the individualized management of patients with type 2 diabetes. Finally, studies with long-term follow-up are needed to demonstrate that the treatment of fatty liver disease reduces the risk of cardiovascular disease. Thank you for a patient hearing.
Thank you, Dr. Virmani, for this interesting presentation and exploring the relation between diabetes, CVD, and AFLD. We'll see if we have time. We will take the question answer session in the last, and we are coming up with a very interesting presentation by Dr. A.K. Singh. And Dr. A.K. Singh is a very well-known figure in the field of diabetology. I don't think he needs any introduction. He is a senior consultant diabetologist and endocrinologist at the GD Hospital and Diabetes Institute in Kolkata. The prolific researcher, he has done many meta-analysis. He is seen at all the diabetes conferences. He's a deputy editor of the Clinical Diabetology Journal. He's associate editor of IJDDC and World Journal of Diabetes. And he is also the associate editor of the book Williams Endocrinology. He received many awards, including Most Inspiring Diabetologist, Endocrinologist of India. And I would request him to give a presentation. His topic is SGLT2 a new statin? Dr. A.K. Singh, please.
Chairman, for the kind word. I hope my slides are visible and I am audible.
Yes, sir.
Thank you, Dr. Bansi and the team, Diacare Kun. It's a pleasure always to share your thoughts with the colleagues. So I have been provided a very interesting, rather I would say provocative topic. A SGLT2 inhibitor, is it a new statin? So I will start just by asking this question that where is the data? We believe in nothing except the science and the data. So let's look into the evidence of a SGLT2 inhibitor, putting the data into the shoes of statin to understand whether a SGLT2 inhibitor really looks like as a newer statin of 21st century. Now let me recall that a drug which has been approved in 2012 by first in United States FDA and by EMA in 2013. So nearly 10 years now the SGLT2 is there in the clinical space. A drug which has been approved for the treatment of type 2 diabetes. So this drug was not supposed to actually prevent heart disease or kidney disease. We don't expect that statin will cure diabetes or control diabetes, no question. Other statins are diabetogenic drug. So you don't expect even a SGLT2 inhibitor to work as a statin. Interestingly, a drug which has been approved to treat type 2 diabetes and that was associated with weight loss and blood pressure reduction is now changing the entire landscape of treatment of diabetology, cardiology, and nephrology. So how come it has happened in past 100 years? Now, if you look into data, so far, we have got 5 cardiovascular outcome trials with a SGLT2 inhibitor since in 2008, US FDA mandated that all new anti-diabetes drug, which has been given approval, has to undergo a safety cardiovascular outcome trial to suggest this drug doesn't do any harm to the heart. And the story started with rosiglitazone fiasco. Now, what is interesting to note that in these 5 cardiovascular outcome trial, no need to read this busy slide. Recently, we summarized those data, busy slide. You all know the result. You have heard perhaps 1,000 times about IMPAREG outcome trial, DECLARE-TIMI, CANVAS, etc., etc. The entire intention to show you in these 5 cardiovascular outcome trial with a 5 different SGLT2 inhibitor, starting from empagliflozin to canagliflozin to dapagliflozin to orforgliflozin. This is not available in India. It's approved in United States. And sotagliflozin. What was common in these trials, although they differ from, to some extent in their primary objective, which was a composite of 3-point mesh. But there was one commonality in these 5 CB outcome trials. In all these 5 CB outcome trials, all 5 SGLT2 inhibitor done one job, that it prevents hospitalization due to heart failure. Remember, ladies and gentlemen, these are not a patients who had a history of heart failure. These are the patients of type 2 diabetes. They could be a garden variety of diabetes. For example, if you see the DECLARE-TIMI, out of 17,000 patients, 10,000 patients were a simple type 2 diabetic patients without any established cardiovascular disease. Therefore, this data suggests that SGLT2 inhibitor prevents hospitalization due to heart failure. You can see, and this, prevention is not in a tune of 5 to 10%. These benefits are in the tune of 30 to 35%. Therefore, if you treat 100 patients of type 2 diabetes with SGLT2 inhibitor, you are likely to prevent heart failure hospitalization in the future in 35 out of the 100. This is not a joke. And therefore, the world's biggest organization sitting together, American Heart Association, American College of Cardiology, Heart Failure Society of America, in their latest 2022 guideline, they give the class 1 grade A evidence to a SGLT2 inhibitor to prevent heart failure hospitalization in patients with type 2 diabetes. What are the anti-diabetes drugs, or what are the agents so far in the pharmacology that has been given approval of class 1 level of evidence A for a primary prevention? Now, if you compare a statin, the statin is a drug which is recommended for secondary prevention as a class 1 grade A evidence. When a statin doesn't have class 1A evidence to prevent heart disease. As you all know, statin is recommended for primary prevention in patients with type 2 diabetes, those who has got a high cardiovascular risk, or those who are aged more than 40 years. But for a SGLT2 inhibitor, this age is 18 years, regardless of whether you have got a high cardiovascular risk or not. If you have got a diabetes, it will prevent heart failure with a class 1A evidence. Number 1. Now let's come to the second part of the story. So over the 10 years, what we learned, that when we learned that this drug has a potential to prevent heart failure, people said, why don't you try this drug in a patient who had a history of heart failure or who has got a diagnosed heart failure? Well, let's do the trial. And to understand if the drug has a potential to prevent heart failure in a patient who doesn't have heart failure, can we treat a patient with heart failure with a SGLT2 inhibitor? Ladies and gentlemen, we have got 5 heart failure dedicated trials with a SGLT2 inhibitor. As you all know, 2 in patients with heart failure with reduced ejection fraction, 2 trials in patients with heart failure with preserved ejection fraction, and 1 with either preserved or reduced. Here is the 5 dose heart failure trial. And you can see, if you see this line, these trials has been done who has a diagnosed heart failure. It can be reduced ejection fraction heart failure, those having a ejection fraction of less than 40%, or those having a ejection fraction of more than 40%, known as heart failure with preserved ejection fraction. So you can see 2 trials, DEPA heart failure and impairer reduced, in reduced ejection fraction, and impairer preserved and deliver in patients with preserved ejection fraction. Another trial, 5th trial, which was done with sitagliptin called SOLOIST, it was done in patients with both reduced and preserved ejection fraction. What we learned, here is the result. If you look at the primary objective of these trials, in all these 4, and if you include DELIVER now as well, because DELIVER was presented less than 1 week back, as you all know, in European Society of Cardiology, very recently, if you combine all the 5 trials put together, one consistent data, SGLT2 has never lose any match till date. In these 5 dedicated outcome trials, the composite of cardiovascular death or heart failure hospitalization, which was the primary objective of the study, was highly statistically significant, and that too in the tune of 20 to 25%. Means if you have got a patient with diagnosed heart failure, regardless of ejection fraction, this drug is going to, treat your patients with heart failure. No wonder AHA, ACC, HFSA guideline put them a step that, yes, gentlemen, you are a class 1 level of evidence A for the treatment of patients with heart failure, regardless of diabetes. Remember, this drug was meant to treat diabetes and now recommended to treat heart failure, even in a patient who do not have diabetes. What a story which has come up in last 10 years. Now, statin, if you take a corollary to statin, they also have got a class 1A evidence in patients with heart disease, but they don't have the class 1A evidence to treat heart failure. That's the beauty and the difference between SGLT2 and statin. Now, this is important. Now, if you look back to patients with heart failure with preserved ejection fraction, this is one area in the field of cardiology which has not been met for past 100 years. There was no drug tried in the past that was useful in patients with heart failure with preserved ejection fraction. Even ERNI was tried, in the recent Paragon heart failure trial. And although there was numerical reduction, you can see there are 5 trials done with either ERNI or spironolactone, and these are 3 trials with RAS blocker. You can see irbesartan and candesartan and ACE inhibitor, perindopril. All these trials shown some numerical benefit. But if you go right-hand side, it wasn't statistically significant. So basically, all these 5 trials done in patients with preserved ejection fraction was a neutral. On the other hand, or contrarily, if you see only 2 trials done so far with SGLT2 in patients with preserved ejection fraction, Imperor preserved, and recently, as I said, week back, Deliver. In both the trial, you can see it met their primary objective with a highly statistically p-value significance ranging from 18 to 21%. This suggests that now we have got a tool for the first time that can take care of patients with preserved ejection fraction. Note again, these are regardless of type 2 diabetes. So these benefits has been seen in a patients with heart failure with preserved ejection fraction, not necessarily that patient needs to have a diabetes. So now you have got SGLT2 that works in patients with reduced ejection fraction, that works in patients with preserved ejection fraction, regardless of type 2 diabetes. Now, if you see the guideline given them level of evidence, which is 2A, class 2A level of evidence P. Now, if you see this AHA guideline, this prize was given prior to the delivered trial. This data is given on the basis of only Imperor preserved data. Now, if I believe if the delivered data would be now added into 2023 guideline, then I am sure this 2A will be elevated after adding. This is how the rule goes. If the 2 randomized control trial shown a positive outcome on the primary composite endpoint, ideally they should get a class 1 level of evidence A. And I'm sure in the next guideline, this will be elevated for the SGLT2 in preserved ejection fraction, similar like a reduced ejection fraction. Now let's shift gear from cardiology to nephrology. We have got 3 kidney outcome trials in past 10 years. And what is again surprising to believe that SGLT2 never bore you. It always comes with a flying color. Now this is the 2 trial which was done earlier, and now we are waiting for the IMPA kidney outcome trial. IMPA kidney is going to be presented at American Society of Nephrology in November 2022, so 2 months from now. And we all know that even IMPA kidney outcome trial was a stop, like Credence and DEPA-CKD, because of excess benefit in the SGLT2 arm. So I do believe that the data of IMPA kidney would be pretty similar or in similar line with what we saw with the Credence and DEPA-CKD. So in summary, in all these 3 kidney outcome trial, the SGLT2 inhibitor met their primary objective, and it reduced progression of chronic kidney disease in patients with CKD, regardless of type 2 diabetes. In Credence, it was all patients with diabetic chronic kidney disease, but in DEPA-CKD and in the IMPA renal or IMPA kidney outcome trial, these are the patients with CKD with or without diabetic CKD. And as you all know, the DEPA already has got an approval to be used to prevent progression of chronic kidney disease, regardless of type 2 diabetes. So therefore, in all the 3 renal outcome trial, SGLT2 came with the flying colors. No wonder if you see the KDIGO 2020 draft, which is yet not a guideline, this will be soon published as a guideline now. They have recommended that if you have got a patient with type 2 diabetes with a chronic kidney disease, do use a SGLT2 inhibitor if the eGFR is more than 20. And this is a mandatory recommendation, and perhaps it would be a crime that if you have got a patient with CKD and patient is not receiving a SGLT2 inhibitor to prevent progression of chronic kidney disease and to prevent the future cardiovascular event in a patient with CKD. So ADGO guideline, and remember even the ADA ESD guideline in the month of May 2022 changed their dynamic algorithm and suggested, remember it was earlier 30, the EGFR cutoff for SGLT2 was 30, but it has been brought down to 20 now, similar like KDIGO guideline, and they recommend that if you have got a patient with CKD and type 2 diabetes, and if the patient has got EGFR of more than 20, you must use a SGLT2 inhibitor. Now, one point, even if the EGFR falls below 20, don't stop a SGLT2 inhibitor unless patient is going for a dialysis or going for a kidney replacement therapy like renal transplantation. Finally, the last part of the story, that the SGLT2, beyond all these trials, they went into acute field. They tried to do, to see the result of SGLT2 in patients with acute heart failure admitted in an ICCU. Now, the concept behind this comes from this 3 trial. Let's go back to the DEPA heart failure, Impera reduced and the Impera preserved trial. What is interesting to note, ladies and gentlemen, that in all these trials, the benefit had started as early as 12 to 18 days. And, as you can see, my lines, beauty lies in the eye of the beholder. People thought that, why don't you try a SGLT2 in a patient with acute heart failure? And people did the trial. Look here. These are the trials which is being done in patients with acute heart failure. And this includes decompensated as well as compensated heart failure. Now you can see on your left-hand side, there are 4 trials with a SGLT2 inhibitor that has been either undergoing and already underwent in patients with acute heart failure. You can see the 3 green mark, 3 trial already has been conducted and the result is already out in patients with acute heart failure. The only one trial is we are waiting for, the dictate heart failure trial is right now undergoing with dapagliflozin in acute decompensated heart failure. But we do have data from the other 3 trials in patients with acute heart failure. And here is the result. You can see here, in these 3 acute heart failure trial, the SGLT2 was started in the first 24 hours of admission in the ICCU setup. And on your right-hand side, here is the result. In all the 3 acute heart failure trial, the SGLT2 didn't show any harm. There was, if at all anything, this shown benefit. And you can see, as you all know, in soloist heart failure trial, it was the primary outcome of CV death heart failure was met. In the impulse trial, although it didn't achieve a statistical significance, but the recurrence of heart failure hospitalization did reduce with empagliflozin. And same data came with IMPA response. And when people meta-analyze these data, you can see here the benefit even was seen in patients with acute heart failure. Ladies and gentlemen, we expect side effects of SGLT2 in a setting of acute, decompensated setup. Now you would be amazed to see that even SGLT2 didn't do any harm when it comes to hypertension, acute kidney injury, etc., etc. You can see there was no signals of any harm even in a setup of acute heart failure when SGLT2 was used within 24 hours of hospitalization due to acute heart failure. Therefore, if you see the entire totality of evidence with SGLT2 inhibitor in patients with type 2 diabetes, and if you go over the time, whether you have got a patient with normal ventricular function, as in these trials, or patient has got advanced heart failure, like in acute heart failure, impulse, IMPA response, you see the benefit. And what is interesting to note that these benefits are higher in those who are more sick. Look here in the acute soloist heart failure trial, the benefit, look at the NNT. The NNT is 10. Where is the data with the statin with an NNT of 10? So what is interesting to know that the more sicker your patient is, the larger the benefit you are going to extract with a SGLT2 inhibitor. And these are absolute benefit Look at the number needed to treat to prevent the primary outcome. Is amazing with SGLT2. Finally, before I finish my presentation, these are two recent studies which I would like to show you. And this is a first evidence which has been done with SGLT2 in a patients with acute MI. SGLT2 was never tried in past in patients with acute myocardial infarction. You can see two trials, IMBODY trial in your left-hand side and E trial on your right-hand side. These are the patients with acute myocardial infarction with or without type 2 diabetes. Whereas SGLT2 was started, in your right-hand side is the IME trial, whereas SGLT2 was started within 72 hours of undergoing a angioplasty. And here is the result with SGLT2 inhibitor. Surprising to see that SGLT2 shown improvement in their primary outcome. They reduced NT-proBNP. They improved all secondary outcome in patients with acute MI. So this is a first evidence for SGLT2 in a patient having a large acute myocardial infarction, undergone a primary angioplasty, and were given SGLT2, yet SGLT2 shown benefit compared to placebo. Look at the result, NT-proBNP, highly statistically significant. Look at the LVEF in patients with acute MI. Ladies and gentlemen, so this is the data in entirety till today. We published a week back. If you look at the SGLT2 inhibitor, what else you want? The drug was meant to treat diabetes. We won in CKD. We won in reduced ejection fraction. We won in preserved ejection fraction. We won in a stable acute HF. We almost won in acute heart failure. And all the trials are going on. This post-MI, I have shown you two data. To finish my presentation, is it a new statin? I didn't say anything. Let's see who said. Godfather of cardiology, Professor Eugene Braunwald, he wrote editorial. He said the SGLT2 inhibitor looks to be the statin of 21st. Now, if you ask me, my statement would be even provocative. Now, if I ask this question, does a statin work in patients with CKD? The answer is no. Does a statin work in a patients with heart failure? The answer is no. If that is the situation, then I do believe that this is a high time that a SGLT2 inhibitor deserves to take first treatment of type 2 diabetes. The metformin is whether given as a first line or not, it doesn't matter to me. Every diabetic patient, if SGLT2 is not contraindicated, must receive a SGLT2 inhibitor. When it comes to comparing a statin, it is as good as a statin, but it is better than a statin in patients with heart failure and CKD, where the SGLT2 sounds quite superior with produced so far. Thank you very much for your patience.
Thank you, Dr. A.K. Singh, for this excellent presentation. As always, we have, I think, 2-3 minutes left. I think we can go for some questions if there are any. I don't see any question in chat box, but I would like to ask you, as you are an astute clinician also, no doubt SGLT2 is a very highly beneficial drug. In your experience, you must be giving it to a lot of patients. We also give to a lot of patients. We see that there is an initial rise in some patients of serum creatinine, which is an adaptation. But for a layman point of view, when the creatinine rises, the patients always question, and when you send to the nephro, they will say, okay, yeah, this medicine has caused it. Literature says to wait for 12 weeks, it will come down. Some patients I've seen remain little elevated. One query is this, as to how do you tackle this? Second is, some people have excessive weight loss and sarcopenia kind of thing with this. Your views, sir, on this?
Okay, fantastic. So that's very elegant question, I would say, and that's very common discussed issues in clinical practice. So, the people has worked in this direction. Very simple answer to the first question is that let's not hesitate to stop, a SGLT2 inhibitor if you feel that there is a quite degradation in the EGFR. So the current recommendation is don't stop SGLT2 inhibitor, even if EGFR. So when we are talking about rise in creatinine, we measure in terms of EGFR, because creatinine is little, rude biochemical character. It can vary for so many reasons. So let's calculate EGFR. If the EGFR drop is less than 30%, don't stop SGLT2 inhibitor. However, if the EGFR falls more than 30% after the start of SGLT2 within 4 to 6 weeks, don't stop the SGLT2. Look at the cause, that what could be the reason as to why the EGFR was fallen more than 30%. So people look into the CKD trial. In the credence, only 1% of the patient in the credence trial had a drop of EGFR more than 30%, right? So, and they did not stop canagliflozin in the credence trial. In the DEPA-CKD trial, less than 5% patient had EGFR drop of 30% when they were started dapagliflozin. What was interesting to note, that those who had a larger drop in EGFR, they benefited most at the end of day. You know, so the trial continued for 2.6 years. In the DEPA-CKD trial, the cohort of the patient who had an initial fall in EGFR higher, they benefited most at the end of mean 2.6 years. Therefore, my suggestion is that you keep a close watch on EGFR, and I would urge my nephrologist colleague not to, unnecessarily panic and, patient को ये बोलने की जरूरत नहीं कि इसी दवा से हो रहा है. उनको ये समझाना जरूरी है. ओ अच्छा, मैं तो इसे ही बोलता हूँ कि आपका EGFR, आपका क्रिएटिनिन बढ़ा है, इसका मतलब आपका दवा अच्छा काम कर रहा है. घबराइए मत, 6 महीने के बाद आपका ये क्रिएटिनिन पहले वाले क्रिएटिनिन से भी अच्छा हो जाएगा. एंड पेशेंट टेक्स इट. दिस इज व्हिच वी नीड टू टॉक. अगर हम उनको ये पैनिक करके बोल दी कि नहीं बंद करो, इसी दवा से हो रहा है, you are not going to give any benefit to his kidney in the next 5 years down the line. You may have brought back the creatinine from 1.5 to 1.7 to again 1.5, but the 5 years down the line, it will cross 2. If it had been on SGLT2 inhibitor, you might bring it back to 1.3, 1.2. So that's the point I am going to, talk to my patient. और दूसरा आपका सवाल था,
just about weight loss and sarcopenia kind of thing.
Correct. Yes, so see, this is again an important point. So if you find there is excessive weight loss, and there is nothing harm in terms of any future complications related to cardiovascular or kidney mortality, only for the cosmetic reason. If you believe that patient is too much catabolic, you might stop SGLT inhibitor for some point of time. And we must ask patient that what is the reason behind. Maybe many patients on a keto diet, doing a lot of diet exercise, and not only SGLT2 inhibitor will cause a maximum weight loss of 3 to 4 kg. It will not make a BMI of 27 to BMI of 18, never. So if someone is losing weight, there must be some other reason. We can discuss with the patient. Sir, at the end of the day, the entire motto is that if the drug is giving benefit, we should not deprive the patients with the ongoing benefit which he is going to receive in the future, whether it is a prevention of heart failure, whether it is prevention of kidney disease, it is going to benefit. But in rare case, when you feel like it's all clinical by the treating physician, if you feel like there is too much of weight loss, please hold back the medicine. There is no harm. We can restart later on.
Thank you very much, sir, for emphasizing this point, because recorded versions will be seen by a lot of diabetologists and physicians. And I put this question because this is a common question in mind of physicians and people dealing with diabetes. So thank you for emphasizing that point. I think we have exceeded 5 minutes. We have had a very nice session of 3 speakers. If my co-chair, Dr. Jitendra Anand, could want to say anything.
Thank you, sir. Thank you all the speakers for excellent presentation. Thanks a lot, sir.
So I thank all the speakers, Dr. Virmani, Dr. Arvinda, and Dr. A.K. Singh, for your excellent presentations. I will now give the give the floor to for the next session to the rapporteur. Thank you.
Thank you, sir. It was a wonderful session of clinical insight. Now moving forward to the next session of state of art lecture. For this, I would like to call our speaker. Prior to that, let me introduce our chairpersons. First chairperson is Dr. R.K. Bhimwal, who is an MD, then fellow of Indian College of Physicians, consultant physicians and diabetologist. And second is our own Dr. Dhruvi Hassani, who is a consultant diabetologist and HOD of clinical research of Rudraksh Institute of Medical Science. So for the next session, I hand over the session to the chairperson, sir.
Thank you so much. Thank you, Dr. Subhajyoti, sir. We've had such in-depth clinical insights session, and now we move on to one of our state-of-the-art lectures. And for that, I have the pleasure of introducing one of my very close friends, colleagues, a person who's so passionate about diabetes. She's a pathologist by her degree, but she's now doing her MPH from the Howard T-Chan School of Public Health. And she's one of our global speakers who is going to talk about global healthcare delivery and decentralizing care for diabetes. She has so many accolades to her name, but the best thing is that she treats everyone with so much of care, passion, and she talks about making care global. So with that, over to Dr. Apurva. We all look forward to listen to you.
Thank you so much, Dhruvi, for such a kind introduction. And it's always a pleasure to come here. And I really thank the entire team at Dr. Bansi Sabu's team and the entire team at Diacare to actually hold this session. So I'm really grateful for this opportunity. Let me just pull up my slides. One second. Can you see it? Yes.
Yes, they're visible here.
Okay, thank you so much. So as Dhruvi pointed out, I trained as a pathologist, but my journey into diabetes came from a lot of like ups and downs of struggling, of coming down from just clinical practice into understanding global healthcare delivery. And that's what I really want to focus on this talk as well. I'm really privileged that I got this opportunity to talk about global healthcare delivery because a lot of my research at the Harvard T.H. School and also at Brigham and Women's Hospital, where I work in clinical research, is around understanding the global health system and to understand that how we can improve clinical outcomes and reduce disparities and inequities in diabetes care, which is quite prevalent across the globe and not just in low resource settings or in middle income countries. So shifting the focus for you all to understand on why we are talking about global health. We all know that many low middle income countries and even low income countries are facing an epidemiological transition, and often thought diabetes as a disease of the rich has broken all barriers now. We don't see it now just the disease of the upper middle class or upper class, but it has broken all social classes and invaded into even our rural areas where we never thought it would. So this has resulted in wide disparities and inequities. Even in our clinics, in the same population of people, we would commonly see some people wearing either a pump, but there are also people who are struggling to even get insulin. So the care is very skewed to the financial power, and this is very disheartening. Our health systems are not organized for long-term care of individuals, and we are very good at acute care. We are very good at managing an amputation. We are very good at managing a kidney transplant. We are very good at managing the acute complications, but we don't see that there are long-term effects of these acute issues, which can result in much more draconian crisis coming with diabetes. And the management of diabetes has so many factors involved to it, and it is very deeply linked to the social determinants of health, which it brings me back to the question, is our global health system equipped to manage the clinical outcomes that diabetes is bringing along? So to understand the global diabetes burden, we all concur with the fact that diabetes is on a rise. The IDF has portrayed really terrifying statistics about diabetes being on the rise. We also know for type 1 diabetes children, we have a really high number of prevalent cases of type 1. And even in India, we have around 95,000 children living with type 1 diabetes. But do we have enough care for them? We still don't know how many patients are still undiagnosed and are just being misdiagnosed as either malaria or something else, which is often misdiagnosis of type 1 diabetes. So now clearly concurring with the fact that diabetes is on a rise, but do you see that these terrifying statistics are actually what it's showing? Yes, it is on a rise, but it's not for all the bad reasons. It can be linked that the global population is rising. That's why we see that the prevalent cases have been on a rise. People with diabetes are surviving longer, which is very good and clearly shows that our global health systems are equipped to understand and making people survive longer. There are lesser percentage of undiagnosed cases, and this is also a positive fact that more and more people are getting more aware of diabetes, and also to our healthcare teams, which are able to diagnose diabetes correctly. So to summarize the situation, we often see the rules of halves, and we often see that based on the total number of people living with diabetes, only half of them are actually diagnosed with diabetes. Out of those, half of them actually receive the recognized care, and only half of them achieve the glycemic targets. This clearly shows there's a big challenge in diabetes care, why treatment gaps exist, and improving care, especially now with the COVID pandemic kind of looming right upon us. So jumping to how we see the health systems, and we all today are integral part of that health system. Some people say, oh, we're doctors. Why are we even talking about it? Why are we even concerned about something beyond our clinics? But we have to see that we all are pivots into this healthcare system model. And it is a key element for being able to provide to the needs of people living with chronic diseases, not only to achieve better outcomes, but also to improve the overall health of the community. So yes, we need to work in collaboration and in tandem with a lot of system and ensure that there is a good policy, positive policy environment, which can facilitate strengthening the health system. Now, a part of my research also works around establishing the targets. For years, HIV was considered to be a disease where people were dying alone. We did not have targets, but now HIV is considered a chronic disease. Now, if you see over the course of years, we see that diabetes is also on a rise. Are we measuring? Do we have established systems to measure these targets? Are we equipped enough? Now, I believe in the fact that what gets measured can actually get done. Now we see that, yes, there has been an accelerating progress in diabetes care everywhere, but are we going to achieve these targets? These are targets which are set up by the WHO, which is also a part of my research to understand how equipped are we to ensure that these targets are met by 2030. So yes, we are a long way ahead, and we have a lot of barriers in our care model. So diabetes is unique and requires a really cross-cutting nature of care. This opens me to an interesting question. Can synergizing the disease-specific vertical programs, if we just cater to diabetes and just focus on the diabetes care and forget about cardiovascular diseases, forget about other, is that going to help improve the outcomes of care, or would decentralization of services improve the overall outcomes in India? I will leave you with that question, but for that matter, when we talk about global health system, when we see diabetes from a global health system perspective, we cater to them as complex adaptive building blocks, understanding each of these blocks at different levels. So I would like you to see this WHO model of health system, and now switch. By the end of the presentation, I will also transition you towards like how we see in a diabetes environment. So coming through each blocks, I would walk you through it, would be first being service delivery, is how healthcare is being delivered in any given context. Yes, decentralization is complex, but care should be continuous, comprehensive, coordinated. We all in India are overwhelmed with our patients. We are trying our best to give care, but because of the disparate doctor-patient ratio, we are unable to give the care which we really want. Everybody wants to give more time to the patients, but unfortunately, we're not able to do it. So thus, decentralization would have some pros, but also some cons as well. But we need to focus on a multidisciplinary team-based care model, and decentralization of services would prove essential. For that matter, I think platforms like DiaCare is actually training providers and also general practitioners who are working at remote places where we do not have specialist care to understand how to deliver diabetes education and identify patients who need urgent care and can be referred to the higher centers. That's very crucial part of a health system model. Now, the health workforce also involves a lot of task shifting and a shared decision making, and that would require us as doctors and clinical providers to actually be able to deliver these services. Now, as I said, what gets measured actually gets done. Yes, we have a culture of data, and listening to so many speakers out there, we have a lot of data available, but are these information systems coherent enough? Are they able to compile, generate, and analyze, synthesize the data which we are getting, and just to understand from a global health perspective? Can you compare the system from India with somebody from outside? How do we do that? And how do we synthesize all that information for epidemiological studies? Now, switching to the other block would be, do we have our resources aligned for our patients to be given that quality and safe care? Is it cost effective? Because if you don't have the safety and the cost effective value of that care, you would not have access. You would not be able to ensure that all your patients are achieving glycemic outcomes. Yes, a lot of systems even in India are based on donation bases, which are run by IDF, not-for-profits, and pharmaceutical companies, but they're often non-sustainable. So we need to equip all of that through the financing systems. And that brings me to the next step, which is there exists no global fund for diabetes, no global fund for NCDs, and very less focus on diabetes care. Though we saw the statistics in the beginning, which was quite daunting to see that, yes, when we do not have the funding, which is crucially important, just like TB, HIV, malaria, for years was often ignored, but a lot of funding went into it. So right now, diabetes doesn't have any global fund, doesn't have any NCD care funding. So why the NCD investment gap exists? But now that brings me to another point. Funding is not the only solution, because funding is important, but not everything. A lot of pieces of the health system is based on all these different models and how competent are we synthesizing the information we are getting from diabetes care. This definitely revolves around leadership, which is the final model, which also helps in building up the policy environment. So as we saw these WHO models, I would like to transition towards a functional diabetes care system, how we can integrate care from our clinics, also ensure that there is value-based, task-shifting, team-based care, because yes, we need to measure the clinical outcomes. For that, you need integrated care delivery. And how we can enhance the medication and commodity access for a patient. Do we have competent research available, electronic hospital records available for appropriate data generation, and ensuring that we have visible policy prioritization of diabetes? That would require a lot of coordination and cooperation. For that matter, we have a lot of health system research happening. This is from one of the research papers which we published recently, and also by the work done by Dr. David Biran, that yes, decentralization would help in the burden of diabetes, but this decentralization doesn't have to be through one level, not only through vertical, but also through horizontal cross-cutting integration. Yes, it has to happen at micro levels, but also requires a lot of work at the health system level, from meso, macro, and ultimately to global outcomes. So to summarize, I know this doesn't answer the question simply that decentralization helps, but it is also not a clear solution. Health systems do not have the capacity to care for those who are living with diabetes. Most systems do not integrate. We have a lot of good data available in India, but we need to comprehensively integrate all of that and organize the roles. Now we understand that diabetes requires a lot of self-management. We need to ensure that there is safe, effective, quality-assured delivery being done for our patients, and also ensuring that there is proper prioritization and there is sustainability in our care. So yes, my talk really kind of summarizes about what our research is focused on. It is quite vast, but a lot of it is focused on synergistic integration and focusing on disease-specific programs like diabetes, and health system research is required to investigate the needs of people. Yes, we need to integrate that. A lot of health professionals need to adapt to this new paradigm where the role of disease management will be less effective in the clinics, but also being adapted to the individuals who are managing it at home. So we need to ensure that people with diabetes receive the care and support they need effectively to manage their condition, and also ensure that the entire health system is competent enough to do that. For that matter, we saw that COVID-19 kind of rolled us all out of our zones, and that requires planning and preparedness. Do we have access to insulin for our patients? Do we have access to even SGLT2 inhibitors? And also for type 2 diabetes management, do we have enough drugs for our patient to survive and ensure, especially in times of humanitarian crisis? Now, a lot of people ask me that, oh, US has a lot of facilities available, and yes, diabetes care and outcomes should be good. But no, even in the best of the finance-equipped health system, there are such complexities in care. There are wide disparities and inequities and variability in insulin pricing that, yes, we are not achieving the diabetes outcomes. And like I pointed out in the beginning, when we talked about the rules of halves, out of the 50% people who diagnosed with diabetes, only 50% of people are actually achieving their glycemic outcome. That clearly shows that we are failing. Yes, we could be doing very well in small-term goals, but overall, we are still failing in achieving the output of diabetes care globally. So this is all about what my research kind of revolves around, understanding the disparities of care. And I am happy to answer any additional questions and also happy to collaborate on further research in this area. So feel free to reach out. Thank you so much for giving me this opportunity.
Fantastic, Apurva. That was really wonderful. So many insights on how things are working globally, as well as in our low middle income countries. But I do have a lot of things to discuss, but I think we'll take the questions in the end. That's what I've been instructed to. And with your permission, we'll move on to our second speaker, Dr. Nidhi Garg. She has done her MBBS and MD fellowship from New Delhi. She has an experience as a diabetologist. She's the senior consultant for Narayana Institute of Cardiac Sciences. I'm not sure if I'm pronouncing it correct, Boma Sandra. Currently, she's working as a diabetology consultant at Narayana Majumdar Shaw Medical Center at Boma Sandra. Am I pronouncing it right, Dr. Garg?
Actually, I'm sorry, like this is the introduction for somebody else. I'm not sure, like this talk is for me or this is for some other person.
Oh my God. Okay, I'm so sorry.
Yeah. So so my topic is genetics of type 2 diabetes.
Yes, ma'am.
Yeah. So shall I start with this? Because my introduction is like, this is not me. I'm sorry about that.
I'm so sorry. I'm so sorry. That was what we were given.
It's okay. Yeah, I
ma'am, if
understand.
you could briefly just, introduce yourself to us and our audience, please.
Yeah, so I'm Dr. Nidhi Garg, and I'm currently working at Mayo Clinic in the research in endocrinology, and I'm working in like really basic sciences research. I have done my MD medicine from India, and I was assistant professor in internal medicine. So I'm working in like endocrinology, and I did my fellowship from PGI. My main interests are like diabetes and transgender health.
Awesome. It's an honor having you, ma'am. So sorry for the wrong introduction.
Yeah.
We'll work out with the tech team.
So it's
we
okay.
look forward to listening to your lecture, ma'am.
Yeah, so mine will be a little bit longer because this is like real basic sciences.
Okay.
So for my topic is like genetics of type 2 diabetes. So I'll start sharing my screen.
Yes, ma'am.
Okay. Can you see my screen?
Yes, ma'am, it is visible.
So yeah, good evening, everybody. And let us start with the discussion on the genetics of type 2 diabetes. So like coming from a transition from the global healthcare to the real basic sciences like genetics and the hardcore research topic. So I'll try to make it as simple as possible. It's not moving. Yeah. So as we all know, like diabetes is known as a distinct disease for the last 2000 years. In 1935, henceforth established that there are two distinct types, type 1 and type 2. And type 2 is the most common and the fastest growing diseases. The estimated worldwide prevalence is 700 million by 2045. It's an interaction between the environmental factors, and there's a strong hereditary component. The various environmental factors like obesity, sedentary lifestyle, stress are contributing to type 2 diabetes, but we will focus on the genetic component of type 2 diabetes today. The hereditary component ranges from like 20 to 80%, and the evidence comes from large studies from population, family, and twin-based studies. The lifetime risk is 40% when one of the parent is diabetic and 70% if both the parents are affected. First-degree relatives have 3 times increased risk of having type 2 diabetes. The concordance rate in monozygotic twins is 70%, and in dizygotic twins is 20 to 30%. This familial clustering is not entirely due to genetic factors. There is something called as epigenetic processes too. So what is this epigenetics? Like if you see the whole gene, there are the coding regions and there are the non-coding regions. In the non-coding regions, there are some other like genetic functions such as DNA methylation, histone acetylation, and non-coding RNAs. If there are changes in any of these functions of the gene, they can also be inherited to one or several generations without having a change in the nucleotide sequence. So this is what is called as epigenetics. The classical example is the maternal environment and the early infancy. Infants who are born small for gestational age, they have an increased risk for obesity and type 2 diabetes when they grow as adults. So it is all because of the epigenetic changes which occur during the intrauterine life rather than the inherited variations in the DNA sequence. Epigenetics can be used in future also, for, like in research for genome-wide DNA methylation studies can be done, and it can help to identify the novel genes in the pathogenesis of type 2 diabetes. So let us focus on the main topic for today, which is the genetics of type 2 diabetes. So the genetic architecture. Type 2 diabetes is a polygenic disorder, and there is a complex interaction between multiple genes and the environment. Unlike type 1 diabetes, where the entire genetic risk is concentrated in HLA region, in type 2 diabetes, this is not the case. It is not concentrated in one region. Rather, there are multiple genes which are scattered all across the genome. The monogenic diabetes of the young, or MODY, it constitutes less than 5% of the autoimmune diabetes. And it is due to single gene mutations in hepatocyte, nuclear factor 1A, and glucokinase. Now, how to identify the various diabetic genes? Like there are 3 main types of studies: the linkage studies, candidate gene studies, and the genome-wide association studies. So let's discuss first about the linkage studies. What is the meaning of linkage studies? So linkage means that the 2 genes, they are so close to each other on a chromosome that they tend to inherit together. They tend to go together to the next generation. So, so they are linked together. So this is what are studied like in the genome. So it is successful in detecting the rare variants of large effect like single gene disorders, but it is not so successful in identifying genes in complex polygenic disorders. However, in type 2 diabetes, 2 genes have been found to be associated for type 2 diabetes, which are calpain-10 and transcription factor 7 like 2 gene. The calpain-10 is the first type 2 diabetic gene which has ever been discovered by linkage analysis in 1996. It is located on chromosome 2, and initially the locus was labeled as NIDDM, but eventually in 2000, the causative gene was finally identified as CAP10. It encodes a cysteine protease, and it has a role in intracellular functioning, intracellular remodeling, and post-receptor signaling. The TCF7L2, this is the most common type 2 diabetic gene. It is situated on chromosome number 10, and it was first discovered in Mexican American population. Later, it was mapped to the Icelandic population, and it was confirmed in US and Danish cohorts. The associations strongly confirmed. This association was confirmed in the genome-wide association studies in different ethnicities. This is the most strongly associated type 2 diabetic risk gene. We will be discussing further about TCF7L2 gene in the genome-wide studies. Coming to the candidate gene studies, so in these kind of studies, the potential pathways, the potential genes and the potential pathways, they are studied in more detail, which we already know, like they are studied in more depth, in more detail. So the genes which are already suspected in the pathogenesis of type 2 diabetes, they are studied through focused sequencing efforts. And the genes like which are involved in glucose metabolism, insulin secretion, insulin receptors, post-receptor signaling, and lipid metabolism. So we know that these are the pathways which are involved in the pathogenesis of type 2 diabetes, and the genes which are involved in these pathways, they are studied by the candidate gene studies. The genes which were associated with type 2 diabetes, they included the peroxisome proliferator activated receptor gamma, the PPAR gamma, insulin receptor substrate 1 and 2, potassium inwardly rectifying channel, commonly called as the KCNJ11, WFS1, the HNF, homeobox A, B, and 4A. So first we will discuss about the PPAR gamma. It encodes the molecular targets for thiazolidinediones, which is a commonly used anti-diabetic drug. At position 12, the proline is replaced by arginine, and which increases the risk of diabetes by 20%. However, this gene is not found to be very significant in the worldwide prevalence of diabetes. The IRS1 and 2 genes, they encode for the peptides which play a role in the insulin signal transduction, and the polymorphisms in this gene result in decreased insulin sensitivity. The KCNJ11 gene, it encodes for the ATP sensitive potassium channel, and it has an important role in the insulin secretion by the beta cells. As we all know, the activating mutations of this gene can lead to neonatal diabetes, and missense polymorphism in KCNJ11 is associated with type 2 diabetes. The odds of developing type 2 diabetes is 1.2 in carriers. The WFS1 gene, it encodes for wolframin protein, and the abnormalities can cause Wolfram syndrome, which is characterized by diabetes insipidus, juvenile diabetes, optic atrophy, and deafness. So this gene is involved in the beta cell function, and there are 2 SNPs. So SNPs is single nucleotide polymorphisms, that one nucleotide is changed and it leads to the change in the genetic function and the genotype. So they are associated with type 2 diabetes. The HNF 1A, 1B, and 4A, which are commonly called as the MODY genes, they have a role in development of and metabolic functioning of the liver and the beta cells. The variants in these genes that do not lead to MODY, they are associated with decreased insulin secretion and an increased risk of type 2 diabetes. The genome-wide association studies. So in the genome-wide association studies, what they do is a large population, a large cohort, and the whole genome sequencing is done for a large population. And in that, the various SNPs, which are related to a particular disease, they are studied all across the genome. So we just get a full idea, a complete idea of the whole genome and the SNPs for a particular disease in a large population. So with the help of high throughput SNP genotyping technology, it is now possible to scan hundreds of thousands of SNPs that were linked in linkage disequilibrium with millions of SNPs across the genome. So basically, we can study the entire genome and related to a particular disease. The most important gene which was associated for type 2 diabetes is TCF7L2, which was initially identified by linkage studies, and now it was confirmed by the genome-wide association studies also. They also help to identify the scores of other genetic loci which appear to be linked to type 2 diabetes. The TCF7L2, this is the most significant and consistent replicated gene for type 2 diabetes. So like we say, like for MODY, we know that it is HNF 1A, 1B. So we know MODY is that. Type 1 means HLA. So type 2, as of now, the most consistent gene is TCF7L2. It was initially discovered by linkage studies, and then it was confirmed by Sladek et al. In a French population by genome-wide association studies. The landmark study, which is the Wellcome Trust study, which comprised 2,000 individuals with type 2 diabetes and 3,000 controls, they also found that TCF7L2 is the most robust type 2 diabetic signal, and the odds ratio of developing diabetes for carriers was 1.36. This finding was then replicated in almost every human population which was studied, and this remains the most robust type 2 diabetic gene identified till date. In general, the carriers have an odds ratio of 1.4 and homozygotes an odds ratio of 2.5 of having diabetes. So it encodes for a transcription factor, which is a member of the WNT signaling pathway and is known to be active in the beta cells. The risk allele is present in the intron 3. So what does it do? It decreases the insulin secretion from the beta cells, perhaps by altering the action of incretins. It decreases the insulin sensitivity also in the target tissues like adipose tissue. There is a recent study on the mouse in which the TCF7L2 knocked out mice in the liver cells they had hypoglycemia, and the overexpression led to hyperglycemia. And this effect was not seen when it was done on the beta cells. So that means liver is an important site where this gene, it influences the glucose metabolism. So like the glucose mediated insulin release. So if the TCF7L2 is there, it will cause hyperglycemia. If it is not there, it will cause hypoglycemia. This was like a recent study which was done by, I think, a Japanese group. Then TCF7L2 has finally it has got a role in cancer as well as in diabetes. So the discovery of this association of cancer and diabetes through this gene has opened a whole new avenue of research for the scientists and researchers all across. Other genes like HHEX, it was identified in both Caucasian and Asian populations. It was located on chromosome number 10, member of homeobux family, and it is also involved in the WNT signaling pathway. It has an odds ratio of developing 1.5 for type 2 diabetes. The other gene is SLC30A8. It encodes, so this also is important for the insulin secretion and present on islands of Langerhans. Interestingly, also seen in type 1 diabetes. Then the CDK, and this gene is on chromosome 9, and it is important for tumor suppression also. It has a role in insulin secretion. Then the IGF-2BP. So these are like various genes which are associated with diabetes and studied by the genome-wide association study. So these are the various genes, and the ones which I have highlighted, they are the significant ones. And if we see like the TCF7L2, the odds ratio is the highest, 1.37 out of all the genes which have been studied by the genome-wide association studies. So what do these genes do? They decrease the beta cell function, which is a final step in the path of diabetes. It causes insulin insensitivity. From 37,000 individuals where the indices of beta cell function, HOMA-B, and the insulin sensitivity, that is HOMA-IR, were derived. And the risk alleles at 10 loci, they showed significantly reduced beta cell function, and at 3 loci showed reduced insulin sensitivity. So basically, these genes, they do two things. One is they cause a beta cell dysfunction, and the other thing is they cause insulin insensitivity. They're also linked to dyslipidemia, atherosclerotic heart disease, and cancer. So there are various gene-environment interactions other than the direct effect on the insulin. And that is, the proof is like the epidemics of obesity and type 2 diabetes, they are almost like parallel to each other. So how can we predict the risk of diabetes based on this genetic information? So this is done basically by the cluster analysis. The clustering analysis can be done either by the clinical and the laboratory data, or also through the genetic data. So the 6 pre-selected variables which were used in the clustering analysis were the GAD antibodies, age at the diagnosis of type 2 diabetes, BMI, HbA1c, HOMA2 beta, and HOMA2 IR. So using this, like it was clustered in like 3 categories: the decrease in the beta cell function, and the genes responsible were HNF1A, SLC30A8, and KCNJ11. The mixed pathology, like the decrease in the beta cell function and insulin resistance, was seen in PAM and RREB1. And the insulin resistance was seen with the genes when the genes were like KLF14, FAM13A. So it also, like when the phenotypic studies were done, it was found that they cause increase in the coronary artery disease, increase in the diabetic kidney disease, and increase in hypertension. So this is how like the clustering was done using the various clinical and the genetic information. What are the caveats using clustering approach? Like first, the clinical data is not a static one. It is strongly influenced by the environment. A person who starts doing exercise and lifestyle modifications, the clinical data will change. And another issue is like which variables we should include in the model for cluster building. So to overcome that, the genetic model has got some advantages because it includes the variants which are from the genome-wide association studies, and already they have seen there is a significant association with type 2 diabetes, and it does not vary with time or environment. So therefore, it can be used at any point of time in life to understand the complex diseases like type 2 diabetes. So this is a pictorial representation of how the clusters look like. So the ones with decrease in insulin, like these are the genes HNF1A, KCNJ11. So if we know like these are the genes the pathology is decrease in the insulin secretion, and we have to treat accordingly. So if there is like mixed decrease in insulin and increase in insulin resistance, then PAM and RRB1 are the genes. Then at the insulin resistance, if it is more, then we know it is the other mechanisms like altered lipid metabolism, lipodystrophy like phenotype, or obesity adiposity. We will be discussing more detail of all these things. So soft hierarchical clustering approach, it was first proposed by Adler et al. To overcome the clinical heterogeneity in the pathogenesis of complex disease. So in this method, each genetic variant, it can belong to more than one cluster of clinical phenotypes. So therefore, it will overcome the pleiotropic effect of the genes. For example, like there are genes which are responsible for both obesity and insulin secretion, which can contribute to type 2 diabetes. So each gene can belong to more than one cluster of clinical phenotypes. The polygenic risk score, they help in predicting the risk for type 2 diabetes. So it was like, this is another tool for predicting the risk for diabetes. So first one was, this was established by Vidon et al. It is about the restricted polygenic risk score in which 3 variants of the candidate genes were used: KCNJ11, the PPAR gamma, and the TCF7L2. So there is a limitation with this kind of scoring system in the prognosis of the disease because it is using only 3 variants. So to overcome that, Khera et al., they recently constructed a global polygenic risk score in which they used all the variants across the genome. And in recent years, the partition polygenic risk score to identify the patients at high risk for diabetes through a specific intermediate phenotype pathways were used. So the various pathways, like the phenotypic pathways like obesity, lipodystrophy, and how they are progressing to type 2 diabetes, they were used for partition polygenic risk score. So global polygenic risk score is by using the bioinformatic machine learning tool and the genetic inheritance patterns by linkage disequilibrium in European ancestry populations, they created this GPRS. And it includes all the variants in the genome. And it was found that the participants in the top 5% of the GPRS distribution had 2.75 times increased chances of developing type 2 diabetes as compared to the rest of the 95 population. This is very close to the monogenic diabetes. So it is very specific and can be helpful in deciding the precision medicine. So this is how the various scoring system looks like. So if we see first the genome-wide association plots, so in this, like all the whole genome sequencing of across the population is done. So it includes all the genes. However, in the restricted polygenic risk score, only 3 genes are studied, and the scoring system is developed based on these 3 genes, whether the patient will develop type 2 diabetes or not. In global polygenic scoring system, all the variants across the genome is used in the global system, and the most advanced is the partition polygenic risk scoring system, in which the genes which are involved in the various intermediate pathways involved in the pathogenesis of the disease, they are studied. So like these are the genes which are involved in pathway 1, that is the beta cell dysfunction. The pathway 2, there will be a decreased, so this is like when in the insulin is decreased. So these are the genes which are involved in this pathway, and in pathway 3, the mixed decrease in the insulin, beta cell function, and insulin resistant genes are involved. In pathway 4, in this partition, there is the genes which are responsible for NAFLD and lipid metabolism are involved. In this pathway, the genes for lipodystrophy are involved, and in the final pathway, the obesity and adiposity genes are there. So in soft clustering method will allow the assignment of one gene to multiple phenotypes. So one gene can be present in multiple phenotypes, like we can see here. So with the help of this partition polygenic risk score, McCarthy proposed the pellet model. So in this, the focus is not on the end phenotype of type 2 diabetes, but rather on the various intermediate phenotypes like obesity, lipodystrophy, NAFLD, and insulin deficiency. So So each intermediate pathway is visualized by a primary color, and calculating then it is calculated, the partition polygenic risk score is calculated for each intermediate phenotype. Then these colors are combined and individual's risk of type 2 diabetes is calculated, and accordingly the targeted therapy can be given. So for example, in the first patient who is 50 years old male with a BMI of 45 with hypertension and hyperlipidemia, this is the partitioned polygenic risk. So the red color shows the obesity, the genes for obesity. The yellow is for the lipodystrophy, blue is for the insulin deficiency, and pink is for the NAFLD. So in this patient, in the partitioned genetic risk, there is like the red color is more, or the genes which are for the obesity are more. So the pellet will mix the colors, and it will be like predominantly for obesity and less for other phenotypes. So we know, like in this patient, probably the targeted therapy with GLP-1 receptor agonist and weight loss with the concurrent treatment of type 2 diabetes will be more helpful. So we can give a targeted or a precise therapy can be given to this patient. For this patient, who is 35 years old woman with BMI of 19 and a phenotype of primary lipodystrophy with the genes, the genotype of lipodystrophy genes. So we know how to treat the patient accordingly by treating the underlying lipid disorders. For 26-year-old male with a BMI of 25 and the predominant genotype is this blue color, which is primary insulin deficiency, which a trial of sulfonylureas will be the best option probably in this patient, as we do in monogenic diabetes. In 44-year-old female with the BMI of 32 and NAFLD with the pink color, means like there is the primary NAFLD or the lipid metabolism cluster. So the trial of GLP-1 receptor agonist and weight loss will be the good option for this patient. So the use of polygenic risk score in clinical use, it is quite limited right now. However, in research and clinical trials, it has been used successfully. So it's mostly like a research tool as of now. So in one study by Lee et al., the restricted polygenic risk score, it showed the patients with higher genetic risk score had a greater reduction in HbA1c in response to sulfonylureas. Jiang et al. Similarly showed that with each increase in standard deviation of the score, the risk of developing insulin dependence increased by 7%. Wagner et al., they showed by using the global, the GPRS, that increased pancreatic steatosis was associated with decreased insulin secretion. And using a partition polygenic risk score for lipodystrophy, they showed that despite having the lower BMI or the waist circumference, those with higher lipodystrophy score, they had significantly higher insulin resistance and LDL, LDL causing increased CVD risk. So there are some other genetic tools which are being used in research mostly. So one is the co-localization technique. In co-localization, the signal from the type 2 diabetes genome-wide association study and the expression quantitative trait loci in a diabetes relevant tissue such as pancreatic islets, they are studied and they find an evidence for potential causal link. So in co-localization, like this is the gene, the genome-wide association study, the genes are plotted and the QTL association is plotted, and then the co-localization analysis is done. If the genes are non-co-localizing, then they are expressed separately, like gene X and the disease gene, they are expressing separately, like two independent variants. But if they are co-localized, then the gene X and the disease-causing gene, they are expressing as a single variant. So there is some sort of causal association between the two genes. So this is basically for understanding the pathogenesis of the disease and understanding the various targets, which can be potential targets, which can be used for the treatment and therapies. Another tool is the Mendelian randomization, which is for the validation and identification of potential drug targets. It's a very strong technique. It's a very powerful technique in which because there is a random assortment of alleles during meiosis, and this helps in assessing the potential causality between the SNP and the outcome. So it is used to, it was already been used to demonstrate the causal link between hyperglycemia and CVD risk. The best example is the PCSK9 inhibitors. In 2005, Kohan et al., they identified there were two nonsense mutations in PCSK9, which resulted in drastically lowered LDL and this led to the development of PCSK9 inhibitors. So if the allele was absent, it led to a decrease in the LDL cholesterol. If the allele was present, it led to the increase in the LDL cholesterol. Another tool is the phenome-wide association studies. These are studies which help in identifying the drug repurposing, basically. So this is different from this is like opposite invert of the genome-wide association study, in which a single SNP is tested for association with multiple phenotypes. So the various off-target effects of the drugs can be studied. This is a very good tool for doing the drug repurposing and to identify the various adverse effects of the drug. The best example is tocilizumab, which is an interleukin-6 receptor antagonist used in giant cell arteritis, but it has a complication of aortic aneurysm. So this is like how we can explain about the phenome-wide association study. Let us, for example, this is gene X. And this gene X, when the phenome-wide association study is done and the graph is plotted using ICD-10 codes, so this drug is primarily used for rheumatoid arthritis. That is the original target of this drug. But by doing the phenome-wide association studies, it was found that that this gene X, it has an off-target effect on the cardiovascular disease and also on type 2 diabetes. It also has an adverse drug reaction, which is bacterial sepsis, which was associated with gene X. So when we know this, like this drug, which can be a potential has a potential target on other diseases. So then this drug, which is already there, being used in some other disease, can be tested and tried in other disease and can be used for drug repurposing. And we can identify the adverse drug reactions also using this technique. So the future directions for research is precision medicine. So it is helpful for risk stratifying the patients. It can be it can be used for asymptomatic patients or asymptomatic people who are at risk of developing type 2 diabetes. Their genetic risk can be scored, and interventions can be done with the help of intensive lifestyle modifications, medications, etc. To the onset of the disease, type 2 diabetes is done. It will mirror almost like that of monogenic diabetes, where specific therapies are tailored to the genotype. Just a little bit about metabolics and proteomics. It's a vast field, but like the major research is only about the branched amino acids and type 2 diabetes risk. The increased level of branched amino acids it's positively correlated with insulin resistance, and there is a 2 to 3.5 times increased risk of type 2 diabetes with higher branched amino acids level. So conclusions, the clustering method allows us for more precise subtyping of type 2 diabetes and increased understanding of the pathophysiology of a complex disease. The genetic methodologies, they offer a wealth of information for a specific patient from a single peripheral blood draw. The use of partitioned polygenic risk score has the potential to identify patients at high risk for specific intermediate phenotypes for type 2 diabetes, leading to the earlier implementation of interventions, and further work is needed to elucidate and demonstrate the clinical utility of germline genotyping and the partition polygenic risk score in type 2 diabetes. So disentangling the type 2 diabetes pathogenic mechanisms. So currently we are treating type 2 diabetes as a homogeneous entity, despite there are various pathological mechanisms like obesity, beta cell failure, lipodystrophy, non-alcoholic fatty liver disease. So we are treating the end phenotype, the final phenotype. However, using the partition polygenic risk score, it can identify the proportion of the genetic risk due to each intermediate pathway, like obesity, beta cell failure, lipodystrophy, and NFLD. And then in future, what can be done to implement it clinically? First is like we need to do more randomization and the real world trials, and then a differential approach to treatment based on the PPRS pathway mechanism. So basically, the aim is to prescribe the most precise medicine to the patient. Yeah, thank you for your patient listening.
Thank you so much, ma'am. It is indeed a very intriguing and something new for our audience here also. I think again we'll take the questions in the end, and with your permission, I'll move on to our next speaker, Dr. Rajaram Karne sir.
Thank you.
Thank you, ma'am. Dr. Rajaram Karne, he is DM Endocrinology from KEM Hospital, Mumbai. He has done his internal medicine residency at the Bronx Lebanon Hospital in New York. He's done his fellowship at NIH, Bethesda, Maryland, and is currently the staff endocrinologist at the Veteran Affairs, Columbus, Ohio, and the American Board Certified in Medicine, Endocrinology, and Obesity. He's done a lot of research work focused on diabetes, insulin resistance, and obesity. So with that, over to the RX team to take up Sir's lecture.
Hi, good evening, everybody. Thank you so much, Dr. Bansi Sabu, for giving me the opportunity to speak for this Diabetes Care Conference. Today, we are going to talk about physical inactivity. Now, as a diabetes practitioner, we all know that physical exercise is one of the most important treatment modalities of diabetes treatment. But equally true is that just by not doing the physical activity, it can be extremely harmful to our body. That's why this is the plan to talk about sedentary lifestyle and how it causes, progresses, and blocks the treatment for diabetes. There is something called as disuse syndrome, which means sedentary lifestyle causing the medical problems. It's a serious worldwide problem, and it has progressively increased over past many decades. Humans are basically not programmed for physically being inactive. For hundreds of thousands of years, the humanity has been extremely physically active, which has recently changed and not surprisingly coincided with the explosion of obesity and diabetes. In fact, there is a term called as sedentary death syndrome because of the premature deaths that would not have happened if the people were active. In the United States, about 2/3 of the major causes of death are related to the lifestyle. And the author of this article actually prefers to label the cause of death as physical inactivity and poor nutrition. About 15% of newly diagnosed chronic diseases you can directly attribute to the sedentary lifestyle. This is a list of all the complicated things that happen because of physical inactivity. We are going to talk mainly about the obesity and diabetes. So obesity first, because it's a precursor of most of the type 2 diabetes, and it's a direct consequence of physical inactivity. Now, diet also plays a major role on it, but that role is superimposed on the level of your physical exercise. So how it is compounded by the excess diet? So people eating less, medium, and more can have a variable outcome for obesity based on how much are they exercising. So graphically, if you put it, there is a caloric intake from 1200 to 2800. And if the person is physically very, very active, then as they eat more, they gain weight, but the slope of that weight gain is not so pronounced. If you are working out less, you gain more weight for the same amount of eating. And if you work less, the progression goes up. But if you go low beyond a certain point, that is almost sedentary level, the weight gain is very disproportionate. And even if these people are in the range of 1800 calories, you will find profound weight gain just by physical inactivity. So I dare to say that obesity is a direct consequence of physical inactivity. Now, there are multiple scenarios in which one is person is absolutely inactive. If they eat just enough, like not too much, not too little, then there is still progressive slow weight gain. And we all know that from the age of 18 to 40, we invariably weight gain because even if we do not overeat. Now, this thing gets worse if you restrict the diet and no exercise, like typically the malnourished individual, you do get stable weight or the weight loss, but there is a significant muscle loss associated with it. Now, if you do the prescribed exercise and use the mindful diet, and I will talk about how much prescribed at the end, then you get the stable mass weight with the stable mass preserved. However, these are the relatively rare scenarios. When you are doing intense exercise like an athlete, they can eat a lot and they can still have a stable weight. But if you eat extremely high amount of diet, even with the intense exercise, which is a very rare case, such as a sumo wrestler, where they eat 10,000 calories and they gain weight in spite of exercise. So that's how you cannot talk in one dimension. You have to have a correlation of it, but for a given amount of diet, the exercise matters how much you will gain weight. And this is how it works physiologically. So if I eat the meal, there is a lot of calories coming in a very short period of time, and immediately they are saved in the liver as a glycogen, about 75 grams, and then a big bunch is stored in the muscle. Now, this is reversible. It is utilized in between the meals to do our daily activities. And by the time I eat my next meal, if I use most of the stored energy, then there is not much energy left to gain the weight or increase the body fat. This part is accentuated by exercise, where you can make sure complete utilization of what you ate. Now, if you eat more, and more means in relation to exercise, then by the end of this utilization, you still are left with some more energy, which is stored in excess by the time you are ready for next meal. And when you take the next meal, those two are added and you have extra energy by the time you eat next. And the stacking keeps on going on. So that stacking eventually leads to the fat storage. Now, if you either delay the meal, which is basis of the intermittent fasting, or if you exercise, then this fat deposition can be significantly reduced. Now, if you are lean, then you can gain weight by lack of physical activity because the food is not being utilized. On top of it, if you eat a lot more, then you can gain weight much faster. When you try to do the opposite, when you are obese to begin with and try to lose weight, we know that it can be done quickly by calorie reduction. But we also know that it is a J-shaped curve where the initial weight loss invariably is associated with a progressive weight gain unless it is added with physical activity. So studies after studies have shown that the only way to stabilize the initial weight loss is by physical activity. Moving on to type 2 diabetes, we all know that insulin resistance is at the basis of type 2 diabetes. A smaller component comes from the hereditary, but the bigger component comes from the lack of exercise and abdominal obesity, which is consequence of lack of exercise and overeating. We all know this slide, so I'm going to skip because everybody knows the natural history. But how physical activity affects insulin resistance? There are two ways. One is the immediate effect, and that is happening by activation of glucose transporters. This lasts for about 24 to 48 hours. And we all know as a practitioner that a patient on the insulin and sulfonylurea, when they exercise, there is immediate hypoglycemia within a few hours, which is mediated by the improving insulin sensitivity. And the long-term effect, when you have a habitual exercise, chronic exercise, that improves the muscle fat ratio, which improves the insulin resistance, and also mitochondrial hypertrophy, which improves the energy utilization. It's very important that interval period between the two meals, if we utilize all the energy, then the liver is not studded with fat. But if you have a chronic excess of the diet, in relation to no spending or no draining of the fat, we eventually get the NASH, which is hepatocellular fat, and also the intramyocellular fat. Both of these ectopic fat deposition are associated with intense insulin resistance. One of the dreaded side effects of physical inactivity is sarcopenia. The loss of muscle mass always accompanies aging. Multiple reasons. One is stem cell depletion, decrease in anabolic hormones, but also the diminished physical activity with age. The muscle strength decreases approximately 50% from age 30 to 80 years. Exercise not only reverses this age-associated decline, but it also gains the muscle strength. In one study, after 12 weeks of exercise training, about 40% of the loss and strength loss and 75% of the mass was restored. Now, how old is old for not to exercise? The answer is no. Even at the age of 90 years of age, the progressive resistance training shows similar or even greater gains compared with the young individuals. And then there are multiple studies on that. The 12 weeks in the older men, exercise strength in extensor doubled, flexor tripled, and the total muscle mass increased. Even in the frail individuals, if you do the 8 weeks of high intensity training, the strength increases, and that has a positive effect on diabetes. Everybody knows diabetes prevention trials, so I'm not going into the details, but basically the lifestyle intervention was as good as metformin. It was not bettered by metformin also. So no question about physical activity as a part of diabetes. So how much activity is good? The guidelines coming from the College of Sports Medicine and Heart Association, which tell us that moderate intensity of aerobic activity, which requires walking, speed walking or little jogging, and aerobic activity about minimum 30 minutes for 5 days a week. It can also be said 1 hour for 3 days a week, which basically means 300 minutes of moderate intense activity spread over the week. Or if you have a vigorous intense activity, which is sprinting or tennis or badminton or fast biking, that involves even minimum 20 minutes, 3 days a week. So it's not a lot. It's really not a lot, but not doing that small part itself can be detrimental. The recommendation for the minutes is similar to the older adults, but the intensity you can modify depending on the baseline strength. And compared with the inactive group, those who exercise even 15 minutes per day had 14% reduced risk of all-cause mortality and 3-year life expectancy. So it is very, very powerful. So each additional 15 minutes further reduced all-cause mortality by 4% and cancer mortality by 1%. So basically my thoughts or the take-home points here are lack of physical activity is the most powerful root cause of morbidity and mortality. The physical activity is one of the most essential component of healthy life. So we should not consider it as a option or a good thing to do, but it is an essential, absolutely important thing to do. No health or the weight loss program can be serious if it does not include structured and monitored physical activity. Again, I'm saying that diet is equally important, but diet alone always fails. It has to be combined with physical activity. So if you get a program of any kind of diet or South Beach diet or Atkins diet or any other diet, if it is not included equal or serious importance to the physical activity, then I don't think the program is very serious. It's not a course. It's not a 90 days lose 30 pounds. It is a lifestyle. It is something that you need to do every day or routinely. So for our doctors, if the work hours do not give us any inbuilt time for exercise, because there are many other workplaces like bus conductor, for example, they are always on the feet and walking. We physicians or computer technologists or many researchers, they are having a sedentary work, which means does not give exercise at work. They have to find time for the physical activity after the work hours to be healthy. And the most important part, if you do not find time for exercise today, you will have to find a lot more time for doctor's visit tomorrow. Thank you so much for your time. Hi.
Thank you, Dr. Karne. Even if it was a recorded lecture, we all did enjoy it. I think we will move on to the last session and the last talk of this session. Dr. Mandeep Bajaj, sir. Can I have a CV on the display, please? Dr. Mandeep Bajaj, sir, is a Vice Chair of the Department of Medicine and a Professor in the Department of Medicine and Molecular and Cellular Biology at the Baylor College of Medicine. He's the Chief of the Section of Endocrinology and Diabetes at Baylor St. Luke's Medical Center and Medical Director of the Baylor St. Luke's Medical Center. Sir has a lot of accolades in his name. He's a medical graduate from the AIMS and has received his fellowship training in diabetes and endocrinology at the Joslin Diabetes Center and Harvard Medical School. He's a reputed clinical and translational researcher in obesity and type 2 diabetes, and his patient-oriented research work has delineated the metabolic and molecular mechanisms of insulin resistance and the pathogenesis of type 2 diabetes. He has published more than 150 research papers, abstracts, and book chapters. He has also provided leadership in developing diabetes care and providing physician education at a national and international level, and is a member of the ADA National Board of Directors. He is currently the editor-in-chief of the BMJ Diabetes Research and Care. Over to Dr. Bajaj, sir.
Thank you. So what I'm going to do today is speak on SGLT2 inhibitors, type 2 diabetes, and heart failure. So let me start this. Can you all see my screen?
Yes, sir.
Okay, all right. So when you look at type 2 diabetes, the hyperglycemia is a combination of several pathophysiological abnormalities. Now, these include impaired insulin secretion from the beta cells, a decreased incretin effect, increased lipolysis from the adipocytes, increased glucose reabsorption, decreased glucose uptake in the muscle or insulin resistance in the muscle, increased hepatic glucose production from the liver or hepatic insulin resistance, and finally, neurotransmitter dysfunction that may contribute to increased appetite and other factors contributing to hyperglycemia. So this slide, as Dr. Ralph DeFronzo has summed this up, shows you the mechanisms really by which you see hyperglycemia, as well as see the effect of various drugs used for type 2 diabetes in terms of their site of action. But what's also important here is inflammation. Inflammation, both vascular, systemic, as well as inflammation in the liver and skeletal muscle, adipocyte, all contributes to this pathophysiological abnormality and therefore plays a very important role in type 2 diabetes in the pathogenesis of hyperglycemia. And finally, there is vascular insulin resistance that contributes to endothelial dysfunction and cardiovascular risk in type 2 diabetes. So the SGLT2 inhibitors really work to affect the reabsorption of glucose, sodium glucose exchange in the kidney, in the tubule, and thereby reduce the glucotoxicity by increasing renal glycosuria. The hyperglycemia gets better, and the glucotoxicity, then the reversal of glucotoxicity improves in insulin secretion, as well as insulin sensitivity in the skeletal muscle and the liver. And that mechanism was shown many years ago in early studies done by Dr. DeFronzo and Dr. Rossetti from San Antonio. So the American Diabetes Association Standards of Care 2022 now says first-line therapy depends on comorbidities, patient-centered treatment factors, including cost and access, and management needs, and generally includes metformin and a comprehensive lifestyle modification, but recommended independently of your baseline A1C, A1C target, or metformin use is the use of SGLT2 inhibitors in heart failure, as well as in atherosclerotic cardiovascular disease, indicators of high risk where GLP-1s with proven cardiovascular benefit are recommended, or SGLT2 with proven cardiovascular benefit. And finally, it's chronic kidney disease, CKD and albuminuria more than 200 milligrams per gram creatinine, or CKD without albuminuria but eGFR less than 60. Again, SGLT2 inhibitors with primary evidence of reducing CKD progression are recommended, or GLP-1 receptor agonists with proven cardiovascular benefit if SGLT2s are not tolerated or contraindicated. So clearly, heart failure is a major indication in patients with type 2 diabetes to use a SGLT2 inhibitor. Now, when we look at this recommendation and compare it with metformin, the efficacy of SGLT2 inhibitors is intermediate in terms of glucose lowering compared to metformin. They do not cause hypoglycemia. There's some weight loss associated with it as you lose glucose in the urine. Cardiovascular effects, again, these two, empagliflozin and canagliflozin, have been found to reduce the MACE in their studies, and I'll show you that. And when we look at heart failure, all the four that are currently approved for use in the United States, EMPA, CANA, DAPA, and ertugliflozin, are clearly beneficial in heart failure. Cost is high in the US for the use of SGLT2 inhibitors compared to metformin, which is generic. And when we look at well, they're both oral, but renal effects, clearly CANA, EMPA, and DAPA have been shown to be of benefit in patients with chronic kidney disease or albuminuria. And again, dosing considerations, contraindicated eGFR less than 30 is metformin. And with the SGLT2 inhibitors, again, each individual drug label may tell you what to use on what dose. But the bottom line is we are using SGLT2 inhibitors till a eGFR of close to 25 in patients with type 2 diabetes and either chronic kidney disease or microalbuminuria. And then the side effects have to be kept in mind. They should be discontinued before any scheduled surgery, about 72 hours before, because of the potential risk of DKA. We do see patients who go in for surgery where the drug was not discontinued and they went into euglycemic DKA post-operatively. Again, euglycemic DKA is a problem seen with these agents. Again, more in type 1, but we do see it in type 2 also. And this has to be kept in mind, and patients explain the risk of euglycemic DKA, the symptoms, and the help that they should seek, as well as monitoring of urinary ketones. The risk of bone fracture, again, is increased with CANA, really hasn't been seen with others. And of course, genitourinary infections are an adverse event that has been noted with these drugs, both vaginal yeast infection, balanitis, and urinary tract infections. And finally, risk of volume depletion, hypotension, especially when used with diuretics. One has to be careful. and some increase in LDL cholesterol and risk of Fournier's gangrene, which is a recent addition to the FDA warning label. So these side effects or adverse events must be kept in mind when you're prescribing these drugs. So why does the American Diabetes Association recommend SGLT2 inhibitors in patients with chronic kidney disease or cardiovascular disease? And the initial trials, EMPA-REG, CANVAS, and DECLARE-TIMI, CANVAS and EMPA-REG were the first two with the results that came out. And these were all patients with established vascular complications or risk factors in CANVAS and EMPA-REG. Whereas in DECLARE-TIMI, these were all patients with high risk for cardiovascular events. The primary endpoint was MACE, which is cardiovascular death, non-fatal MI, non-fatal stroke, and the results of all three trials are available. And that's summarized here. So SGLT2 inhibitors reduce cardiovascular risk. MACE came down 14% and was significant. In EMPA-REG, so was it significant with identical reduction in CANVAS. With DAPA, MACE did not change significantly. Cardiovascular death reduced with EMPA almost 38%, with CANVAS 13%. And with the DECLARE-TIMI DAPA study, you saw a reduction in a composite of cardiovascular death and hospitalization for heart failure, which was really driven by hospitalization for heart failure, a reduction in that. Clearly, heart failure hospitalization across all three studies came down significantly, as you can see here. So in terms of heart failure, these drugs have a clear benefit in patients with heart failure in terms of reducing hospitalization for heart failure. Now, let's look at CANVAS and EMPA-REG separately. And what you see here in red is EMPA-REG and blue is CANVAS. MACE came down identical in both studies, but with important differences. Cardiovascular death was much more reduced, as you saw with EMPA compared to CANA, and non-fatal MI was reduced somewhat in both groups, but stroke tended to increase in EMPA-REG, and in CANVAS came down a small degree here. So in bottom line, the MACE came down with both, but this was largely driven by cardiovascular death and some effect of reducing non-fatal MI. But in CANVAS, it was almost equally cardiovascular death, non-fatal MI, non-fatal stroke. Hospitalization for heart failure came down significantly with both EMPA and CANA. Cardiovascular death or hospitalization for heart failure, when combined together, you can see here a much more effect with EMPA than CANA. All-cause mortality came down with EMPA, and progression to macroalbuminuria was significantly reduced with both, and so was the renal composite, which favored SGLT2 inhibitors in both cases. And that's the results from EMPA-REG. EMPA slowed the decline in eGFR in these patients. As you can see here, this is 10 milligram EMPA, this is 25, and this is placebo. So both 10 and 25 slowed the decline in eGFR over 192 weeks, whereas with placebo, there was a steady decline in eGFR from almost 876 down into the 70 or 68 range. Now, when we look at DAPA in the clinical trial, you can declare TIMI, you can see here 17,000 odd patients with type 2 diabetes. Established cardiovascular disease, 6,974. But multiple risk factors was the predominant group, 10,186 without established cardiovascular disease. And DAPA 10 milligram versus placebo, and again, with follow-up visits, primary endpoint MACE, cardiovascular death, MI, stroke, and again, the second endpoint was cardiovascular death or hospitalization for heart failure. And when you look at the results, cardiovascular death, hospitalization for heart failure came down significantly. With MACE, it was non-inferior but not superior to placebo. And most of this was driven by a reduction in hospitalization for heart failure, MI, small reduction, ischemic stroke, no reduction, cardiovascular death, no change, and non-cardiovascular death, a little bit of reduction here. And secondly, you saw the renal composite, which was a 40% decrease in EGFR to less than 60, end-stage renal disease or renal or cardiovascular death, again came down 24%, as you can see here very clearly. So important benefits, again, on renal outcomes and hospitalization for heart failure. And these are results from patients in the DAPA-CKD study, 4,304 participants, EGFR 25 to 75, with a urine albumin to creatinine excretion of 200 to 5,000, DAPA 10 or placebo, primary outcome, composite of sustained decline in EGFR of at least 50%, end-stage kidney disease or death from renal or cardiovascular causes. And the secondary outcomes were composite kidney outcomes of a sustained decline in EGFR of at least 50%, end-stage kidney disease or death from renal causes, and a composite cardiovascular outcome defined as hospitalization for heart failure or death from cardiovascular causes and death from any cause. So these were patients with chronic kidney disease, but did not necessarily have to have diabetes. So this included patients without a diagnosis of diabetes. And when you see in the DAPA-CKD study, the primary outcome was reduced significantly, as shown in this slide, by almost 39%. And then the renal specific composite outcome was again reduced significantly. Composite of death from cardiovascular causes or hospitalization for heart failure came down significantly, as shown here, and death from any cause came down significantly in the DAPA-CKD study. So patients with chronic kidney disease, EGFR 25 to 75, as well as urine albumin to creatinine ratio of 200 or more, clearly the drug was reducing the hospitalization for heart failure, as well as having a protective effect in terms of renal outcomes. The VERTIS cardiovascular study looked at EMPA, ER2, and placebo, ER2 5, ER2 15, and placebo. And the primary endpoint, again, was MACE. MACE has always been the primary endpoint in these studies, and secondary outcomes, cardiovascular death, composite of cardiovascular death, heart failure, and renal composite, which is renal death, dialysis transplant, or doubling of serum creatinine. And when you see here, these were all patients more than 40 years of age, type 2 diabetes, again, established atherosclerotic cardiovascular disease involving the coronary, cerebrovascular, and or peripheral arterial systems, and obviously type 1 diabetics or patients with a history of ketoacidosis were excluded from these studies. So when you look at VERTIS CV, MACE again did not change with ertugliflozin versus placebo. And cardiovascular death, as you can see here, really did not change significantly, but hospitalization for heart failure came down significantly. And the composite of cardiovascular death, hospitalization for heart failure was small decrease. But the major effect was, again, on hospitalization for heart failure. The renal composite came down, just didn't reach significance, as you can see in this data here. The p-value was 0.08. And finally, with CANA and renal events in diabetes and established diabetic nephropathy, CANA was really studied here in 3,700 type 2 diabetics with diabetic nephropathy, EGFR 30 to 90, and macroalbuminuria, receiving standard of care plus ACE or ARBs. So they had already been optimized on ACE or ARBs. And the primary endpoint, time from first occurrence of event in primary composite endpoint, end-stage kidney disease, doubling of serum creatinine, renal or cardiovascular death. And the secondary was the first occurrence of an event in the cardiovascular composite endpoint, that is cardiovascular death, non-fatal MI, non-fatal stroke, hospitalization for heart failure or unstable angina. And when you see here in this slide, you can see very clearly the primary composite, which is really renal or cardiovascular death, end-stage kidney disease. You can see here that that came down very significantly. Cardiovascular death came down just about near significance, 22% reduction right here. So notice previously we were not seeing a reduction in cardiovascular death other than with EMPA, but in this study we can see clearly that those with chronic kidney disease, you saw a reduction in cardiovascular death. And then end-stage kidney disease, doubling of serum creatinine or renal death came down very significantly, as well as the risk of dialysis, kidney transplant, or renal death. So the bottom line here is, in patients with chronic kidney disease, you have important benefits on the progression of chronic kidney disease. And in the CREDENCE study, you saw a reduction in cardiovascular death that was of borderline significance. So in the CANA CREDENCE study, this is the urine albumin to creatinine ratio, as you can see here, and that is reduced with CANA, as would be expected, and the change in EGFR is shown here. This is CANA, this is placebo, so the decline in EGFR was reduced with CANA versus placebo. So summarizing as a meta-analysis data from these studies, subgroup analysis by atherosclerotic cardiovascular disease, as is shown here. This was a combined meta-analysis presented at the ADA. So if you have atherosclerotic cardiovascular disease versus no atherosclerotic cardiovascular disease, the presence of atherosclerotic cardiovascular disease leads to, in a meta-analysis, some reduction in MACE, about a 10% reduction, whereas no atherosclerotic cardiovascular disease, you only saw a reduction in the CREDENCE study in MACE. So really not much of a benefit on MACE, the only exception being patients with chronic kidney disease. They're high risk for cardiovascular disease, and MACE did come down in CREDENCE. But otherwise, the effect on MACE is really, other than EMPA-REG and CANVAS, the other studies did not show a benefit in MACE. Now, time to cardiovascular death, again, in EMPA-REG came down, CANVAS, some reduction, the rest really not much of an effect, except in credence again, patients with diabetes, type 2, and chronic kidney disease, a reduction in cardiovascular death, because patients with chronic kidney disease and type 2 diabetes are high risk for cardiovascular disease and cardiovascular death. And in that focused subgroup, you see a benefit in reducing cardiovascular death. But heart failure across the board, whether the patients had established atherosclerotic cardiovascular disease or no atherosclerotic cardiovascular disease across the board, came down very clearly by 30 to 40% with all these studies. And so the major effect is really on heart failure and renal complication. And that's what the meta-analysis supports. Prioritize the use of SGLT2 inhibitors independent of glucose control considerations. It doesn't matter what the baseline A1C is. It didn't matter what the target A1C is. In patients with type 2 diabetes, with or at high risk for cardiovascular and renal complications, because the effects on hospitalization for heart failure were most consistent across the trials, and greatest magnitude of benefit is the reduction in risk for hospitalization for heart failure and kidney disease progression. And this is a nice summary of all these trials, which was published in BMJ Diabetes, the review published from here at Baylor by Dr. Virani and Dr. Navneethan. Really a nice table showing you the outcomes, the primary endpoint, the kidney outcomes, and the results, all in one nice table summarized here. Canvas, Credence, EMPA-REG, Declared TIMI, DAPA, CKD study, all these I've talked about, and then Vertis Cardiovascular. The only study I didn't talk about is SCORED, because sotagliflozin is still not FDA approved for treatment in diabetes. And again, here you saw a reduction in hospitalization for heart failure and in the study, as well as renal protection. And finally, SGLT2 inhibitors for heart failure, irrespective of the ejection fraction or a diagnosis of diabetes. Both DAPA in patients with heart failure and reduced ejection fraction, and EMPA in the EMPEROR reduced trial, looking at cardiovascular and renal outcomes, with EMPA in heart failure, irrespective of the diagnosis of diabetes, so DAPA heart failure and EMPEROR reduced showed a benefit. And that's shown in this table here. What you can see here is cardiovascular death, hospitalization for heart failure, DAPA heart failure, EMPEROR reduced, 25% reduction. First heart failure hospitalization, 30% reduction. Renal composite endpoint, 30% or 29 here and 50%. And some reduction in cardiovascular death. But again, the major reduction is in hospitalization, first hospitalization for heart failure and the renal composite. And these were patients with a reduced ejection fraction of less than 40%, class 3, 2, class 3, class 4 heart failure with or without diabetes, which is why these drugs are now being used by cardiologists in non-diabetic patients with heart failure, and of course in patients with diabetes, as the ADA recommends. And then in patients with preserved ejection fraction, the EMPEROR preserved showed the primary endpoint, cardiovascular death, hospitalization for heart failure. And again, it reduced the combined risk of cardiovascular death or hospitalization for heart failure in patients with even preserved EF, regardless of the presence or absence of diabetes. And the same study delivered trial with patients with preserved or mildly reduced EF. With DAPA, the formal results are still awaited, but it did show again a reduction in hospitalization for heart failure. And finally, preserved heart failure. DAPA improved symptoms, physical limitations in patients with heart failure with preserved EF, as this study published last year or so showed in Nature Medicine. So coming down to the bottom, we see a clear benefit in heart failure. Not much of a benefit on MACE other than with EMPA and CANA. So what is the mechanism by which these drugs have a myocardial benefit in terms of myocardial ejection fraction or myocardial energetics? And I'm sure you all heard by now the preceding lecture by Dr. Sundar Mudaliar in another room, where he talks about his hypothesis. And the bottom line is patients with type 2 diabetes have increased fat oxidation, decreased glucose oxidation, decreased P2O ratio, which is basically energy efficiency. P2A ratio reflects the number of molecules of ATP produced per atom of oxygen reduced by the mitochondrial electron transport system, and decreased cardiac work efficiency, which is why patients with type 2 diabetes have much more heart failure and decreased myocardial contractility. And there's an increased incidence and progression of heart failure. So a type 2 diabetic heart has these problems. When you treat with SGLT2, you reduce the fat oxidation, increase glucose oxidation, but you increase the formation of ketones, beta-hydroxybutyrate, and that is used by the heart for energy, increased P2A-O ratio, or you have more ATP production and increased cardiac work efficacy, improved myocardial contractility, and a reduced progression of heart failure. Again, this is really a hypothesis. We still don't have a proven infusion of ketones in type 2 diabetics clinical trial showing us a clear benefit in ejection fraction. And the studies are being done. And so can a shift in fuel energetics explain the beneficial cardiorenal outcomes in the EMPA-REG study, a unifying hypothesis? And again, this is, as I said, Dr. Mudaliar, Dr. Eli Peranini proposed this and postulated that cardiorenal benefits of EMPA are due to shift in myocardial and renal fuel metabolism away from fat and glucose, which are energy inefficient in type 2 diabetic heart and kidney, towards energy efficient superfuel ketone body, which improves myocardial renal work efficiency and function. So again, still a hypothesis. But we went back to the lab and we said, well, let's look at other mechanisms. And in a model, in a mouse model of diabetic cardiomyopathy, what we found was, and again, these are animal studies, that SGLT2 inhibition with DAPA reduced the activation of the inflammasome. So myocardial inflammation comes down, and there is some reduction in myocardial triglyceride, and clearly the left ventricular ejection fraction in these BTPR mice diabetic cardiomyopathy model is improved. So DAPA attenuated the activation of the inflammasome fibrosis, myocardial fibrosis, and deterioration in LVEF. Adding a DPP-4 inhibitor to DAPA did not result in a greater effect on these on myocardial fibrosis. And these anti-inflammatory, anti-fibrotic effects, as we showed in vitro, are direct of DAPA, independent of SGLT2, SGLT1, and glucose lowering, because there's no SGLT2 in the heart. And were replicated when we had an in vitro model of cultured cardiofibroblasts. We found that DAPA basically augmented AMPK phosphorylation in cardiofibroblasts. So what is AMPK? A key molecule responsible for fat oxidation in the heart, in the liver, other organs, and AMPK phosphorylation was significantly augmented by DAPA directly. And that the effect of DAPA on LPS-induced inflammasome activation was blocked by using compound C, or AMPK inhibitor, and these results could be replicated by an AMPK activator. So we conclude that there's a reduction in inflammation, a reduction in fibrosis in the heart, and that these effects are direct of DAPA and are AMPK dependent, and you actually increase fat oxidation, probably reduce myocardial triglyceride, and have better cardiac efficiency. Well, we all know that metformin has an effect on AMPK activation. So do we see the same with metformin? In general, metformin is contraindicated in patients with heart failure. Why? Because you increase in patients with heart failure, there's tissue hypoxia, increased risk of lactic acidosis. But several studies have looked at metformin in patients with mild to moderate heart failure. And what you can see here is these studies have shown some benefit with metformin in patients with heart failure, including one from here at Baylor by Dr. David Aguilar, which showed a significant improvement in terms of reduced mortality in heart failure patients. So mortality did come down in this meta-analysis of heart failure patients, and this was published in the Annals some time ago. And secondly, the same AMPK activation is taking place in the liver with SGLT2 inhibitors. And this is a study that was published in a small number of patients where they did biopsies and treated NASH in patients with type 2 diabetes with empagliflozin. You see the nice fatty vacuoles right here, some inflammation and fibrosis. And after treatment, you see a marked reduction in the steatosis, as you can see here, and some reduction in inflammation and fibrosis. So just as you're reducing triglycerides in the myocardium, you're reducing triglyceride in the liver by the same mechanism and reducing inflammation, and larger studies with biopsies obviously need to be done in patients with NASH to really start using them. I know there's some studies were done in India, but I think we need a large clinical trial to really look at this. But at the same time, you need to look at myocardial triglycerides also in treating heart failure patients with SGLT2 inhibitors to see if there's a reduction in myocardial triglyceride, because fatty heart and fatty liver, although independent, may be major problems in patients with type 2 diabetes. So the last unanswered question remains, why no effect on MACE, or a small effect on MACE, but such a large effect on heart failure? So do these drugs have anti-atherosclerotic effects? We saw effect on MACE with EMPA-REG and CANA. Again, the effect with EMPA was largely driven by reduction in cardiovascular death. Stroke actually did not benefit much in any of the clinical trials other than in the Canvas study. So what's going on here? Is there an effect on atherosclerosis? And that's an under-recognized or unanswered question regarding SGLT2 inhibitors and anti-atherosclerotic effects. There's a clear effect on the myocardium in terms of heart failure, but the anti-atherosclerotic effects are unclear. Studies in animals do show improvement in endothelial dysfunction, but that's still an open question, which is why the ADA says in terms of atherosclerotic cardiovascular disease, they basically propose using CANA or EMPA, but none of the others, and really focusing on either using GLP-1 receptor agonists, which have a clear benefit in terms of MACE versus SGLT2 inhibitors, where this effect is still potentially an unanswered question. So I'll be happy to answer any questions. Thank you.
Thank you, sir, for a wonderful presentation.
Any questions that the audience may want to ask me?
No, sir. Just now, we cannot see any more questions in the chat box.
All right, I guess it's 9 o'clock in India, 9:15. So everyone's hungry and tired. Okay, still early in the morning here, or well, midday here. So we're still energetic. All right.
Yeah.
Okay, so thank you all very much for inviting me again. Thanks to Dr. Bansi and all the organizers for inviting me. Thank you so much.
Okay, with this, I would like to take the permission from the speakers, all the speakers, to end the session. May I?
Yeah, thank you.
Thank you, thank you. It was a wonderful session. Hearing from the still world, giving a nice presentations. So, hoping to see you in the next program of DICON. So, good night from India.
Yeah, thank you. And hello, Doctor. Yeah, thank you so much.
Thank you. Thank you.